slide advancer that we could give Dr. Pencil? There was a little clicker yesterday. Do we have that today? Here it comes. Thank you very much.
Okay, so I will also want to use this opportunity. Okay, so I will also want to use this opportunity to thank the organizers for inviting me to give this talk, to talk about my experiences, and also thank AMCC and World Child Cancer for sponsoring my trip here. So when we talk about projects or research, do we think I have nothing to disclose? When we talk about projects, do we think it's a luxury or it's a need? If we look at the Harvard Catalyst Clinical Research Center, they've brought about a lot of data about research that is done. And looking at the clinical research in cancer for the past 5 years, it was seen that lots of our research came from the basic sciences. We see lots of papers out from the basic sciences. And then also some clinical trials. And out of it, we have a few which were approved and then patents also granted. And then from these, our main goal in all these clinical research is that we want to improve on our public health goal, to improve on the outcome of our patients. And that is basically what we want to improve on. And if we want to do that, then we can say that research is really a need if we want to advance our patient management. So why do we need a multinational research? We need it because we want to improve on the global health issues. Apart from improving on the global health issues, we need to meet patient recruitment goals, because if you have a research, you need about 1,000 patients and you are not able to meet those goals, then that means you can't effectively make any meaning out of the data that you have. And then it also helps so that you can recruit patients from multiple sites in different countries. Most of the time, what happens is that if you have multinational research, you are able to complete your research quickly, you are able to complete it efficiently, and then you are able to advance science rapidly. And then also you are able to conserve some of the research-specific capacities or resources that you have. And in advancing our science rapidly, we have seen that if we are able to advance research, what it means is that it will reduce the burden of disease that we have, and then it will promote health, and then also it will extend longevity for all people. So looking at some of the research that we have, we've seen that with research, we've been able to come out with treatment modalities that are good, that have improved on our outcome. And also with that, you are able to prolong the patient's life also. And when we are talking about research, we want to make research results generalizable. But if you have research just in just one portion of a country, you can't generalize it throughout the whole world. So if you have a multinational research, then with that, you can generalize your results, because you have patients from different parts of the world, different ethnicities, and so you can generalize that. And if drugs are available, you can also help you to know whether the drugs are good for different parts of the world. And one important thing about multinational research is that it helps to build capacity in the countries that the research is made in. So let's take Ghana for instance. If we are doing a research and then we train people in research methodology, people in the use of some equipment. With that, you see that expertise is built up in those countries. So with multinational research, that is one major thing that we can also get. And it also improves patient care, such that patients have access to new drugs, patients have access to expertise, patients have access to diagnostics, and also to treatment and different protocols. And that helps because it improves on the care for our patients. And so anytime that you have a research, we always say that patients who are in the research always get very good care because things are standardized such that when you know that you are in a research, you get comprehensive care. So what is the governance system for a multinational research? It can be very complex, but I've tried to simplify it so that there are basically three major components in the governance system. You have the ones who have the oversight activities to make sure that everything runs well and things are being done well. You have at the coordination level, those who help so that they can coordinate the different sites and make sure that things are run properly. And then we have the sites where the real work, the real research is being done. And so if there is any problem in any of these, then there can be issues, and then the research won't be appropriately done. So for the oversight, you have your sponsors there, and then mostly you have your steering committee. The steering committee mostly is made up of people who have skill and expertise in that field, and also the PIs, from the principal investigators from the different sites, and those that they think is needed, then they are all added to the steering committee. So for those who have oversight, we can also bring in our regulatory bodies. Your IRBs and then your regulatory bodies can also have some oversight activities. And then your data and data safety and monitoring board can also have some oversight activities also there. So from the steering committee, you are also able to get your publication subcommittees, your ethics subcommittees, and any subcommittee that for a research you think is important. You can have all those subcommittees under the steering committee, and they mostly directly report to the steering committee. And then coordination center, where you can have your coordination center. It could be in one site, where the site can serve as a hub and also as one of the sites. So you can have the coordinations there. And they make sure that everything that the other sites reporting is being done in the right way. And then you have your different sites, different level, either site 1, site 2, site 3. It can be, since it's multi-level, it can be as many as possible. So if you take a site, you expect that you have your principal investigator who will have the duty of making sure that everything works in that site. And then you can have your collaborators who will come in. It could be external collaborators. You can have your co-investigators who can also be there. And then your research manager. And then from the research management aspect, you can also have your clinical research coordinator and then other research support staff. So for research support staff, you need your data managers, you need your research assistants, you need your secretary, your administrative support, and then also, if you are doing anything in clinical trial, you might need your study pharmacist also there. You can have also your lab technician or your biomedical scientist also in there. But depending on the research that you are doing, you can have other people on board who can support and be at the role of other research support staff. So what do? You, as a researcher, should put yourself in a way where you are prepared. So you have, first of all, to stay prepared. How do you stay prepared? By making sure that you educate yourself. So you don't wait till someone comes to you that, oh, I want us to do a research in this and that. And then you don't even have any basic knowledge about research methodology, and then you start working. With that, you might fumble and make a lot of mistakes. So make sure that you start prepared, you improve on your capacity, build on your expertise with all that you need in terms of research methodology. And then whatever protocol is available to you, make sure that you read your protocol well, because when there is a research, there is a protocol there, and you have to make sure that you go and you abide by whatever is in the research protocol. So read it, imbibe it, and make sure that every line of it, so that when you are asked any question, you can be able to answer. Because some of the research staff might come at some point in time to ask you questions about what is happening. You as a PI should be able to know and answer appropriately. And then you need to also keep detailed minutes of what meetings you had, making sure that you have notes of things, of action points, so that at the right time you do the things that are available. Otherwise you will be overwhelmed at some point in time. And be flexible with your time, by making sure that there are always timelines to all research. So if you are supposed to give data at a specific time, make sure you send those appropriate data that is required. And then make sure that you have the required human resources for the project. For project, we have mentioned all the different staff that are needed. So you need all those human resources in terms of someone who can help you with your data, someone who is good enough for you to be able to pick up the research and be able to fill the forms, the CRFs that are available. If there is anything to do with lab, you need someone who can help you with that. So having the required human resources is very important, making sure that all cadres of staff are there. Your doctors, your nurses, and everyone, you should involve all of them. And ensure good communication among your team members. If there is no good communication among your team members, you might go into a lot of trouble, because you give instructions, your team member doesn't understand, and will just translate it into something that is not supposed to be done. So communication between you and your team level, it should be very good. And not only that, communication between yourself and your collaborators, external collaborators, your coordinating center should also be good. And all these communications should also be in a timely fashion. And make sure that you have project management skills, or at least someone there should have very good project management skills, because we are talking about multinational projects. So you need your project management skills to be able to have a good impact. And we need to ensure these, to make sure that you have your IRB approval. There have been chances where someone will come to you and tell you that, oh, there's this research I want you to do with me. You talk about the different approvals that you have to go through. They will tell you that, oh, this is just a small project. You don't need to go through all these ethics approval. Please don't bow to that. Make sure that all approvals are gotten and in a timely fashion for your projects, because it's very important. What the IRB helps is that it makes sure that the safety and well-being of your patients are strictly adhered to. So if you don't get the approvals, there is always a chance that you do things in a shady manner. And as researchers, we are supposed to be very honest. So IRBs, we need to go make sure that our IRBs are always gotten in a timely manner. And then let's clarify the roles and responsibilities of every member of the research team. Apart from that, you also have to get a very objective and approved study budget before you go in. And in terms of the contract or memorandum of understanding, make sure that you have one which is approved and signed. With a contract, if you really don't understand what is in, get someone with a legal background to help you, so that whatever intricacies are in that contract, you will be able to understand. Because at times there might be some lines hidden in the big volume of contract that you have, and possibly you might skip over it, and that can come and bite you at the end of your project, when you're expected to produce something which you think you didn't even see in your contract, because contracts are legal and they are binding. So let's make sure that whatever contract we sign, we have to make sure that we read it appropriately and then it is approved. in the case of when you are doing your clinical trials, whoever is on board, you have to make sure that you get their medical licenses. If the pharmacist, their licenses too. If it's a nurse, their license too is important, so that you know that they are authorized to work in that field. So some challenges can occur when you are conducting research. We as clinicians, we know that time is of essence to us. So our time is a very big constraint whenever you are doing research. Do you have adequate time that you can commit to the research? If you don't have adequate time to commit to the research, please don't take it. Just let someone else who has time do the research. And then also our regulatory bodies, at times it's so complex, going through FDA, going through IRBs and your ethics board, it's very complex, but that can be a challenge. And most of the time, there are lots of delays from that place. So let's make sure that you start in a timely manner so that when these challenges come, it doesn't delay it unnecessarily. And for most of us in LMIC, our supportive infrastructure is very weak. We might not have units that are fashioned to support you when you do research. You might have to start from the scratch. And if you have to start from the scratch and you don't have anyone to guide you, that can be a lot of problem for you. And for those, some of the people might not even have any research training. And there are times where collaborators also want sole ownership. So that comes in when you are signing the contract. Make sure you know what is in. And then also make sure that you have skilled staffing. Okay, because that will come in, so that, because if you don't have skilled staffing, you can have a lot of problems. Opportunities that you can have is that you can consolidate international research standards in whatever is done. So you are able to do international research at your facility, and that is a real plus for us. And if there are new methodologies, new technologies, you can help to promote that. And you also improve on the human resource in your facility whenever there is research going on. And also, it also opens doors for your facility to get equipment, because some of the projects might bring in equipment for your facility. Some of the lessons learned are these: that whatever you're going to do, keep it as simple as possible. So I will use the Wombs Tumor Collaborative project as an example, where we try to keep everything as simple as possible, and we try to bring everyone on board. And we need a very good communication regularly with your team members, with your external sites, and then your collaborators. And also invest in educating yourself and your team members, but making sure that the safety and well-being of your patients are the utmost importance. Okay, thank you very much.
Thank you so much. That was perfectly timed. We don't unfortunately have time for questions, but thank you so much. That was a great offering. Just to remind everyone, we have 8 papers to deliver in the next 2 hours. So each speaker has roughly 15 minutes, and if you can try and keep your presentation to 10 or 12 minutes so we have some time for questions. I see our next speaker has presented himself to the podium, Dr. Jacques van Heerden from Belgium, and I'll let him introduce his own topic. Thank you, Jacques. You can go ahead.
I'm just waiting, as we're waiting for my presentation to load, so I just want to say, whatever my dear colleague Vivian has said, I think the next 3 presentations exemplify what clinical research is about, and I'm very glad that SIOP Africa has actually given us a chance to show that we also should be studying a very difficult tumor. So can I have my slides, please?
Yeah.
Okay. So in South Africa, we have a big problem understanding what's happening with our surgical component for treating neuroblastoma. So we wanted to look at the factors that determine the access, or to see what determines if a patient gets operated or not in our high-risk population in South Africa. And I'm doing this on behalf of the South African Children's Cancer Study Group, the neuroblastoma working group. So I have nothing to declare. And the background for this is obviously that surgery has a great prognostic importance in neuroblastoma. And in South Africa, we have a great percentage of high-risk neuroblastomas, and we wanted to see how we could optimize the surgery in that group. And also in our country, the distribution of surgical resources is unequally distributed. Both of these points have been published from the South African study group that you're welcome to read. So our aim, as I said, was to look at these factors that influence the surgical component of it's not nice to bother people while they're talking, you know. Can you just, I'll sort it out myself. So obviously the aim of and objectives of this was, so the primary objective was to, sorry if I'm leaning on this thing, it's just easier to do it this way around. So the objective was to identify the factors that determine the access to getting the surgery. And the second one was then to which of these factors determine the outcome. So this slide is very populated, but the reason why I'm putting up this slide is we have to talk about the fall off of our population. So between 2000 and 2016, we identified 463 patients that were treated in South Africa, and we want to really see what the image-defined risk factors was, which is obviously a radiological investigation. And as you can see, the patients started falling off because of poor documentation. They did not have radiology and so forth, or they just died before they were able to be available for surgery after, so they probably died somewhere in their induction chemotherapy, so they never had the opportunity to be evaluated for surgery. So that left us with 271 patients over all risk groups. And if you look then further, eventually we got 204 patients that were in the high risk group. And we also just wanted to look at the stage 4 patients in that group, because we wanted to exclude any confounders in the high-risk group itself. And that left us with 178. So you'll see that when I give some of the data, the total will differ in all of those groups. So the methodology, so the factors that we were looking at were patient factors, tumor factors, staging, and we had to go and look at the INSS, and we know that that is falling out of favor in the neuroblastoma group. So we also went and had a look at the image-defined risk factors to do the INRG staging. And then we wanted to see management outcomes, and obviously the metastatic complete remission was really important there. And then you wanted to see what's the impact of the treatment site for treating your patients. So obviously we looked at it with a univariate analysis, and we did a multivariate analysis, and we had our ethical approval from the University of Stellenbosch in Cape Town, South Africa. Now, if we look at this, so I'm just going to squeeze everything together, otherwise I'm going to keep you here till tomorrow. I'm sure you all have flights. So what I've done here is I've taken all the factors that we looked at, and I'm showing you who were, for those factors, who were operated, who were not operated, and what the totals were, and the univariate analysis, if that was significant or not. So on this slide, from the patient factors, you can appreciate that age is still a very important factor. But ironically, well, probably not ironically, is that the highest number of children were in the 18 months to 60 months group. And if you know higher income data, usually it's more skewed to the lower ages and not to the nearly 5-year-olds. And that is easily explainable by patients that had fallen off because regression of a tumor had happened and was never diagnosed. Sex, obviously, that we know was also not a factor. So we looked at some of the tumor markers, and people always want to chase after a MYC-N amplification, which is really important in certain of the groups. But we proved that LDH and ferritin were really, really reliable when it came to determining which patients go to surgery. But if you think about it, that also prognosticates which risk group you are in. So if you are not going to operate your high-risk patients, this is kind of like flows into that. And then when we look at the grouping, you can also appreciate that 80% of our patients, or otherwise 70%, were distant metastasis patients, so the stage 4 patients. So you can understand why we have such a high-risk group in South Africa. And both of those, whether irrespective of your risk group, both were predictive of who got surgery and who did not. So you can already see where I'm going. Patients that are metastatic don't get operated. So, oh, sorry, did I give the thing away? So anyway, so if we look at the number of image-defined risk factors, you can see that about 60% of them did not have any image-defined risk factors. And now you'll think like, oh my gosh, this sounds like a very high number, which it is, because we only had retrospective reports from radiological reports and so forth to work on. So if your radiologist is not primed to look for those things, they're not going to report it. But as you can appreciate, all the high-risk image-defined risk factors were there as well. And some of them, there were some of them that had more, 6 of them had more than one. And you can see there's a higher percentage of patients that actually also present with pleural fluid that's not an image-defined risk factors, but is called other during the classification. This is no surprise to everybody, but getting a patient into remission after induction is obviously a big factor that determines if a patient gets operated or not, especially if it's the metastases are not completely in remission. So now, this slide is a compounded slide. So what I want to show here is that these are the hospitals. Okay, so yes, in South Africa we name our hospitals after alphabet letters. So the hospitals, I classified them according to the SIOP PODC neuroblastoma level of care. And as you know, one is where you've only got some basic resources, where level 3 is the possibility to do a transplant. But I want to remind you, in this data set, only 3% of the high-risk patients were transplanted. So it wasn't a factor that factored in here. And as you can see, is that and that's the second, or the second colored column, is that the hospitals with the higher numbers, the third column, the ones that had the higher operation rate, also had longer mean survival, if you look at that, and then the two of them had a really good outcome. And if we know, high risk neuroblastomas with trimodal therapy gets around 20% survival. And if you look at the green bar at the bottom, the total for South Africa, so we hit that mark more or less 20%. And that was just prognostic value. But please appreciate this was a very small cohort, the 174. So hopefully in bigger groups we can delineate that much better. So what I want to tell you here is that, so the word patients in neuroblastoma that live longer is really important, because we think they all die. So if we can make them live longer, we know that stage 4 do really badly. But if we can make them live longer, that's good palliative care. So when we look at multivariate analysis, throwing all these factors together, what came out is that metastatic complete remission was the main factor here, and then the staging, which is a bit logic because, stage 4, most of them, and that feeds into your metastatic aspect up there. So you can see whether the patient got surgery or not, which hospital they belong to, how many IDRFs they have, did not play any role here in the outcome eventually. It's getting those patients into remission because that influences your surgeon's decision to operate. So just to show you the nice curves that we always get from our statisticians, and I've got a really amazing statistician. You can see here, and this was all then adapted or for all the confounders, and you can appreciate the staging. It really shows you really nicely that the lower stagings do better than the higher stagings. And here, the survival curve, if I went into remission at the top and at the bottom, do better. And just think of this slide. This is your stage 4 patients. So if we get them in remission, they can do much better than the ones that aren't in remission. And if you look at the other one, the ones that were operated did better. Now, the kicker in this whole setup is that when I showed you the operated and not operated, you could appreciate that there was no clear delineation if you were in metastatic remission or not. The decision for that wasn't very clear cut, and that's why we did this study. So in those operated ones, there were people that were not in metastatic remission, so which might also be a confounder. But so I'm in this discussion, so it's really important to know that classification is obviously really, really important, but that the unit where you go to that's got, and as Professor Pritchard Jones said, it's not centers of excellence, but centers of expertise. So if you have your expertise there, and people that are committed to really, and we know neuroblastoma, you really have to be committed to dissect that tumor out, they do better or live longer. And I want you to realize that they live longer, which is a really important aspect in neuroblastoma. And do we know if it's better to operate them when they are not in metastatic remission or not? Well, if we look at North America and Europe, they have different approaches to when operating if you're in metastatic remission or not, and they still get their good outcomes, but caveat, they have transplantation and targeted therapies. So it's really important for us to start looking at this kind of data in our settings and see what comes up for us. So in summary, resecting high-risk neuroblastoma tumors has prognostic importance. So we must work harder to get them into metastatic remission. So we, as lower and middle income countries, must work from the front and not from the back of our treatment line. And then, so we must think more innovative how we're going to do this. And you do this by making the MDT more important. And that's why today I want to give a shout out to our wonderful surgeons, who you can see that is the ones at the bottom of this page. The rest of us are also important, the oncologists, but certainly our surgeons. And I don't think I have time for questions, but you're welcome to approach me with any questions afterwards.
Jacques, thank you so much. We're going to move straight on to our next speaker, Dr. Robin Charlton, staying with the same theme of neuroblastoma. She's speaking to us on the socioeconomic factors and distance from treating centers do not predict survival in South African children with neuroblastoma. Thanks, Robin.
Good morning. Good morning. Today I'll be speaking to you about neuroblastoma and the potential effect that socioeconomic factors may have on predicting prognosis in this disease. Okay, so neuroblastoma, as we all know, is the most common extracranial solid tumor of childhood, accounting for about 8 to 10% of all childhood cancers. It, however, has a disproportionately high mortality rate, being responsible for about 15% of all childhood cancer deaths. Another important thing to note about neuroblastoma is that it's a clinically heterogeneous disease with a highly variable course, ranging from spontaneous tumor regression in some infants to highly aggressive, often fatal disease in many older children. It's for this reason that it's vitally important that a patient be classified into a certain risk group at the start of treatment so as to guide the management strategy that is used for that patient. Now, there are certain clinical and biological factors which have been shown to be strong predictors of prognosis in neuroblastoma, and so these are used in the risk stratification. However, which factors are the most important is something that's still up for debate and differs in different classification systems among different working groups. So this here is a classification of risk by the International Neuroblastoma Risk Group, and as you can see, lots of different factors are looked at, and it can become quite complicated to try and figure out if a patient falls into high, intermediate, or low risk. Now, while these factors have been well researched and are frequently used in high-income countries, they're inconsistently available in low and middle-income countries such as South Africa. For example, the genetic tests of MYC-N amplification and 11q chromosome deletion tests are not always available in the public centers in South Africa. And if a patient were to go privately and try and buy these tests at, say, the Ampath labs, it would cost them about 6,000 Rand. Now, just over 50% of South Africans earn less than 2/3 this amount per month. And the unemployment rate in South Africa is greater than 30%. The informal unemployment rate is far higher than that. So this means that these tests would be completely unaffordable for the vast majority of South Africans. Now, this is where our study came in. We decided we'd try and find additional low-cost prognostic factors which could be used to try and help risk stratify a patient in situations where not all of these factors are available. This is not to say that any of these factors would replace the established clinical and biological factors, but rather that they could supplement the available factors where others weren't available. So in looking for which other factors we may be able to use, we thought we'd look at socioeconomic factors, as socioeconomic status has a huge impact on health, especially in low and middle income countries. So we chose a couple of indicators of socioeconomic status. So we looked at parental income, parental employment status, the distance of a patient's residence from their treating facility, and nationality, as South Africa often treats a variety of patients from other sub-Saharan African countries. So we conducted a retrospective record review in the 3 pediatric oncology units in Johannesburg. So the Charlotte Macnaike Johannesburg Academic Hospital and the Chris Hani Baragwanath Academic Hospital are both public or state hospitals serving Johannesburg and Soweto respectively. Together they have about 4,300 beds and serve a population of greater than 3 million. And then the Wits Donald Gordon Medical Center is a private facility in central Johannesburg, about 140 beds, offering services purely to patients who can pay privately or have medical aid, generally in the central Johannesburg region. So we looked at children under the age of 18 with pathologically confirmed neuroblastoma. So this is either on biopsy of excision specimens or fine needle aspirates or bone marrow trephine, depending on what was available for that patient. They had to be treatment naive. And we looked at a study period spanning 19 years. So we collected data on a red cap system. We looked at 2-year overall survival. This was so that we can get a larger study population going a greater study period. So normally a 5-year survival is looked at. We decided to do 2-year because it correlates reasonably well with the 5-year survival, and we get a greater population. And then we looked at certain prognostic factors. So the clinical ones were age, greater than or less than 18 months, stage at diagnosis, and we then looked at sex and things like that to see if it made any difference. The biological factors we looked at were levels of tumor markers, so LDH greater than or less than 750 units per liter, ferritin greater than or less than 120 milligrams per liter. We looked at MYC-N amplification status as none, gain, or amplified, and INPC tumor histology as favorable or unfavorable, and then the socioeconomic factors as I described. So one thing is, for parental income, we use the proxy of hospital classification, because in our public system, the way that a patient is classified is according to combined household income. So we thought this would be a good proxy for parental income. So we created Kaplan-Meier survival curves with multiple Cox regression modeling. And during our data analysis, we thought we saw an association between distance of residence from treating facility and the stage at which a patient presented. And to further investigate this relationship, we did a Kendall-Tau B correlation on the advice of our statistician. Okay, so overall, we had 164 patients, 19 of which were excluded, 16 because the files were missing, 2 because the patient's family declined treatment, and 1 because the patient wasn't treatment naive. Yeah, we found that the male to female ratio was 1.07 to 1. Our median age was 2.3 years, about 28 months. And the most common primary tumor site was the adrenal gland. In 4 cases, we were unable to find the primary site of tumor, and in all of these cases, it was because the patient presented very late with widespread disseminated disease. So this is also not going to go into too much detail here with all our data, just to point out the important points here. That stage was statistically significant on multivariate analysis. So anything that we found significant at 20% level in univariate analysis, we put into multivariate analysis. And then we found that LDH level was also statistically significant. As you can see here, stage has quite an impressive Kaplan-Meier survival curve with almost 100% survival in stage 1 and very poor survival in stage 4. In terms of our socioeconomic factors, we found that none of the factors we looked at actually had any significant effect on prognosis. In terms of that association we thought we saw between stage and distance from treating facility, there was a weakly positive correlation, but when we actually saw if there was statistic significance, there wasn't. As hospital classification, for example, looked as though there might be an association, but then didn't prove to be statistically significant on multivariate analysis, as with most of the socioeconomic factors. So this is the first study that's been performed looking at socioeconomic factors and survival in neuroblastoma. We found that our demographic profile was very similar to that seen globally, although our median age at presentation was 28 months, which is quite a bit higher than the 22 months reported globally. However, this is in line with other studies conducted in South Africa by Jacques van Heerden, where the median age is a little bit higher, although the patient overlap is possible there. It also could help to explain why we had generally poor outcomes in our study, as older age is associated with worse prognosis, and more than 93% of our patients presented in stage 4 disease. We found that there was a lower 2-year survival with age greater than 18 months, LDH level greater than 750 units per liter, and more advanced stage. We didn't find an association between MYC-N amplification status and survival, which we were expecting to find, as that's been shown in other studies. However, it could be that we had missing data. 37% of the data around MYC-N amplification status was missing, mainly because in the early years of our study, this test was inconsistently available in South Africa. Only 1 center in the country offered the testing, and even then, it wasn't always possible to get results. So the crux of the matter is that socioeconomic factors were shown not to have any effect on survival. And now this could be that perhaps some of the limitations of our study, so missing data, those 16 missing files, some data on the actual factors themselves, although only about 10 to 15% of information such as maternal employment was missing. So that's not actually a huge amount of information. The other possibility is that we had a poor choice of proxies. So hospital classification as a proxy for parental income isn't necessarily that great, as the HO or HG classification should be assigned to all patients below the age of 6, regardless of parental income. So overall, though, what our study found was that there is a definite increased survival with age lower than 18 months, stage lower, the lower the stage, the greater the survival, and lower LDH levels, less than 750 units per liter. There is not an association between parental income, parental employment, or distance of residents from treating facility on neuroblastoma prognosis. So we know that neuroblastoma is strongly biologically driven, and it's a highly aggressive disease. And it seems from our study results and from what we've seen in neuroblastoma generally, that it is actually unaffected by external factors, including socioeconomic factors. So it may be that the very nature of late-stage neuroblastoma has an overriding influence on survival, which is unaffected by things like socioeconomic factors. Thank you.
Robin, thank you very much. I'm going to ask you to stay there because we have now a few minutes for questions. That's always nice. Are there any burning questions or comments from members of the audience? You've stunned everyone into silence. Jacques, yes, please. There's a microphone coming at the back.
Don't worry.
Sorry.
I'm not a saboteur, don't worry. Okay. One thing that you did not mention is the amount of treatment a patient got. Did you guys look at that? Because we know that if you have one treatment modality versus multiple, it does have an effect.
That's true. But no, we didn't look at that specifically, but that is a very good point and something we should have a look at in the future. Thank you.
There's a question in front here.
Hi, thank you. Kathy Pritchard-Jones from the UK. Are you able to capture any information about how knowledge of the potential prognosis of the disease affects families, drive to complete treatment? Because obviously neuroblastoma has this whole range of highly curable, young, localized, and then very poor prognosis. And I just wonder if that influences it's a sort of chicken and egg, because you're talking about prognosis, but I'm also thinking of Jacques'
Yes.
presentation, which we didn't have time to discuss.
No, that's also a very interesting point. And no, we didn't really look at that in particular, but that would be interesting to investigate further.
So Kathy, is it on now? Oh, okay. So Kathy, I think your question just on that is that I think it was somebody last night at Judy Skuman said we've got 11 official languages, and communicating such things to patients obviously comes very difficult. So just the basic concepts of what happens with neuroblastoma and the tumor biology is difficult to explain, and then to multiply that with make a decision based on outcome. I think that might be a challenge that stops us from looking at that, but it's certainly a worthy thing to look at.
Thank you. Thanks, Robin. Thank you so much. Right, so still staying with the theme of neuroblastoma, I'm going to invite our next speaker to the podium, Dr. Irene Nanyanga. Irene, I hope I've pronounced your surname correctly. And she's going to be speaking to us about a multi-center study evaluating the presentation predictors of survival and outcomes, again, of neuroblastoma in Uganda. Thank you, Irene.
All right, good morning. I'm called Irene Nanyanga. You did well, Mike, thank you. And I'm a fellow at the Uganda Cancer Institute. I want to tell you about this very prime study that we did, a multi-center study that looked at evaluating neuroblastoma, the presentation, outcomes, and prognostic factors in our setting in Uganda. Sorry about that. So I have nothing to disclose. So just like Dr. Charlotte and Dr. Jacques described neuroblastoma, this is a well-known adverse presentation tumor which has a vast presentation, just like in our setting, just like in your setting, in our setting, it can mimic so many childhood illnesses as well. So given the fact that we did not know how it presents in our setting, we needed to know at baseline and also look at some of the factors that could predict survival in our setting. So the approaches to its management still in our setting as a low income country actually, are not known, and we still have those poor outcomes as you highlighted in South Africa. So we went ahead to look at how does neuroblastoma present in Uganda, and then after looking at its presentation, we wanted to see the outcomes in regards to survival, and then what are those factors that predict the survival of the tumor in our setting. So we did, this was a retrospective multi-center study, and we did a chart review at 3 sites, the Uganda Cancer Institute. This is the Center of Management of Cancer in Uganda, and it oversees different sites in different regions, but also receives patients from all the regions in the country. We also had Mulago Hospital Pediatric Hematology Oncology Unit, which also receives patients from the different regions of the country. And added to that, we had a 3rd unit, which was specifically in the western part of the country. That was the Mbarara Regional Cancer Center. So our study population were children 0 to 15 years, and we collected the data from 2010, that was January, up to 2020, November. So after collecting the data, we went through a procedure, entered it in a red cup, and then we did analysis using Kaplan-Meier for survival, and we went ahead and did Cox regression for prognostic factors, and then looked at the bivariate and multivariate factors and considered those which were significant. So our interesting results came out, and we had 84 patients who had a diagnosis of neuroblastoma, but we had to exclude some of these. Our inclusion criteria looked at all children who had a diagnosis of neuroblastoma that was morphologically done with or without immunohistochemistry. We had only 52% of our patients having immunohistochemistry done. That is just slightly above half of the population. Then we excluded some patients who did not have the initial presenting features like age and others that are key in defining our prognostic factors. So at the analysis, we had 61 patients whom we analyzed for survival and prognostic factors. 14 of our patients were not included in analysis because we wanted to look at 1-year survival, and these had not made 12 months in care. So when we looked at the epidemiological data, most of our patients were aged between 1.5 years to about just below 5 years. And we had our male to female ratio of 0.9, and the Uganda Cancer Institute contributed just slightly above 50% of the patients that we enrolled in our study, also the charts that we reviewed in our study. So at presentation, we see that just like we have described prior, our patients presented with abdominal pain, abdominal swelling, abdominal masses as some of those presentations of neuroblastoma, but we had a significant number presenting with constitutional symptoms, including fever, night sweats, weight loss. And just to note that in this population, just above 80% of our patients had raised blood pressure, both elevated and hypertension. And that was something that was significant to note. So when we looked at the tumor characteristics, we see that most of our patients had suprarenal as their primary tumor location, but in total, the abdominal tumor location accounted for up to 72%. Then we see that just like Dr. Charlotte has elaborated, most of our patients presented with high-risk disease, and we see the impact of high-risk disease to the outcomes, to treatment, and survival of our patients. So it's key that we identify the children early to present this presentation. So some of our patients did not have a documentation of their risk done, and then we had, in regards to metastasis, we had lymph node metastasis as coming out most prevalent, but this included both regional and distant metastasis. But just to note that we had a number presenting with bone marrow metastasis. This was 16. Unfortunately, we managed to do only about slightly above 50% of our patients had bone marrow biopsies done. So getting 16 out of about, let's say, 50% was quite a number for our metastasis to the bone marrow. And also we noted the scalp metastases were rather high in our setting. Then most of our patients, just like you have elaborated prior, were in stage 4 disease. Actually, over 90% of our patients presented with stage 4 and stage 3, and we had no patients in stage 1 and stage 2. So when we went to the treatment, we gave induction chemotherapy to 69 of our patients out of the 75 total that we had. And 6 did not have chemotherapy because 4 of them died prior to starting chemotherapy. 1 of them got spontaneous tumor regression, which was good, and then 1 was due to start chemotherapy. When we finished the induction chemotherapy and we assessed, there were some patients who went on to have maintenance schedule. So this is very key to note that we are going to see later the effect of giving maintenance schedule in our patients, even if they are possibly on palliation, and its effects on survival time. So we saw 13 of our patients got maintenance schedule, and 32 did not have maintenance schedule, and the other 30 were among those ones who were possibly not yet ready for starting maintenance schedule because they had not finished induction, or they are patients who had died before reaching the time of induction. So when we looked at the general outcomes of our data, 30 of our patients had died, were alive at the end of data collection. 37 of them had died, and 8 of them were lost to follow-up. And we did not see this, despite the efforts to contact them through phone calls. They were not reachable. So we see that 10 of our patients got remission, clinical remission. 5 of them got partial remission. But the 60 that is up there includes those who had not reached the time to get into remission as well. So it shouldn't scare us so much. However, just to note that 22 of our patients went on to go into disease progression, and even those who had got clinical remission, 4 of them relapsed. And 2 and 3 of those who relapsed died, actually. So when we did this analysis, we looked at the survival, and we saw that our median survival was about 18 months, which is 1.5 years. Then overall survival rates for our cohort here at 1 year and 2 years were 61 and 44%. And then we looked at surgery. We know that local therapy is very important in curbing the disease in neuroblastoma. And we looked at the few who actually had surgery done, who were just 15 of the 75, and those who did not have surgery. Those who did not have surgery had an adjusted hazard ratio of 1.23. Though it was not significant, we thought that this can enlighten us as people, as carers of neuroblastoma, that local therapy is very important, and if we had done a rather bigger number of surgeries, maybe it would have been significant. So this is where I come in to enlighten us about the CADO, maintenance CADO. So we had the 13 patients who had maintenance CADO given, and we compared this to the 32 who did not have maintenance CADO. So the survival time for those who had maintenance schedule increased to almost 3 years, compared to the 1 year of those who did not have maintenance schedule. So as a low-income country, we look at how to improve the survival time for our children. And one of the things that we may take from this study is that giving maintenance schedule can have a positive impact on the survival time of our children, though it didn't have effect on the overall survival. So these are some of the Kaplan-Meier curves looking at the prognostic factors that were significant following bivariate and multivariate analysis. So this study was rather unique. We found that age above 18 months was rather significant for survival, unlike previous studies where we have reported that below 18 months has better outcomes. And this is unique to this population, and we'll find out reasons why later on. And we see that patients who presented with elevated white blood cell counts also had poorer outcomes, and it was also significant on multivariate analysis. Presence of lung metastases also turned out to be significant, but this has also been described in previous studies. Even in higher income countries, the lung metastases are poor indicators of survival, but we see that patients who did not have metastatic disease actually had better outcomes in our findings. The Kaplan-Meier curve on your extreme left is looking at the maintenance schedule versus no maintenance schedule, just to elaborate again that those whom we gave maintenance schedule had actually a better outcomes compared to those who did not. So for this study, we found that children below 12 months actually had poorer outcomes compared to the previous studies that have been highlighted. Why is because we thought our patients in this cohort presented with advanced disease. We had 6 patients below the age group of 12 months. 5 of them died, and they had advanced disease. And still these patients, we know that neuroblastoma regresses, especially in infancy. So our cohort has delayed presentation and often poor health-seeking behavior. So we think that maybe the children who had neuroblastoma in infancy or in the infancy period actually stayed home and the tumor regressed. They did not report, and so we did not capture that data. That's why the one that we are presenting are the ones with advanced disease. Then elevated white blood cell count. In the earlier 1990s, it was described as leukoerythroblastosis, whereby these patients had presence of mature and immature erythroid cells in their blood film, which were elevated with or without anemia. So when we went ahead and looked at the patients who had elevated white blood cell counts, we found that actually 75% of these had bone marrow infiltration. And of the 25 who remained, they had actually not done bone marrow biopsies. So it's actually an indicator of poor survival that we can use in our setting to show that the implication on white blood cell count on survival. On the other hand, we see that localized disease had better outcome, just like I've elaborated, and giving maintenance schedule has an effect on survival time, but not on overall survival. So in our recommendations, we think that if we have more resources, should be allocated to local therapies, because we've seen that if we had more numbers having surgery done, then maybe there could be an effect on overall survival. And then giving maintenance therapy has an impact on our management, especially if we are to do palliation per se. And then if we can use early awareness or creating awareness for the early presentation signs of our childhood cancers, then maybe we can capture our children early on. These are my acknowledgements to the staff of Uganda Cancer Institute, Mulago and Mbarara, and those are my supervisors. Thank you, Dr. Jacques, and Dr. Joyce Balagade, and Dr. Victor as well, and I appreciate SIOP for giving me this opportunity as well to present my findings. Thank you.
Thank you, Dr. Nanyanga. We don't have time for questions, although I have a burning question, but I'll ask you at tea time. We're going to change tack now to Wilm's tumor, and I want to invite Dr. Ernestina Skandorf. I hope I'm pronouncing that surname correctly. Ernestina, you can tell me. and we're going to talk about 5-year review of epidemiology and survival rates in Wilms tumor at a tertiary pediatric center in Ghana. Welcome.
Good morning once again. Thank you very much for the privilege. So my name is Dr. Ernestina Shandorf, but you tried. Yes, so I'll be presenting. I have the opportunity to present on the 5. Okay. So I have the privilege to present on the 5-year review of the epidemiology and survival rates of children with Wilms tumor at a tertiary pediatric facility in Kolebu, in Ghana. I have nothing to disclose. So to start with, this is the beautiful picture of our teaching hospital, the Kolebu Teaching Hospital, which is located in the capital of Ghana. It is a 2,000-bed facility, and the pediatric oncology unit sees about 200 children a year. It's the leading referral center in Ghana and the largest hospital in West Africa. Currently, we have available the radiotherapy department and more recently, the pediatric intensive care unit, which started in 2019. On the right, you see a picture of our pediatric oncology unit, daycare, where the children receive their chemotherapy. So as a way of background, we all know that Wilms tumor is the commonest renal tumor in children, and it contributes to 6% of all pediatric malignancies. But even though it's highly treatment responsive, there still remains a disparity in survival between high-income countries and low-income countries, where in high-income countries, the survival is above 90%, where in resource-limited countries like Ghana, is still less than 50%. And the total number of Wilms tumor cases we see in our unit is about 22 per year, which constitutes 11% of all pediatric malignancies. So the aim of this study was to evaluate the epidemiology and survival rates of Wilms tumor at our unit in Kolebu Teaching Hospital. So we retrospectively analyzed 114 hospital records of all patients with Wilms tumor admitted to the pediatric oncology unit of Kolebu Teaching Hospital between 2014 and 2019. All the patients underwent SIOP PODC protocol with preoperative chemotherapy with either 2 or 3 drug regimens, including vincristine, actinomycin D, and doxorubicin, depending on the staging, after the initial assessment. And after about 4 to 6 weeks, depending on the stage, a nephrectomy is done, and post-operative chemotherapy is continued based on the surgical pathological staging. So for our results, over the period of 5 years, the proportion of Wilms tumor was 9% out of 1,060 patients with malignancy. And this was relatively higher than the estimated 6% from literature. For the age distribution, we also noted that the mean age was 4 years plus or minus 2 standard deviation years. The youngest child we had was 5 months, and the oldest child was 11 years, 3 months. We also noticed that females, the girls were more predisposed slightly by 52%, which was also consistent with literature. For the tumor sites, most of the tumors occurred in the left kidney with percentage of 53%, and bilateral disease was found in 6% of our children. For pathological staging, we noticed that for the surgical staging, most of the assessments were mainly stage 3s. However, on histology, stage 2 was the commonest pathological stage. And based on the histological findings, it was also noted that the intermediate risk mistype contributed to 2/3 of the histology findings, followed by the high-risk blastemal type, which was 16%. We had 2% of focal anaplasia as well. For the percentage necrosis, majority of the patients had necrosis of less than 65%, and only 3% had a necrosis of 100%. The results of for our treatment status, we had slightly more than half completing their treatment. That's 55.3% of the children completing their treatment. However, 10.5% abandoned treatment, and unfortunately, third, like 31.5% died. Of those who died, majority were stage 3 and stage 4. With stage 4s, so the number who died was 12, and about 7 of them were stage 4, and the rest were stage 2 and stage 3, but no child with stage 1 died. So we also analyzed the overall survival rates, the 5-year survival rates with Kaplan-Meier curves. And as you can notice, stage 1 was the best survival with no child dying from stage 1 disease. However, the survival rates gradually decreased by 20% as the stages advanced. So the survival rate for stage 2 was 87.7% and was 71.1% in stage 3. And stage 4 had the lowest of 52.4%. And overall survival was 74.7%. The significance, the p-value for this curve was 0.04, and this was significant for our study. So in reference to the collaborative Wilms tumor project, where the adaptive Wilms tumor treatment guidelines were implemented in sub-Saharan Africa, with countries like Ghana, Uganda, Ethiopia, Malawi, and Cameroon being included. The survival rates that were found at baseline and at the end of treatment were improved from 52% to 68%. And from our study, you can see that this had actually improved even further to 74.7%. However, the late stages had very low comparative stage 1 and 2. So Wilms stage 1 and 2 confer a better survival rate for our children. And increased advocacy, especially in developing countries, is very, very crucial for early diagnosis and treatment and adherence to treatment to the protocol. Because during the early stages, the cost involved is less, the treatment duration is less, and parents tend to comply more to the treatment and abandon the treatment less as compared to the late stages. So increased advocacy is very, very crucial in our country. And this is also in line with the Global Initiative for Childhood Cancers to try and improve the survival to at least 60% by 2030. And we have a long way to go with our late stages, especially stage 4. And so also we need to have more efforts in reducing abandonment rates. And one of the efforts is advocacy, advocacy, advocacy. The earlier they present, the less expensive, the less time they spend, and the more they comply to the treatment. And also, we need to improve the survival in our late stages. And with the introduction of our new pediatric ICU, it will help significantly in the very, very ill children with the late stages so that we can also improve the survival of those with stage 4 and stage 3. So I'd like to acknowledge all the patients and the parents who participated in this study and the whole pediatric oncology team. I'd like to acknowledge SIOP and WCC, World Child Cancer, that has been supporting us as well, and all of you for listening to me. Thank you very much, and medase, as we would say in Ghana.
Thanks, Ernestina. I'm going to ask you to stay there because we have lots of time for questions. Kathy, I'll take yours in a second, and then Esther. I have a question though. In the group of patients who abandoned, do you have a sense of how advanced their disease were? So in other words, did they abandon treatment because they were very advanced, or was there no relationship between stage?
So yes, thank you very much, Mark. So we noticed that for those who abandoned, majority of them were stage 4 and stage 3. And also the abandonment rate was worse between 2019 and 2020. And we suspect because of our COVID restriction protocols during that time, a lot of people couldn't travel from their locations to the hospital. So we suspect that also contributed to the abandonment rate around that time.
Thank you, that's really useful. Kathy and then Esther. Can we have a mic in front for Professor Pritchard Jones, please?
Thank you. Very nice talk and comprehensive review of what you're doing at Corlebu with Wilms. I just really have a comment, because you use the word only 33%, I think, had regressive disease. No, I'm just going to say that is exactly what we find in the Wilms tumours in these mostly European children in the SIOP renal tumour study group. It's about, a small percentage totally necrotic, about 1/3 regressive, and then the rest have a histological subtype. But what I do note is you have probably a higher proportion with the high-risk blastemal type, and this may, of course, be related to tumor volume at diagnosis being overall larger, because we see this in Brazil as well, who take part in our study, that they have bigger tumors at diagnosis, and that may explain the residual burden of blastema. So just an observation, really, but I think it would be great, to build on this now, and I'm hoping that centres in Africa will be able to look at the somatic molecular genetics of their Wilms tumour in relation to things like gain of 1Q, once we get the assays sorted out and affordable. But it's the next step of research is to understand the biology of the tumours as well as the response rates.
Thank you very much.
Hi, thank you so much for your presentation. I just wanted to ask the patients who died in your study. I know you talked about you guys having ICU right now. So my question was, the patient who died, did they die during treatment or after completion of treatment?
Thank you very much. So yes, for the patients who died, majority of them died before treatment, and some during the preoperative chemotherapy treatment. Most of them came with extensive pulmonary mets, and our ICU started in late 2019. So prior to that, we didn't have an intensive care unit. So they were basically managed on the wards. Yeah, so most of them died pre-surgery, pre-chemotherapy, and a few of them during the pre-op chemotherapy, and a few of them died during the initial chemotherapy. There was one patient who died from renal failure. That child came with bilateral disease, and unfortunately we couldn't salvage the renal failure.
Thank you, Ernestina. Any other comments? Oh, yes, I see.
Yeah.
Thank you.
Thank you very much for that presentation. I'm an oncologist from Uganda. I have a few questions on Wilms tumor because we are currently facing quite a slug, let me say, in our treatment of the Wilms tumors. We seem to have a lot of relapses currently for our children. And we have discovered that we have a very high rate of diffuse anaplasia. In your presentation, you talked about the focal anaplasia, but you did not mention the percentage of the kids with diffuse anaplasia. I'm curious to know if that is something that you're seeing in your setting, because in the Western world, it seems to be at a low rate, but we tend to find it to be extremely high for us currently. And then my next question is, for the patients who you're treating and they are not improving on the treatment because you're not doing surgery upfront, what then are you doing? Did they actually affect the survival rate? Did you look at that as well as a separate cohort to see if it's a confounding factor? And the patients with bilateral disease, if you put them separately, how is their survival compared to the ones who come in with unilateral disease? Thank you.
Thank you.
Okay, I'm going to ask you to answer the question about the anaplasia, and you guys can catch up over coffee to discuss the other two questions, if that's all right.
So thank you very much, Victoria. So surprisingly, during our histological assessment of the histologist, we didn't have a diffuse anaplasia patient, but most of them were focal anaplasia, blastemal types. We had epithelial, and then we had one rhabdoid tumor, but we didn't have diffuse anaplasia.
Yes, quick.
Just to say, anaplasia is often not recognized by the local pathologist who's not familiar with many renal tumors. So I think it's important to have a discussion, but having a national sort of review service in Ghana, and it'd be interesting to ask Gordon Vujanik, who's the SIOP Renal Tumor Study Group pathologist, if he might help you with reviewing these cases to see if there is anaplasia present. Because you're seeing it and your centre's not, but I suspect it's probably the same in both, and maybe it's a question of recognition.
Thank you. Thank you, Ernestina, so much. So I'm going to invite our next speaker. Thank you. Dr. Shamimu Namugerwa. I hope I said that correctly. Wonderful. And we're staying with the theme of nephroblastoma, and she's going to chat to us about the outcomes and predictors of survival in children with Wilms tumor at UCI. Welcome and thank you.
Good morning. Thank you. My study was titled Outcomes and Predictors of Survival Among Children with Wilms Tumor at the Uganda Cancer Institute.
Can you guys move the slides on for us? It's still on the first slide. Can we get a...
Okay. So, Wilms tumor, there are no disclosures.
You can move to the next slide, please. Thank you.
Yes. Wilms tumor is the most common extracranial solid tumor of childhood in Africa, and at the UCI, it is the commonest abdominal tumor that we see. It's one of the success of pediatric oncology, with the survival rate in high-income countries above 90% for localized disease and almost above 75% for metastatic disease. In Uganda, the reported survival rates previously were ranging from 11 to 43.6%. In 2013, the treatment protocols that were adopted at the Uganda Cancer Institute, and the protocol improvements included adjusting chemotherapy for children with malnutrition, and then having a central pathology review of all tissue samples, and then timely and protocol-specific surgical intervention, and then time and protocol-specific radiotherapy interventions. Also, there was a formation of a committed pediatric oncology department at the Uganda Cancer Institute, and formation of a multidisciplinary tumor board that discusses about these children with solid tumors every week to make a plan for them. And also there was improvement in social support. There was introduction of hostels where children who are undergoing treatment can stay as they wait for their next appointment of chemotherapy. So our objective, well, our purpose of the study was to find out how we are doing after all those improvements in the management of children with Wilms tumor. So the primary objective was to determine the 5-year overall survival rate of children with Wilms tumor, and also to determine the predictors of survival. The second objective was to determine the treatment abandonment rate of these children. This was a retrospective cohort study that was done by chart review, and our study population were all children aged 0 to 15 years of age that were diagnosed with Wilms tumor from January 2014 to December 2019. All these patients had a histological evidence of Wilms tumor in their files, and patients who had received initial chemotherapy or surgery somewhere else before referral to the UCI were excluded. In the baseline characteristics of these children, most of our patients were females at a percentage of 53.9%. The age group, most patients were between 3 to 6 years. The mean age of presentation was 3.6 years. In the clinical characteristics, the median duration of disease symptoms prior to diagnosis, prior to the presentation, was 3 months. And the commonest presenting symptom was an abdominal mass, which was at 74.8%. Some patients presented with abdominal distension. A few patients had fever, weight loss, and abdominal pain. And actually, only 7% presented with hematuria. We noticed that 65.2% had hypertension, and majority of the children had a normal nutritional status at diagnosis. Only one patient in our study had hemihypertrophy, and no patient presented with acquired vulnerable brain disease. The total number of patients that we had in this study were 115. So most of our children, important to note, presented late. Most presented with stage 3 disease, that was at 58.3%, followed by stage 4, 33% presented in stage 4. We only had 4 patients presented with stage 2, and no patient presented in stage 1. The lung was the commonest metastatic site, followed by those patients who had both lung and liver mets, and liver had only 5.2%. At diagnosis, also of note that we had many patients with anaplastic histology. 40.9% of our patients presented with anaplastic histology, and of which 14.8% had focal anaplasia and 26.1% had diffuse anaplasia. In the outcomes of children, those who went into complete remission were 58 at a percentage of 50.4%. 23.5 had disease progression. We had 9 patients, that is 7.8%, that had relapse disease. Of note, among the patients who had relapse, actually 7 out of the 9 patients who had disease relapse had diffuse anaplasia. Then those who abandoned treatment, the treatment abandonment rate was 29.6%, and those who were lost to follow-up were 16.5%. In the outcomes, the overall survival at 1 year, as we see at the Kaplan and Meyer, was at 77.8%. And then at 3 years, the overall survival was 58. And at 5 years, we had an overall survival of 48.3%. The treatment abandonment rate was 29.6%. And when we look at the Kaplan and Meyer of the treatment abandonment rate, we see that those patients who abandoned treatment, actually their 5-year survival was less than 25%. And among the prognostic factors, the predictors of survival, children with both liver and lung mets were 3 times at a risk of dying than those who had no metastases, as we see in the Kaplan and Meyer. And those patients who had diffuse anaplasia were 3 times at a risk of dying. Similarly, those patients with focal anaplasia also had 2.83 times of dying. So when we look at these results, children with diffuse and focal anaplasia almost had the same outcome. And when you look at the Kaplan and Meyer, the 5-year survival for those patients with diffuse anaplasia was also less than 25%. Among also the other prognostic factors, patients who had surgery done had a 69% less risk of dying compared to those who did not have surgery. And those patients who had radiotherapy had 83% reduction in the risk of dying. And then for relapse patients, patients who relapsed had a very poor outcome. And at the end of the 5 years, almost we did not have any patient that had relapsed who was still alive. So in the conclusions, children with Wilms tumor at the Uganda Cancer Institute have increased rates of hypertension at 65.2% and high rates of anaplastic histology at 40.9%. Protocol adaptations at the UCI have contributed to improved outcomes. When we compare the previous outcomes that were 1 year was around 43.6%, and now the 1 year survival is around 77.6%, and our 5 year survival at 48.3%. There is great improvement in the outcome of these patients. Survival is equally poor for those with focal and diffuse anaplasia, as we know that in the treatment and risk stratification, these patients are stratified differently, those with focal and those with diffuse anaplasia. Treatment abandonment is still a major problem affecting outcomes. In this study, it was at 29.6%. However, it has reduced compared to the previous studies, where the treatment abandonment rate was in 43.6%. So we think the social support that has been put in place, where patients can stay in hostels and wait for their next appointment, has improved the treatment abandonment rate, but it's still a major problem, and we need to devise more ways of dealing with it. Both patient-related and tumor-related factors still contribute to the shortfall of the overall survival to reach the GICC target of 60%. As for now, 5 year survival is at 48, so we need to improve our care so that we reach the 60% survival. Of note also in the presentation that our patients present in stage 3 and stage 4 disease. So it is also to be put in. So my recommendations, Uganda should increase the resources to access surgery and radiotherapy, as we have seen that local therapies have great importance in the management of children with Wilms tumor. Then adaptations to the management protocol to improve outcomes of diffuse and focal anaplasia, as we have seen that both have equally poor survival for those with focal and those with diffuse. Then strategies to prevent abandonment should be developed. I appreciate the Uganda Cancer Institute team, Makerere University Department of Pediatrics and Child Health, and then my supervisors, Dr. Joyce Balagade, Dr. Gary Gafadil, Dr. Eric, and Dr. Jacques. Thank you so much.
Thank you, Shamima. We do have time for questions, but before we start, can I just ask the House if Dr. Abdul Karim Doumbia is here? I'm going to take that as a no. And also Dr. Brenda Malon. Brenda, will you load your presentation with, is it there? Because I've just been told that the next two presentations are not appearing, so just double check, will you? Ta. And then also Dr. Elizabeth Nagawa, are you present with us? You here? Oh, great, thank you, Elizabeth. Sorry. It just affects how we take questions. So we do actually have additional time for questions. So yes, Doctor, first you, and then you will take the mic there. The gentleman over in the pink shirt there at the end. Yes. Sorry, is that pink? My eyes are bad, so.
Hi, great presentation. Thanks so much. My name is Maz. I'm from Malawi. I just wanted to touch base on the high rate of abandonment. You know, I was just trying to reflect on some of the statements that were made at the gala night yesterday, where, you know, during the time of, early time of the UCI, we actually had rates of 6%. And now we do have, a hostel, there. Do you have any sense as to why there is still such a high rate of abandonment? And are these abandonments happening pre-surgery or post-surgery?
Thank you so much. Why we have high rates of abandonment despite having the hostels? Most of the other things were, because when we are collecting data, we had to call the parents for those patients that were not reporting at the UCI. And some of the responses that we are getting, some patients preferred alternate therapy, going to herbal medications instead of coming back. Some of them after surgery, most patients after surgery, when they think the child is now better, they don't come back for more chemotherapy. Yes. So they feel like the child is better. There is no need of coming back. Yes.
Thank you. Doctor?
Okay, thank you. I'm Dr. Mulgeta from Ethiopia. It was a nice presentation. My question is like, we have 40, close to 50% rates of aplasia, focal and diffuse. So was there any second look by the verifying pathologist, or is there any way that you have confirmed that these numbers are really true? Or is that a kind of a single pathologist report? Thank you very much.
Thank you so much. Most of the patients that were included in this study, they had a biopsy initially at presentation, and they had a documentation of the histology. But also after surgery, the nephrectomy specimen was also studied, and they had a histology after. So I looked at both, having the first biopsy that was done, and then also the nephrectomy specimen. So they were done 2 times. And most of them had the same anaplasia at the beginning of treatment, but also at surgery, it was still anaplasia.
Thank you. Again, very nice presentation, thank you. I just have a comment really. Again, to amplify your point though, I think having some form of pathology, as a group in the various African centres that have these nice data on survival outcomes, it would be good to see if you could get your pathology colleagues to perhaps agree to do a retrospective sharing of a subset of samples to see how often they agree on the presence or absence of anaplasia. It would be quite a simple thing to do, I think. Now, I just wanted to comment on the survival rates. So in the SIOP WT 2001 study, the children with stage 4 disease and diffuse anaplasia, despite very intensive chemotherapy and radiotherapy, had an overall survival rate of about 33%. So given the proportion of your patients that present with stage 4 disease and have diffuse anaplasia, I'm not surprised that your overall survival rates are only hitting about 50% at longer term. And it says to me that you've probably got your treatment right. The biggest challenge is to get the patients to present earlier and to reduce abandonment. And I think also in this context of how your patients come to you, you've got an opportunity to potentially do some studies of, does time in the patient lead to increased risk of anaplasia? Is it time in the patient because your median symptom duration is quite long? Or is there something fundamentally different about the biology of Wilms tumors in sub-Saharan African populations? And again, you probably need to be able to have samples to look at the molecular biology to get to the bottom of that.
Thank you, that's really useful.
Thank you so much.
Any other questions or comments for Shamimu before I release her? No, Shamimu, thank you so much. Well done. So we're going to change the order of the presentations just for ease, and I'm going to ask Dr. Elizabeth Nagawa to come and speak to us on one of my favorite topics. So we're changing tack now to muscle tumors, and she's speaking to us about the outcomes and predictors of survival in orbital rhabdomyosarcoma at UCI. Thank you, Elizabeth.
Good morning to you all. By the name, Elizabeth Nagawa. I'm an ophthalmologist, and we did a study about outcome and predictors of survival among children managed for orbital rhabdomyosarcoma at Uganda Cancer Institute. I have no disclosures, and that will be my outline. And orbital rhabdomyosarcoma is the most common rapidly growing solid tumor of the eye, with 10% occurrence from literature. It is noted that a study done in Makerere in 1960, Makerere University in 1967 noted that orbitorhabdomyosarcoma accounted for 7.6% of all tumors of the eye and adnexia. It is highly curable globally, especially in the well-developed countries, with reported 90% survivals, and this has been attributed to the multimodality approach. However, with all this knowledge, the survival and the outcomes in our study population or in Uganda had not yet been studied. Hence, we decided to find out how our patients with orbitorhabdomyosarcoma are faring, since Uganda Cancer Institute had become a center of excellence. So our general objective was to assess the outcome and predictors of survival of the children. And in our study, a child was anyone aged 0 to 18 years. And this was a 10-year retrospective study, and the data was collected between 2008, January to December 2019. The specific objectives were to determine the 3-year and the 5-year survival of these children, and also to determine the predictors of survival. So as you can see, that is in the background, that is the Uganda Cancer Institute, the Fred Hash building. And this was a retrospective cohort review of files. I collected my data between the 1st of May 2021 and the 31st of May 2021. And all the children who had been managed at Uganda Cancer Institute with a diagnosis of orbitorhabdomyosarcoma were included in my study. And this has to be histologically confirmed. And all those patients who had been diagnosed, however, they abandoned or ran away from hospital before commencement of treatment, were excluded from this study. And then we obtained a sample size of 71 children. So we retrieved from the records, with the help of the records department, we retrieved 78 files of children with orbitorhabdomyosarcoma. However, 4 did not have the histology diagnosis, so they were not included in our study, and 3 were excluded. Of those of the 71 files that had histological confirmation of orbitorhabdomyosarcoma, we were able to obtain the vital status from the files of these patients of 44 participants. And of these 44 participants, only 13 were alive at the end of our study and 31 were dead. So for the 27 participants, according to our protocol, we were supposed to use a pre-stated phone script and call up the parents with the help of a counselor and find out how the patients are faring. We were able to reach only 18 participants, and of those, 8 were alive while 10 were dead. However, 9 of the patients were not able to reach them and were censored alive at that time. So in the results, with our population of 71 patients, our median age at diagnosis was 6 years, with the youngest participant 5 months old and the oldest 18 years, with majority of our participants, that is 43.7%, aging between 7 to 14 years. More than half of these study participants were male, with a ratio that is noted. However, the ratio is slightly similar, 1 to 1.2. Sorry, 1.2. And most participants, that is 64.8%, came from the rural areas. Our participants, we followed them up retrospectively for a total of 177.3 person years. So from the baseline characteristics continuation, we noted that majority of our participants, that is 60.6%, presented with the tumor group 3. And according to this, these are patients if you are in the orbit and after surgery, there is residual tumor, then we are grouped as group 3. And then combination of late disease, that is group 3 and group 4, also took a bigger percentage of approximately 73%, with the most common histological subtype being embryonal with 59%, followed by alveolar. And then the list, some of the samples had not been classified, so that those took about 14.10%. So in the outcomes of children, at the end of our study, 30 participants were alive, while 57.8 of these participants had died. Of those who were alive, we had only 11 patients who had been declared cured. However, these 11 patients, 4 were alive, but on treatment and without disease. And 6 patients were on treatment but with disease, while 2 were not on any treatment. They were still home. They had not yet come back to hospital to follow up. So 9 of our patients were lost to follow up, and 59.2 had disease progression. We note that about 69.0% of our patients had defaulted treatment. However, on calling them or reviewing the files, we noted that 13 of these patients had returned, and our abandonment rate of treatment was 50.7%, which is an issue that is cross-cutting in the UCI, in the cancer department. So using the survival analysis, the Kaplan-Meier, we noted that out of the 71 patients that were followed, 42.2% were alive at the end of the study, with a median survival time of 2 years. And the 3-year survival and 5-year survival was 44.2% and 42% respectively. So we also continue to do survival analysis comparing secondary orbital tumor. This is to say that there are some patients who had an origination of the, in our study we included those patients who also had a primary orbital tumor and those who had secondary orbital tumor. Having a secondary orbital tumor means that the tumor is from either the nose, the head and neck, and then it migrates, especially the nasopharyngeal, and then it migrates to the orbit. And the orbit is not the primary side. So we noted that those with secondary orbital tumor had significantly reduced survival probabilities compared to those without, with a median survival time of 1.5 years versus the 4 years of those with primary orbital tumor. So using the Cox regression analysis, we were able to get the adjusted hazard ratios for the variables that in the bivariate analysis had p-values of less than 0.2. And then we set our level of significance at 5%. From this, in the multivariate analysis, we noted that participants that were aged between 3 to 6 years had a 70% higher probability of survival than those that were less than 3 years. Similarly, those between 7 to 14 years had a 74% higher chance of survival than those less than 3 years. Also, when a patient came and their symptoms were, they complained of symptoms of more than 6 months, they had a 76% higher chance of survival than those whose symptoms were less than 3 years. This is kind of controversial from what literature says, but according to our setting and the way that we know that most of our patients came with embryonal rhabdomyosarcoma, which is aggressive and it grows fast from literature. So in case a patient came later, we think that this patient's tumor was less aggressive than those who came earlier. And this may be due to different personal characteristics of the patient. We are yet to go deep into this to understand it. So we also noted that patients who had primary orbital tumor were 63% more likely to be alive at the end of our study compared to those who had secondary orbital tumor. And also all those patients with no disease progression had they had a 6 times chance of reduced death than those who had progressed disease. So in conclusion, we note that our 3 and 5 year survivals are well low compared to the goal of the Global Initiative for Childhood Cancers that aims at a 60% increased chance of survival by 2030. This may show gaps in the care and management in our setting, but also if we note that most of our patients had advanced disease, and then also we note that about 50.8% of our patients had disease progression. This may have contributed to the poor survivals. Also, we note that there is a stepwise increase or chance in survival as a person, stepwise relationship between age and reduction of risk. That is 3 to 6 years, 70% reduced risk, and 7 to 14 years, 74% reduced risk. And this may be due to the fact that different children have different characteristics that we don't know. But then also we think that for children who are less than 3 years, the toxicity of the drugs may also affect them, and yet we've not yet personalized protocols of the treatment stratification so that we can help them and they reduce on the drug toxicities. And then also we have to note that though it is not included here, most of our local control was poor, or a few of our patients received the multimodality therapy. Out of the 71 patients, only 14 patients had received surgery, chemotherapy, and radiotherapy. And we have to know that for orbitorhabdomyosarcoma, what can increase the survival of the patient is the multimodality therapy from literature, and this means that we need to do local control. Because if this tumor spreads away from the orbit or away from the original site, the chances of survival, if we don't use aggressive treatment, decrease. Also, we know that the patients, from conclusion, better survival was noted for patients who had primary orbitorhabdomyosarcoma versus those with secondary orbitorhabdomyosarcoma. So we recommend that efforts should be made towards rapid diagnosis and recognition of these children with orbitorhabdomyosarcoma, because we know that from literature in the developed countries, survivals are up to 100%. So we wonder why our survivals are less than 50% or less than 60% that is set by the GICC. So if we improve on our early detection and diagnosis and also make efforts in local control, I think our survivals will increase. And then also we need to have a discussion between different teams and come and understand what the root cause, that is what is causing our patients to default in the treatment. Because there are different successes of children who had their treatment and they are very well. And from literature, we know that now if we get if we diagnose the child early, we no longer have to do an exenteration. We can manage the tumor and the child can stay with their eyes and their eyesight. So I want to appreciate Uganda Cancer Institute, the administration, the nurses, the records personnel for having made my stay there as I was doing the research very comfortable and good. And then also Makerere University, the Department of Ophthalmology, my lecturers and mentors, Dr. Titi Juliet, Dr. Mpaire, and Dr. Lusobia, and Dr. Imi. And then also my supervisors, and also to appreciate my colleagues that were with me in class, because they covered me some days as I was collecting my data. And lastly, I appreciate SIOP for giving me this opportunity to disseminate my findings. Thank you.
Thanks, Elizabeth. Can I ask you, considering your local control rate was so low, what was the specific reason? Did you interrogate why only 14 of the 71 came to surgery and radiotherapy? Because you had a big group of group 3 orbits, right? What were the reasons that the local control rate was so low?
Okay, thank you so much for that question. I think we basically went back into history. We reviewed the files, and it was not well stated as to why patients did not have surgery. However, just recently, that is about 2016, that is when Uganda Cancer Institute was able to get an ophthalmology oncologist. So I think before 2015, the surgeries were less because they did not have the manpower, and with the too much population, one surgeon may also be overwhelmed.
Thank you. Are there any other questions? Yes, doctor from Uganda.
Thank you very much for that wonderful presentation. I think I'd initially introduce myself. I'm Victoria, and I'm an oncologist from Uganda. One of the things that I want to say is a comment, and I think it could answer what Dr. Hendrik had just asked about. Why is it that the rate of local control is quite low? Because if you look at studies, orbitorhabdomyosarcoma the orbit is a favorable site, and embryonal is actually a good histology. So you would expect that for patients with primary orbital rhabdomyosarcoma, the survival should be much higher and the outcomes should be better. But we have noticed that among our patients, the acceptability for local control is still low. The idea of taking out an eye, and before we did not have prosthetic features, now they are available in Mulago. So I think if you liaise with the ophthalmology department, they are able to get. So the acceptability is getting better. But also because you know that the radiotherapy in the eye leaves other complications. You know, they keep on getting irritation and so many other things. So the acceptability for both those measures has been a bit low, and it takes a bit of convincing to get patients to accept to get an eye out and also get their radiotherapy done. Thank you.
Thank you. Just to respond to the first part of your comment, I mean, albeit that the orbital site is good and that embryonal histology is more favorable, that's still predicated on getting all the necessary modes of therapy. So it doesn't follow that if you're an orbital embryonal tumor that you can forego radiotherapy if you still have post-operative residua. The radiotherapy should still be offered, but you are correct. If you only have external beam radiotherapy for an orbit, then there are complications that can follow, both with asymmetry of the face and with especially dryness of that eye, which can really cause very horrible irritation. Any other comments or questions? All right. Thank you so much.
Thank you so much.
So our last presenter for this session will be Dr. Brenda Malone, and she's going to discuss the feasibility of staging and estimating outcome according to the Toronto Pediatric Cancer Guidelines for 3 childhood cancer types. Thank you so much. Careful.
I didn't know. Oh, that's nice. Thank you. Good morning. Thank you for stressing me a little bit more by not having my... Anyway, it's good. So this morning I'm going to present the feasibility of staging and estimating outcome according to the Toronto Pediatric Cancer Stage Guidelines for 3 cancer types. And this was a study that was run in 7 sub-Saharan African countries, and it was work by the French African Oncology, Pediatric Oncology Group known as the GFAOP. So, not that one, this one. Okay. So I just thought firstly we'd look at why cancer staging is important, and it was particularly important for our group because we're a young, very young, dynamic group of pediatric oncologists. So to know that staging determines the prognosis, it's based on the size and the spread of the disease, and it helps clinicians establish treatment planning. So in the case where we've accurate documentation, this does help for registers so that this information could be used on a national scale, but also on an international scale. And it's also important to know that the proportion of children who are diagnosed with advanced disease is actually a key measure of the burden of cancer in the country, and this information is important for cancer planning on a national basis. So I'm not sure if all of you have heard of the Toronto Pediatric Cancer Stage Guidelines, because it was a consensus that was started in 2018, where a group got together and came to this consensus. And these guidelines are actually used for registers, for national registers of cancer. And they collect data on 15 different major childhood cancers. So all children are diagnosed taking into account the extent of metastasis in the child. And also it is a 2-tiered system where the establishment of a tier 1 system is for centers that might have less resources. And then the tier 2 system looks at the extension of the disease, but it requires more information on the extension of the disease. Sometimes it's also looking at genetic information. However, if all information is not available for tier 2 staging, it can be dropped back to tier 1. So that's an important part of that system. And underneath you see the link if you want to have more information about the guidelines. And also there are two major articles that have come out, but the names to keep in mind if you're looking for them are Atkins and Gupta. So if you're looking on, and you find most of the information on the WHO site. So this data hasn't been used yet. We do hope to publish, as you can see. So the objectives of this study, firstly, we wanted to identify in our group if it was possible to divide into the 15 different groups our population. So we also wanted to assess the feasibility of allocating this type of staging in our setting. And then looking at the possibility of implementing the tier 1 or the tier 2. So we wanted to see whether our data actually was available for tier 1 and tier 2. And then finally, to look at the feasibility of estimating survival, we decided to look at 3 of the main cancer types, so identifying those cancer types and then looking at it based on the tier 1 and tier 2 setting. So how did we go about all of this? Basically, the GFOP is in 18 different countries, but because of data collection and quality and the time that we were looking at, we chose 7 of these units, which are actually 7 of our bigger units. So data was collected from January 2017 until December 2019. All children who were identified less than 18 years of age with one of the 15 cancer types. So confirmation of diagnosis was done based on clinical and imagery, histological, cytological, and hematological examination. What's important to note from our data was that we were not able to stage 4 of the 15 cancer types. Why was this? Because even though we have a lot of data, and we're over 300 children that were in this data set who had all acute lymphoblastic leukemia, we could not classify them because of our staging. Our staging is based on the age of the child and risk factors. So the same is said for brain tumors. We only identified 16 brain tumors in the whole data set, which is very, very few, obviously. But we were not able to classify them, basically because CNS involvement was not, we did not know, and we didn't have histological information on that. So that for us was very important to identify on that information. So how did we look at survival? Survival, the data, if we had the date of diagnosis, but if we didn't, we took the date when chemotherapy was started. And dates of follow-up, we needed the 2 dates, obviously, to estimate the survival. And also, when we started doing the registers, we asked people to give us information at 12 months, but obviously later on, as time went on, we kept on asking for more information and if we could have better follow-up. So we continued following up the children, and we're hoping to continue just until 5 years, but for this study we went as far as 3 years. So vital status was considered as dead or alive. So this shows on the cancer, the first column, you can see the 15 different types of cancers that are selected for the Toronto staging, and you can see the 11 that were involved in this study. The tier 1 shows you, in the second column, you see the criteria for putting children that are of one of the 11 cancers, how we put them into the different categories. So it's localized or metastatic disease for the majority of tier 1 staging. And for 4, I think it's localized and regional with metastatic information. And you can see from that also the tier 2 gives you're required to have much more detailed information. However, it's important to say that for certain tumor types, it's exactly the same staging for tier 1 and tier 2, as you can see for the non-Hodgkin's lymphoma and also for bone tumors. So here we get to our results. So there you see the 7 different centers that were chosen. I think it's important also for us to say that most of our centers are quite young centers that were started collecting data with us in 2016. So from the 7 centers, we collected data on 1,619 children who had a diagnosis of one of the 11 cancer types. So the sex ratio was 1.3 males to 1 female. And the mean age was 6 years with a predominance of children from the 0 to 4-year age group. So 49% of children were in that age group, and 12% of children were in the less than 12-month group. Also, what's important here is that 77% of the population studied were Burkitt's lymphoma, Wilms tumor, and retinoblastoma group, with Burkitt's lymphoma 30% of the children. And this looks at the 11 cancer types on the first column, and then the number of cases that went into each group. And you see on the T1 the number of children that we were able to put into that staging. So 90% of retinoblastoma were in the T1, and Wilms tumor 95. So Wilms tumor, it was a localized disease, metastatic disease, and the same for retinoblastoma. In the tier 2, Burkitt's lymphoma, 93% of children were in the tier 2 group. And the group that had the least, the poorest staging system was in the Hodgkin's lymphoma with 66%. What also it's important to say is that 8% of children were not staged because we did not have data, but it's quite a few, and 91% then of children were classified. So this is our survival, which is one of our aims of this project. And if you remember, Burkitt's lymphoma, we did a tier 2 staging, so it looks at stage 1, 2, 3, and 4. 91% of children were either stage 3 or stage 4. I asked the French register for the same period of time how many children are stage 3 and stage 4. So 64% of the French registry of children with Burkitt's lymphoma are stage 3 and 4, compared to our group, which is 91%. So there's a huge difference. The mean follow-up was 11 months. This, even if it is significant that there is a difference in survival, it is not significant on this. Now, why is that? We were sort of disappointed with our results. However, I think one of the things is that we don't know what the treatment of these children, we know that they were treated, but we don't know if they got full treatment. Our question is, treatment started, yes or no, that's all we know, but we don't know how many. We know that there's 20% dropout, abandoned, but we don't know whether they got all of their treatment or not. So that will be studied, I think, in more detail, and it's important to note. So looking at Wilms tumor, 36% of this group were stage 4 disease. We had data, follow-up data for 87% of this group. And this is significant. there is a very significant difference between localized disease and metastatic disease, with 64% for localized disease, which is very good for our group to know, and 42% for the stage 4. And looking at the retinoblastoma, if you remember the stage, this was a tier 1, so they were staged into localized, regional, and metastatic disease. With very few regional children with regional involvement, which was surprising for us to see that as well. 29% of this group were stage 4 disease. And here our survival is very significant, with a 71% survival for localized retinoblastoma, and stage 4 is 32%. So there's 71% with information for follow-up in this group. I think it's important also for me to say that those 3 tumors are actually tumors that the GFAOP group works very hard with each center to have treatment programs and also to try to have medication for those children. So to summarize, 31% of diagnosed cases were not able to be put into the Toronto stage system. So they included the all and the 3 brain tumors. 77% were Burkitt's lymphoma, Wilms tumor, or retinoblastoma, which is a huge part of our population. So basically, the Toronto guidelines are possible for our group, but for 11% for 11 types of cancers and not the 15, with 55% of tier 1 and 36% of tier 2. This is, for us, it was very important to get into staging and to get into the idea of staging, so that was important for us to have these results. We also showed that staging is a predictor of survival in our group, with 70% of survival at 18 months for the Wilms and retinoblastoma. However, I think a longer collection of data for a longer period of time, and also to look at the treatment that these children got, which is not always possible in registers. So the studies are being put in place to look more closely at that. I think it's also important to say there's a lot of work that has been going on to improve data collection
with a project called Benchista, standing for International Benchmarking of Childhood Cancer Survival by Tumor Stage. So it's really important at a population level we understand the basis for variation in outcomes in Europe, and we think a lot of that might be due to more advanced disease, but we can't prove it at a population level, so that's what our project will do. And I'm really pleased to see that the GFAOP network is doing this with their hospital-based registries, because we're all trying to start somewhere. Yeah. So I suppose my question to you is the process to apply Toronto staging to those, I think I wrote it down, a large number of children, over 1,000. Is it sustainable? So will those centres be able to capture Toronto staging prospectively on all the relevant patients? Or do you think every time you want to do it, it'll be a big effort to get the data?
Well, what we're doing at the moment is that the centres register the staging, that is, and they're downloading the reports that have brought them to their decision on staging. We're not asking them to actually put into the Toronto staging. After they come to the database, the centre, and we actually, with the help again, we have Eva Steliarova, who's been very helpful, and Jacqueline Clavel. And their suggestion was to actually do that at our level. So we get the information. If there's any query, then we go back to the centre and we get more detailed information. And then we actually do the staging at our level.
Okay, but do you have a plan to try and train the centres to do it themselves? I mean, and are you using that CAN staging tool that's been developed online?
No,
with
we have no.
Joanne Aitken?
No, we're not using that, but that might be something that we can have a look at.
Yes.
The idea is not to get the centres to do the staging. The idea is that we would do the staging, but why not? For the moment, that hasn't actually been discussed because we're really assessing our feasibility. We're still at the feasibility stage.
Thank you. Once again, thank you to all the speakers. Please show your appreciation for them again. And I hope I've delivered on my mandate as chair to get you to tea on time. It is now 10:20, so please enjoy your tea and coffee. Thank you so much.
Hello. There we go. Good morning. Sorry about the delay, guys. Just a small problem with the microphones. Welcome to session 2 of the final formal day of SIOP Africa 22. I hope you're all enjoying the meeting. It's been absolutely fabulous so far. And we have a very good session on targeted therapy coming up. I'm Alan Davidson from Cape Town, South Africa. And my co-chair will introduce himself.
The most common neoplasm in our hospital, followed by brain tumors, neuroblastoma, Hodgkin lymphoma, non-Hodgkin lymphoma, and bone tumors. Again, this is our 5-year overall survival with around 71.27% for all types of malignancies. Cancer in children is one of the success stories, as overall survival for acute lymphoblastic leukemia at Central Hospital was less than 10% in the 60s, and now it exceeds 90%. Again, earlier, chemotherapy, radiotherapy, and surgery were the only tools to treat cancer. Now, and thanks to the advances over the past 10, 15 years that increased our understanding of mutational and phenotypic diversity of tumor cells, again, sequencing studies culminated in identifying many signaling pathways that are crucial for tumor cell growth, enable us to tailor treatment according to the patient's own mutations. And I believe in the future, there will be no one size that fits all. In this figure, deregulated signaling pathways in a Philadelphia-like acute lymphoblastic leukemia, and it includes the JAK-STAT pathway, the ABL pathway, RAS signaling, FLT3, NTRK, and FGFR. Again, immune phenotypic targets on the cell surface of the B cell may include CD19, CD20, and CD22. And immune targets on the cell surface of the T cell may include CD2, CD5, CD7, and CD25, while CD38 and CD52 are co-expressed on both T cell and B cell acute lymphoblastic leukemia. Blinatumomab is an anti-CD19 bispecific T-cell engager with an antibody-dependent cellular cytotoxicity. Again, it is mainly used as a consolidation for patients with high MRD post-induction, again, for relapsing CD19 patients with acute lymphoblastic leukemia. And in a COG study number 1331, with the objective to determine if substituting blinatumomab for intensive consolidation chemotherapy can improve outcome. And it included patients under the age of 30 with first relapse with medullary or extramedullary, and patients with Down syndrome, Philadelphia positivity, prior transplant, or prior blinatumomab were excluded. Patients with a higher risk of relapse, that's to say, patients with early relapse and or patients with late relapse, but having a high MRD at the end of reinduction, were randomized into patients who received 2 cycles of consolidation chemotherapy and patients who received 2 cycles of blinatumomab. And those who went into a complete remission were bridged to bone marrow transplantation. And as you could see here, patients who received blinatumomab had a better disease-free survival and a better overall survival. Yet it did not reach statistical significance, and they attributed that because the study was underpowered. Again, another monoclonal antibody, inotuzumab, that is anti-CD22 drug conjugate that is linked to calciamycin toxin. And in a study, in a COG study, phase 2 single-arm study, they used inotuzumab for patients with primary refractory or relapsing, heavily pretreated acute lymphoblastic leukemia patients. And patients who went into complete remission were bridged again to a transplant. And as you could see here, the event-free survival was 28%, and the overall survival was 38% for this very poor risk group. Patients who went into a transplant had a higher probability of contracting veno-occlusive disease of the liver. BCR-ABL tyrosine kinase inhibitor acts by blocking the ATP binding site for BCR-ABL fusion protein. And since their introduction in the treatment of Philadelphia positive acute lymphoblastic leukemia, they nullified the need for consolidation allo-BMT. And as you could see here, when tyrosine kinase inhibitor plus chemotherapy were compared with bone marrow transplant, whether related or unrelated, there was no statistical significance regarding the overall survival and event-free survival, with an overall survival of around 70% and event-free survival of around 60%. Again, at the Children's Cancer Hospital, 140 Philadelphia positive ALL patients were included. 48% received imatinib plus chemotherapy, and 52% received dasatinib plus chemotherapy. 16 out of the 140 patients received an allograft, and our overall survival was 70.4%, and our event-free survival was 64.4%. Again, when imatinib was compared with dasatinib, there was no statistical significance regarding the event-free survival and overall survival. However, if we are going to continue using imatinib with chemotherapy for Philadelphia-positive acute lymphoblastic leukemia, one should intensify the CNS-directed therapy because imatinib does not cross the blood-brain barrier. Moving into acute myeloid leukemia, tremtuzumab is an anti-CD33 drug conjugate that is linked again to calciumycin toxin. And as you could see, it has been shown that it improves the event-free survival and reduces the relapse rate for patients who are belonging to low risk or intermediate risk acute myeloid leukemia. And it is becoming a standard treatment in the new COG trial. Again, sorafenib, when used for FLT3 ITD positive patients with high allelic ratio, it improved the event-free survival, but did not reflect much on overall survival, and it was coupled with cardiac toxicities. And now COG is trying a new generation of anti-FLT3 that is gilteritinib, yet the results are still awaiting. However, when sorafenib was used on adjuvant basis post-allo-BMT for FLT3 positive patients, it improved the relapse-free survival and overall survival with very high statistical significance. And I believe in the near future it will become a standard of care for patients who are undergoing bone marrow transplant. Rituximab is an anti-CD20 monoclonal antibody, and in a study that was published in the New England Journal of Medicine, it was shown that rituximab improved the event-free survival and overall survival for patients who are belonging to Group C and high-risk Group B. And to improve the outcome of our patients at the Children's Cancer Hospital, we started using rituximab plus LMB chemotherapy for patients with Group C and high-risk Group B. 52 patients were belonging to Group C, and 40 patients are still alive and 10 are dead. Again, 26 patients were belonging to Group B, 23 patients are still alive and 3 are dead. We don't have survival curves for this group of patients because the observation period is too short. Brentuximab vedotin is an anti-CD30 monoclonal drug conjugate that is conjugated to the microtubule disrupting agent, and its main indication is for relapsed refractory Hodgkin lymphoma. Again, it could be used on adjuvant basis post-auto-BMT. When used with chemotherapy, one would expect a metabolic complete remission that is ranging between 65% and 80%. Again, a progression-free survival between 60% and 70%. Rituximab, as I said, could be used on adjuvant basis post bone marrow transplant. And as shown in the ATHERA trial, brentuximab adjuvant treatment improved the progression-free survival for patients who are having a primary refractory disease, patients who had a relapse within the first 3 years from diagnosis, and patients presenting with an extranodal disease. At Children's Hospital, 47 patients received brentuximab with chemotherapy as a second line, third line, fourth line, or even after bone marrow transplant. Again, this is our overall survival of 64% and our event-free survival of 33%, keeping in mind that some of the patients received brentuximab as a fourth line. When compared patients who received an auto transplant versus those who did not receive an auto transplant, patients who received an auto transplant had a much better event-free survival, yet there was no difference regarding the overall survival. There is no statistical significance between patients who received stem cell transplantation versus those who did not regarding the overall survival. Moving into neuroblastoma, denotuximab or anti-GG2 immunotherapy is an antibody that is having an antibody-dependent cellular cytotoxicity, and it can fix complement. And as shown in a study that was published in the New England Journal of Medicine, addition of anti-GG2 antibody and GM-CSF and interleukin-2 can improve the event-free survival and overall survival for high-risk neuroblastoma, and is becoming like a standard of care. Again, for soft tissue sarcoma and bone sarcomas, radiation therapy, surgery, and chemotherapy are still the mainstay of treatment up till now. Yet, one can target angiogenesis, tumor microenvironment, epigenetics, DNA repair, sustained peripheral signaling, and or cell cycle progression. And there are many targeted therapeutic agents that may include mTOR inhibitors for sarcomas and subepidermal giant cell astrocytomas in tuberous sclerosis. Again, anti-MAG in plexiform neuromas, or anti-BRAF for melanoma, LCH, or gliomas, or anti-ALK like in ALK-positive neuroblastoma and inflammatory myofibrotic disease. However, targeted therapy is not without challenges, and among the challenges, the turnaround time, obtaining an adequate tumor material, the rational combination of targeted therapies with chemotherapy and or with other targeted therapies, again, defining the pathogenic variants in the pediatric population, ethical challenges of germline mutation, again, the unknown downstream effects of our targeted therapy, and the relative paucity of mutations as well as molecular alteration compared to that in other cancer. However, the most important thing up to me is cost, and every effort should be made to make these very valuable targeted therapies available in this area of the world. And coming to this end, I would like to stop here and thank you all for your attention. Thank you.
Thank you very much, and we'll ask Prof. Al-Haddad to stay on the line until the end of our session. So the next speaker, a compatriot of mine, Jennifer Giel, is an adjunct professor of pediatrics at the University of Witwatersrand and head of the Pediatric Oncology Unit at Charlotte Macleake Johannesburg Academic. I won't list her many contributions to SIOP, not the least of which is an enormous amount of work for this meeting. But importantly for us this morning, she's the national PI for Hodgkin's disease in South Africa. And she's going to talk to us about a case series this morning.
Must I use the on button?
You're good.
Okay. So I must just warn you, halfway through a talk, I seem to lose my voice at the moment. So don't get too disturbed. So the topic of my talk was a case series, but I realized as I was doing it that was actually too boring for all of us. So I've decided to give you the benefit of some of the South African experience, just so that you can see if there are things that resonate with you, if there are things that you think you might need to learn from, if there are things that you would like to argue with me about. I've got no relevant disclosures. But I must admit that I'm not an expert on targeted therapy. I'm just a very interested person. And I will only be discussing drugs, so I won't be discussing things like MIBG and any other surgical techniques, etc. So I'll take us back a few years. We have the dubious honor of having been led by a man called Thabo Mbeki. So Thabo Mbeki was our second president post-democracy. He was a highly intelligent, well-educated man. He'd been all over the world getting postgraduate qualifications. And at the time that he came into political power, he was well respected. He was seen as a worthy successor to Nelson Mandela. But he had one big problem, and that was that he did not see the link between HIV and AIDS. He thought that HIV did not cause AIDS, it was rather poverty, environmental factors, etc., etc. And he didn't have the scientific background that we have to try and explain it, because a lot of it actually does make some sense. But the things that he did were criticizing the scientific consensus that HIV causes AIDS. He then instituted policies denying antiretroviral drugs to people with HIV. Then there were clinics that had managed to access drugs as donations, so he withdrew support to those clinics, and he even prevented mother-to-child transmission of HIV using nevirapine. And this obviously had a huge effect in letting the pandemic really take hold in our country and flourish. So what did we do as a medical community? We were not mighty enough to go against the government, but we had our own strengths, and one of those was science. We started academic trial centers whose entire reason for being was to run trials on antiretrovirals and to get people onto treatment. So South Africa really helped to push forward the science on ARVs, but the major secondary gain was that we got lots and lots of people onto treatment. So my first job when I finished training was at a place called the Diana Princess of Wales HIV Research Unit in Somerset Hospital in Cape Town. It's just down the road from where Alan works. And the people who ran this unit were very canny. So Princess Diana had died just recently. There was a lot of positive feeling attached to her name, and they quickly named the unit Princess Diana, and they got lots and lots of donations. And it was highly successful. It was later named the Desmond Tutu HIV Centre because he was now far more popular in the public eye. But one of the important things that also helped was that Nelson Mandela, who was still alive and well and very well respected at that point, actually aligned himself with the HIV access movement. And there's a famous picture of him with Zaki Ahmed, who's a well-known HIV activist. And the shirt just says HIV positive. It doesn't say I'm with him or I'm not HIV positive, but I support you guys. It just said HIV positive. And he was trying to help break down the stigma of HIV. So that's something similar to what a lot of our kids deal with the stigma of having cancer. The current situation, we now have 7.7 million people living with HIV, and our HIV prevalence is 20%. It's a really high number. But we've met the first of the 90-90-90 targets, and 90% of people living with HIV are aware of their status as of 2018, and the other two targets are to have 90% of them on treatment and 90% of those virally suppressed. So we're actually, from having been such a worldwide embarrassment, we've now become a beacon of hope for HIV. We have the world's largest antiretroviral program, and we're the first country in sub-Saharan Africa to fully approve pre-exposure prophylaxis, which is now available to people at high risk of infection. So let's talk about targeted therapy. Targeted therapy to many people is the new kid on the block. It's the kid who's never going to get onto our block. It's a far-off dream. But it's really the result of the last 100 years of research. And this research has been dedicated to trying to understand the differences between cancer cells and normal cells. Conditions that may benefit from targeted therapy in children, there are many, but I'm just going to highlight some of them. Leukemias, lymphomas, neuroblastoma, and I mean, if any of us could get something that cured neuroblastoma, we'd be extremely happy. I hate this disease. Many different kinds of brain tumors, including low-grade gliomas, sarcomas, and many rare tumors. So if you think about that, that's a good proportion of our work. If you do a search for targeted therapy for children with cancer in Africa on PubMed, you'll come up with a grand total of 13 publications. If you go through them, you'll find that only one is relevant. So there is just about nothing published on this topic in our continent. So maybe if I'd used different search terms, very specific search terms, I would have found a few more. But there's nothing that looks at the overall approach that we need to start getting used to. In South Africa, as I've mentioned before, we have a fairly well-run state sector and a well-run private sector that caters to a very small proportion of our population. So we do have the basics. We've got imatinib, rituximab, we've got sirolimus, we've got everolimus, and I think there are a few more running around that are kind of intermittently available. In the private sector, we have the same, but we also have brentuximab, pembrolizumab, dasatinib, nilotinib, dinutuximab, and vemurafenib. And again, there are more that are in use. I'm just picking up the most commonly used ones. And then we've got this new arm of access, which is targeted therapy available via clinical trials. So this is very similar to what we did with HIV 25 years ago. So currently we've been approached by drug companies to run trials on pembrolizumab, lenvatinib, carfilzomib, blinatumomab, and ribociclib. So those cover, again, a large number of patients with relapsed and refractory diseases. Here's another way that people can access targeted therapy: crowdfunding. Now, I have many ethical issues with crowdfunding. So just as a short explanation, it's normally hosted on platforms that take a percentage of the income. So you put your sad story up, you talk about the disease, you put a photogenic picture of a child with cancer, and then the platform like BackaBuddy or Do It for Charity or something like that, they take a percentage, and it's normally about 10%, sometimes more. So there's no incentive for them to check that the medical story that's put on the platform is true or is feasible, whether this is a good child to fund, or whether it's a last-ditch, no-hope case. And what we've seen in our practice is that it is often a last-ditch attempt. So we've exhausted all the conventional means of chemotherapy. We've done everything we possibly can, including transplant, referring to other people, and then they hear about something in a trial center in Rome, for example, and they try and get their kid in there. So crowdfunding, it would not have worked 20 years ago because we didn't have social media. So you really put out massive calls, and you have to be very canny in the way you do it, and you have to be very, very active. You can't, drop your story and walk away and come back a week later expecting to have gone viral. It doesn't work like that. And then there are ethical issues with it. So the things that I have identified as problems are, one, you're getting a community to focus on one child. And it's often a photogenic child living in a happy family. And in our context, it's almost always white patients. We hardly ever see black patients having crowdfunding done for them. The second thing is that they often have incurable conditions, but the people who are giving money don't know that it's incurable. They just go, oh, shame, I want to help this child. I'm just going to give the little bit that I can. And they give 100 Rand or 1,000 Rand or 10,000 Rand or whatever. And that money often goes to waste. So these people spent months and months on the internet. And they photographed this child in every single situation, and that I also have a bit of an ethical problem with, because yes, you're trying to save her life, but you are exposing her to the public gaze in a way that she doesn't always know to consent to. And in the end, of course, this child died. So the family had raised the equivalent of $1 million, gotten the entire community, which was a really, not a very wealthy farming community around them, to all give their support, and then she died. And what does that do to the community's confidence in the healthcare system and in the doctors? You know, they kind of think, shame, childhood cancer is too scary, I'm not ever going to engage with that again. Oh, sorry, now how do I go back? Right, so then there are pharma-sponsored trials, which also have their own ethical issues. The first one, which I think we're all very aware of, is the issue of recruiting African patients to clinical trials for agents that will not be available in their populations. What we did in the HIV era was that we negotiated very hard. We said, if you don't have lopinavir and ritonavir, and you're not selling it in South Africa, but you're using South African patients to get this drug registered, you will provide that drug to these patients lifelong, or at least until it becomes available at a reasonable price in our country. So if we do this kind of thing, we have to be very assertive about how we negotiate with these pharma companies. The next thing is that there's no such thing as a free lunch. Pharma companies will promise you the earth, but you will sell a little part of your soul to them, because they are in it for money, we are in it to save lives. And when we mix the two, there's going to be a little bit of blurring. People are concerned that you might be diverting attention from more important issues. So should we not focus on the fact that we're still not diagnosing patients? We still have poor diagnostics. Doctors and nurses out there still don't know the early warning signs. Why did I put that in yellow? Oh, it was also, yeah. So we don't want to take away, if we bring in these agents, we don't want to take away from the existing projects that are running parallel. And the other things that could be upset by introducing a new modality of therapy are having sustainable sources of drugs and insufficient staffing. Thank you. And then the other big thing is that you can't run a clinical trial without a huge amount of effort and staff. It's not something you can do on the side effectively. You know, if you want to do one patient just to give access to that one kid, that's one story. But if you want to actually run a clinical trial program, you need a place, you need people, you need IT, you need infrastructure. And that's just, you know, what I can think of off the top of my head. So if it's such a hassle, why do we need to know about it? Well, the thing is, it's considered standard of care in high-income countries now for many diseases. So if any of you are thinking of emigrating, you're going to look like a bit of an idiot if you go there and can't talk with us about this stuff with confidence. Alternatively, if you're going to refer a patient to another place that has this, you also need to know about it, because your parents and your kids will come back to you and ask you the questions. And you can't just say, oh, I don't know, they do that in India, ask the doctor over there, because you are their primary physician, and they need to have confidence in you. And the other thing I think that's important is that it gives hope. So I put this survival slide on yesterday, and I feel like I can't put it on enough. We have to be part of the movement of raising survival rates. 50 years ago, the survival rate was just about nothing. It was raised through research. So we could argue it was raised using the modalities that we have available now, absolutely. But what's stopping us from improving the standards using what we've got now and trying to include targeted therapy in a strategic manner. The main barriers to wide rollout are obviously cost. It's wildly expensive. The cost is both to the patient and to the system. And then it's expensive for the company to bring the agents in if they want to register it in that particular country. I think what holds a lot of us back is fear of the unknown. So a few years ago, we would talk about anti-GD2 therapy and we'd say, oh no, it doesn't work, it doesn't raise the survival rate, it's really too scary, it's so toxic, you have to give them analgesics while you give them the infusion. And then we began to see the people around us giving it. And everything was fine, there was barely a ripple. And we discovered, yes, we can actually do it in our community, and if they're doing it, why don't we do it too? The other problem is that the regulatory wheels move extremely slowly. It's very hard to get a new drug registered, I think, in most countries. You do need a certain level of infrastructure. So you can't do it in a place that is mixing pediatric beds with adult beds or cancer beds with other pediatric beds with rotating nursing staff and no dedicated medical staff. And then the other big thing is that there's a lack of data in African settings. So what are we going to do because the data isn't there? If we do any of this treatment, we have to create our own data. So I think we've got a responsibility to gather all this data together and to publish it and discuss it and disseminate it with our colleagues. If we were to bring in targeted therapy more widely in Africa, who would it benefit? Obviously the patients, that's the whole point. But it's generally patients with relapsed or refractory disease and their families, because obviously they want their kids to survive. It might benefit us as highly trained healthcare professionals because it might encourage us to stay rather than being part of a brain drain. It would benefit academic programs that attract top professionals. And it would benefit pediatric oncology units that need to be at a certain standard of competence and efficiency to use the opportunity to administer these costly options. So you can't just give this stuff anywhere, you have to actually be fairly organized. And then the other knock-on effect is it would benefit laboratories who identify the targets. So if you're in a place that doesn't have a laboratory that can identify the targets, there's pretty much no point doing targeted therapy. But if you work together with a laboratory, it could be introduced in parallel. The benefits of getting targeted therapy into Africa are often these agents have reduced toxicity. So we know that our patients have high levels of toxicity, and that's often the main cause of death, treatment-related toxicity. It might just help us increase survival rates a little, but as I alluded to earlier, we need to get the basics right first. It might help to decrease disparities between high and low income countries because, in my opinion, every time there's a new advance, the gap between us just gets wider and wider and wider. And then it may increase trust in the healthcare system because children could finally access modalities that have been out of their reach. If you're not rich and you can't afford R1 million, at least you can go down the road to the Uganda Cancer Institute and get your medication. The disadvantages of increasing access are, of course, cost. Many are still in the early stages, and we don't know what the evidence really is in our population. It might increase disparities rather than decreasing them. And we also know that when we try new things in our units, it often destabilizes the system for a while. So it has to be done very, very carefully. I think this is the last slide. So the future possibilities for increasing access are many, and I think they're far more than are on this slide. The biggest, most sustainable source of funding is always government. Compassionate use programs, which, even though it says program, it's generally on a case-by-case basis, so it's not easy to coordinate. you could set up hybrid trials, so not a pure pharma-sponsored clinical trial like a phase 3 or whatever, but actually a hybrid trial that's investigator-led, but the pharma company supplies the medication and works with you. Then the just purely pharma-sponsored trials, and this is probably a joke, getting targeted therapy onto the EML, but I'm just putting it out there. So thank you very much. I'm hoping that this talk gave you a lot of questions and things to think about. Thanks.
Thank you, Jennifer, for a wonderful presentation. I'll invite you to sit at the high table so that we can have the questions after the rest of the presentations. Our next presentation is from Professor Suzanne Turner, and Suzanne is a professor at University of Cambridge in the Division of Cell and Molecular Biology and Addenbrooke's Hospital, and she'll be talking to us today on the future of target therapies in lymphoma and the potential role of Africa during development. And Suzanne is the key collaborator with the Uganda Cancer Institute working on pediatric lymphomas, and I'm sure she'll mention some of the exciting work we're doing together at the Cancer Institute. Suzanne?
Thank you, Nixon. So good morning, everybody. First of all, I want to thank Dr. Joyce for inviting me to give a talk this morning. I hope you've all rested and suitably recovered from last night's gala. The UCI certainly know how to throw a party. I hope you all enjoyed yourselves. So I'm standing in front of you today, as Nixon said, as a professor of cancer cell biology at the University of Cambridge, but also as a member of the Uganda Cancer Institute family. And I say that because we really very much are working together with our shared goals to improve the lives of children with cancer. So I have no conflicts of interest to declare. And I'm going to start talking a little bit about a lot of what you probably already know. So, of course, most of the non-Hodgkin's lymphoma we see diagnosed in Europe and, of course, also in sub-Saharan Africa are endemic Burkitt or sporadic Burkitt lymphomas. And these account for about 50% of the non-Hodgkin's lymphoma that we see in both of those resource settings. Of course, there are differences, as you're well aware, and the biology and clinical reaction of these different tumors are different. And so, for example, when we look at endemic Burkitt lymphoma, we know it has very different clinical outcomes and very different biology to that we see with sporadic Burkitt lymphoma. And the differences don't stop there. So if we think about the incidences of these diseases, we actually see far fewer cases of a sporadic Burkitt lymphoma in higher income settings, and about 25% of these are attributable to Epstein-Barr virus infection, where of course we're approaching more like 8,000 cases of endemic Burkitt lymphoma, of which the large majority are attributable to EBV, particularly in malaria endemic regions, as you well know. And clinically, of course, the outcomes are very different. In high-income resource settings, we can achieve approaching 95% survival for our children. And in Africa, or dependent on the region in which we see these endemic Burkitt lymphomas, survival can range from anything from 10 to 70%. And that's largely perhaps accountable to the way we can treat these tumors very differently. So in high-resource settings, we can give a very aggressive, intensive chemotherapy regimen with a multitude of cytotoxic agents. And this can lead to children being in intensive care. It can lead to considerable side effects, which are things that can't be managed so successfully in low-resource settings. And so, of course, there, in lower resource settings, you use much reduced chemotherapy regimens. The problem we have more in the high-income world with sporadic Burkitt lymphoma are children that relapse or are refractory to disease. And so for these children, we really still don't know how to treat them. Survival is very low, it's less than 30%, and we have no way of identifying who these children will be at the start of therapy. So we have different problems in both cases. With sporadic Burkitt lymphoma, we're probably over-treating a lot of the children. And for these children, we need to think more about dose de-escalation, so removing some of those cytotoxics for the better prognostic treatment groups. But we don't have a way yet of identifying those children. We also have the problem that we don't really know how to trial novel agents in the populations in high-income countries, because when you already have high survival rates, you cannot risk removing any of the existing cytotoxics from that chemotherapeutic protocol and replacing them with a novel agent. So it becomes very difficult because we have to add these novel agents onto already existing chemotherapy backbones, which already have very good survival outcomes. In contrast, of course, with sporadic Burkitt lymphoma, in the case of endemic Burkitt lymphoma, a lot of the poorer outcomes may in part be due to late diagnosis, misdiagnosis, underdiagnosis, which also can be the case in high-income countries. But we perhaps need to look at things like dose escalation, so the exact opposite of what we're doing for children with sporadic Burkitt lymphoma. And I would argue that this is the better population for trialing novel targeted agents. If you already have lower survival rates, then you are better equipped to see improvements in survival with novel agents. And I appreciate all the issues that Jennifer just spoke about, but I think we really have to try and lead at the front there and make sure that we are ideally placing these drugs in the right populations. And so just to summarize that introduction, I hope you appreciate that lymphoma in children in Africa shouldn't be considered to be the same as lymphoma in children elsewhere in the world. And so we really need to conduct research to understand their unique genetics, their unique biology, and design therapies which are specific to this population, not just applying what we know from children in high-income countries. And of course, those therapies, I'm well aware, as I'm sure you all are, need to be adapted to these lower resource settings, whether that be drugs needing to be stored at room temperature, given orally, whatever the situations are locally. And so a number of targeted agents are being introduced into the treatment of children in lymphoma. From your previous talks, I see that some of these are now being used in Africa. But of course, we're also trying to bring these into the treatment of children in high-income countries. And actually, we're not too much further along than you are in this regard, in that we have struggled to engage pharmaceutical companies to persuade them to work with children with cancer. CAR T cells, of course, are an option. I won't talk about them any further, as I know that we have a talk coming up on that next. Small molecule inhibitors that was discussed earlier, so there are a variety of those, and you may be familiar more with things like imatinib for treatment of Philadelphia-positive leukemia, things like BTK inhibitors, which have been trialed to treat B-cell lymphoma without much success. And then, of course, the other immunotherapies, so the monoclonal antibodies like rituximab, which you're very well aware of, and then the antibody-dependent cytotoxicity mechanisms that go with that. And then, of course, our ADCs, our antibody-drug conjugates, such as brentuximab or anti-CD30, which is used to treat Hodgkin's and anaplastic large cell lymphoma. So for those of you who aren't familiar with these therapies, I've put together a very basic cartoon just to make sure we all understand where we are. And so, of course, B cells within the immune system express a protein called CD20. And CD20 is like a little flag that lights up on the surface of the tumor cells. It's also on normal B cells, but in particular it's on tumor cells. And rituximab, that monoclonal antibody, what it does is it recognizes that flag on the surface of the tumor cells and it marks them up. It gives an eat me signal so that the T cells of our immune systems can come along, recognize those cells, and eliminate them. In contrast, antibody-drug conjugates are slightly different. So they also recognize flags on the surface of cells. So in the case of brentuximab, it recognizes CD30. And brentuximab works slightly differently in that it has a mitotic spindle poison bound to the surface of the antibody. And what happens is when that recognizes the tumor cells, it gets internalized into the cell and sets off that mitotic spindle poison like a little bomb, which kills the tumor cells. And then we have the bispecific T-cell engagers. And what these do in the most simplistic form is they recognize those little flags on the surface of the tumor cells. They recognize the little flag on the surface of the T cells, CD3, and they bring them together to encourage T-cell kill of the tumor cells. So these are the bispecific T-cell engagers. And so rituximab, as you heard earlier, has been used very successfully to treat Burkitt's lymphoma and other B-cell-derived lymphomas in high-income countries. And so the trial in particular that was alluded to before was the INTER-B Ritux 2010 clinical trial. And this was a collaboration between a number of different groups in Europe, including, for example, the European Intergroup for Childhood Non-Hodgkin Lymphoma, for which I chair the biology, but also the Children's Oncology Group in the US, groups in Canada, Australia, and involved 12 countries across 292 sites. So a monumental trial. Of course, it was sponsored by the Gustave Roussy in Paris and also the Children's Oncology Group in partnership with Roche. And of course, what you'll all know now is that rituximab is off patent. So it's taken us a long, long time to get this drug from use in adults to use in children. But the results, as you were told earlier, have been outstanding. And so this is a slide that's been shared with me by Veronique Minard-Collin, who was chief investigator of the trial. And what you can see now with the 4-year follow-up data is that we're now at 94% overall survival, 93% event-free survival. So fantastic results from adding rituximab in. And this was 6 administrations of rituximab in addition to standard LMB chemotherapy backbone. And so this wasn't without its toxicities. Of course, when you're still using a cytotoxic backbone, you expect to have toxicities, but what we didn't know was if rituximab would make them worse. And what we actually see in these children is an increase in the incidence of acute infections, particularly enteritis and adverse events of grade 4, but fortunately no increase in toxic deaths. And so this trial led to the approval by the European Medicine Agency for the use of rituximab for the treatment of children with B-cell non-Hodgkin lymphoma. So it took a long time to get to this point. So even in high-income settings, we struggle to engage pharmaceutical companies to make sure that we can use these drugs clinically. Of course, rituximab is now being used, as I've heard a lot through the course of the past couple of days, in sub-Saharan Africa and above the Sahara. And in particular, at the Uganda Cancer Institute, we have a trial running with rituximab with the Fred Hutch Institute in Seattle. And there is one arm to this trial which is yet to commence, where children will be receiving rituximab in the form rituximab hyaluronidase. And we very much look forward to seeing the results of that study. Where are we going in high-income countries? Well, the next trial we are working on is called GLOW-BNHL. As the name suggests, it's a global trial, unfortunately not including Africa, which I guess is something you're all very familiar with. But this is a trial which has arisen from the Accelerate platform. So the Accelerate platform was set up by Gilles Vassal in Paris and Andy Pearson in the UK. And the idea behind the Accelerate platform is to essentially bring pharmaceutical companies together with academic researchers and clinical researchers in a way to force pharmaceutical companies to work with us, to design drugs and to apply them to pediatric populations and to make children a priority. And so I'm really happy that the GLOW-BNHL trial will hopefully start towards the end of this year. The chief investigator is a colleague of mine, Amos Burke, in Cambridge. I'm leading the biology of this trial. And again, this is a trial being led by ICANHL together with the Children's Oncology Group and ITCC. It's funded by Cancer Research UK and Kick Cancer. And it's coordinated by the Clinical Trials Unit at the University of Birmingham. And so this is quite a unique trial. It's a novel trial. It's a platform trial where we're basically going to have all comers. So children with any prior therapy, any histology, can come into this trial when they are relapsed or refractory to treatment. And they'll be recruited into one of 3 treatment arms. The third arm is CAR T cells. We don't yet have a product for that particular arm of the trial. The second treatment arm is an antibody-drug conjugate, and in particular, we're using a drug which targets CD19 and has a DNA cross-linker attached to it, so very similar to brentuximab, gets internalized into the cells, causes massive DNA damage and cell death. And that's a compound which is being, we're working with ADC Therapeutics on that. The first arm of the trial will have 2 parts to it, and this is the bispecific T-cell engagers, because we really want to focus on the potential toxicity of these drugs. And so in this case, we have a drug from Regeneron. It's a CD19-CD3 bispecific engager, and that arm will essentially ramp up as we learn more about the toxicity of these bites in children. So these are small numbers, very small numbers of children. Each arm will recruit 15 children, which will then ramp up to 30, dependent on the results of the first study. And this trial will run over 7 years. So it's a very big trial, but fortunately, these children are rare, and so we'll need that amount of time to recruit these children. And it's designed on a Bayesian methodology, and so we're really very much looking forward to getting this trial started and to seeing some good outcomes for these children. So how do we develop drugs for children in Africa? And bearing in mind all the issues, all the economical issues, all the problems that Jennifer raised in her talk, how do we turn things around so that Africa leads on this? So we go back to the point, as we were with Burkitt's lymphoma some 50, 60 years ago, where we're really informing the pediatric oncology community as to how best to treat children with lymphoma. And so this is where I've been working very much in a collaborative manner through Cambridge, Africa, with the Uganda Cancer Institute. And we really work as a team to try and think about how we might improve the situation. And so what we've done here at the UCI is we've established what we think is the first ever bioresource of viable, fresh tumor material from Burkitt lymphoma patients. So this is something I've been doing in Cambridge. We now have it set up here where we are collecting tumor cells from children at surgery. Those tumor cells are processed so that they are fresh and they are living, they are viable cells. We can then grow these cells in the lab on a feeder cell line, and that's work that's been conducted here at the UCI. And then back in Cambridge, we also grow those cells in immunodeficient mice. We're also now working with humanized immunodeficient mice. So these are immunodeficient mice that have no immune system of their own, and we give them a human immune system. So we put back stem cells from human peripheral blood, and we give them a human immune system, which means we can also look at immunotherapies. And so we're growing these tumors, and essentially what we end up with is an avatar of the patient. So we're growing a patient's tumor both in vitro and in vivo. And this is an example from one of our sporadic Burkitt lymphoma xenografts, but what you can see when you look at the hematoxylin and eosin staining and compare passage 1, so that's the tumor having passed through a mouse once, to passage 3, so going through 3 different mice, that we retain the features of the original primary tumor. So you can see here there's still that starry sky appearance, even though we've passaged these cells through a mouse. They're still rapidly proliferating, and of course you'll know Burkitt's is one of, if not the most rapidly proliferating cancer that we see. And that's denoted there by the Ki67 brown staining. And we even retain the T814 translocation, as you can see by fluorescence in situ hybridization there. And furthermore, when we look at the transcriptomics of the genes that are being expressed in those cells and compare them between the primary patient sample, so the tissue that was taken from the patient, and that that's been passaged through the mouse, they're still expressing the same genes. So we have a mimic of the human disease here in mouse form. So what can we do with these? Well, we can do all sorts of interesting things with these that we can't do with patients. So essentially, we can set up mini trials or mouse hospitals, if you like, where we can investigate how we can better treat these types of lymphomas. And so this is an example here of where we've treated one of our patient-derived xenografts with a chemotherapy regimen that was developed to sort of mimic the LMB backbone in a very reduced format. And so these are mice that get doxorubicin, vincristine, and methotrexate, and they're dosed with these drugs once the tumors have reached quite a substantial size. And the red lines denote where at each point we give the treatment. And so you can see with each treatment, or each red bar there, the tumor shrinks. And we can get these mice to the point where the tumor is completely shrunk and we cannot detect it even more, even using mini mouse PET-CT and MRI. But what we do see, unfortunately, is when we leave these mice for long enough, the tumors do relapse. They do come back, and when they come back with a vengeance. They grow very aggressively. And so one thing we're also doing in the lab now is comparing the transcriptomes, the genomes, the epigenomes of these tumor cells, both when they're first established in the patient from their biopsy material, and also from the relapsed tissue. And from doing this, we hope that we'll have some idea of what's causing these tumours to grow, what's causing them to relapse and become refractory to treatment. And we're very much looking at the interclonal dynamics of the tumours in that manner. We're also using these to conduct drug screens. So we're not just thinking about developing new drugs, but also repurposing existing drugs. So we use a library of FDA-approved compounds. There's about 4,500 drugs in this library. And what we could do is we grow the endemic Burkitt lymphoma primary patient tissue in Petri dishes, and we subject them to the drug screen. And then we can validate any hits that we find in our humanized mouse models or in our immunodeficient mouse models, depending on the mode of drug action. But what about those novel targets, those things for which there aren't already drugs in existence? Can we think and be optimistic, be a little bit more hopeful that we can maybe design new drugs specifically for children's cancers in Africa? And so for this, we're also conducting CRISPR screens with our endemic Burkitt lymphoma xenografts. So for this, we take patient-derived xenograft tumors, we transduce them to express Cas9 or a dead form of Cas9. So for those of you who aren't familiar with this is a system whereby you can guide Cas9, which is basically cuts out regions of the genome or drives their overexpression. And you can put a library of guide RNAs into the cell which target every single gene in the human genome. And then you can see which genes those tumor cells need to survive. And you can do this in a subtractive process or a positive process, and we've done this now for neuroblastoma, we've done this for anaplastic large cell lymphoma, and also for Burkitt's lymphoma, sporadic Burkitt lymphoma. We're now working with endemic Burkitt lymphoma. So can we identify those genes which on transcription are really important for survival of these tumors? Because if we can identify those, we can work towards developing specific drugs that will inhibit their activity. And so essentially at the UCI, we're innovating for Africa, as is the name of the conference here. And we're really hoping to push things along, become the leaders again in this field of research activity, to improving therapeutic opportunities for children with Burkitt lymphoma, to identify existing efficacious drugs, which hopefully have fewer side effects and could be more manageable in the clinic here, and also to be ambitious, to design efficacious drugs with predicted fewer side effects. And the picture here, this is Sylvester and Marta, who I think are in the audience somewhere. So if you want to learn more about the project, please do find them out and speak to them. And Sylvester and Marta have been working on this project here in Uganda. And Jamie is our resident bioinformatician and a PhD student in the lab who's also been working on this project. And unfortunately isn't with us here today. He's back in Cambridge. And of course, I have to finish by acknowledging the important people who have been doing this work and have really been pushing the project further. So Jamie and Marta are in my own lab, but also here at the UCI, Dr. Oram, Dr. Nixon, Dr. Joyce, Dr. Garriga, and Sylvester, who without their insight and their drive, this project really wouldn't be getting off the ground. And as I said, this really much is an African-led collaboration. The funding for the project comes from the Global Challenges Research Fund in the UK and the Albarada Trust. And going forward, I'm delighted that we now also have funding from Great Ormond Street Hospital Charity and also the Little Princess Trust from the Children's Cancer and Leukemia Group. And I'll just end there with a little quote. You can't come from Cambridge and not have a quote from Stephen Hawking. And so Stephen Hawking once said, "Look up at the stars and not down at your feet. Try to make sense of what you see." And I like to think he wasn't thinking of the stars in the universe, he was thinking of the starry skies of Burkitt lymphoma. And I'll leave it there and thank you for your attention.
Thank you very much, Suzanne. We're going to ask you to join us, but don't go away from the microphone for 1 second. Prerogative of the chair, because we're going to be discussing CAR T in the discussion. Can you give us a sense of those early results with rituximab? Is it going to move the cheese significantly?
Sorry, is it going to move the...
Adding rituximab to the conventional backbone, are we going to see a dramatic improvement in first-line treatment?
If you do it here, you mean? Or, yeah, I would guess so, yes. I mean, I really think this is the perfect population to look at things like rituximab and adding these agents in. And I'm really excited to see the results of the trials which are being run in the French-speaking countries and elsewhere with rituximab. I think it's exciting times. And undoubtedly, I'm pretty sure you'll see improved outcomes. I mean, what we want to be able to see is the longer follow-up now with the European population as well. And make sure that those event-free survivals are sustained. But it's certainly very promising.
Wonderful. Thank you so much. So our last speaker before our discussion is Professor Mahmoud Hamad. He works in the Department of Pediatric Oncology and Stem Cell Transplantation at the Children's Cancer Hospital in Egypt, and is on the faculty of the National Cancer Institute of the University of Cairo. And he's talking to us today about CAR T-cell therapy. Is it a priority or not in pediatric oncology? Thank you, Prof.
Hello, everybody. Good morning. I would like to thank the SIOP committee for giving me the privilege of being here and discuss this interesting topic. It will be discussing the CAR T-cell therapy in Africa. Is it a priority or not? I'm just checking okay. I have no disclosures. The objectives of the talk will be an overview on CAR T-cell therapy, its structure, its approved indications, common side effects, and results of clinical studies, some African barriers and limitations to offer CAR T-cell therapy, and practical steps to overcome limitations, and I will be focused on FDA-approved CAR T-cell therapy in relapsing and refractory acute lymphoblastic leukemia. The learning curve for cell-based cancer therapy started to increase since the introduction of allogeneic stem cell transplant in 1960s, with the recognition of the importance of T-cell with its important effect on graft versus tumor effect and its disadvantage of graft versus host disease. And then with the start of haplostem cell transplantation, there was a mandate to start manipulating T-cell with T-cell depletion, either ex vivo or in vivo, and more clinical implications have started to make use of the potential killing effect of T lymphocytes, including antibody therapies, as well as, I don't have the presentation here, to use T-cells killing effect like checkpoint inhibitors and bispecific antibodies, and lately the CAR T-cell therapy. We can see that the African continent is sharing a great burden of global childhood cancer cases, constituting around 26.3% of the global childhood cancer. And according to the WHO in 2020, the most two common malignancies are non-Hodgkin lymphomas and leukemias, where we can see from this bar chart that more than 60% have still high mortality rates. In general, acute lymphoblastic leukemia accounts for 25% of cancer children below 15 years of age, with a 5-year survival rate now exceeding 90%. 2 to 3% of patients will experience induction failure, and 10 to 15% will experience relapse. Besides, the 5-year survival rates for relapsing and refractory cases is still approximate to 30%. Still, multi-drug chemotherapy is the mainstay of treatment. However, this doesn't give a long-term remission, and allogeneic stem cell transplantation is needed to consolidate remission. But patients who are not eligible for a stem cell transplant or relapse following a stem cell transplant will have almost no chance of survival, which mandates the need for new treatment options. The concept of CAR T-cell, as seen in this illustration, we can see it's a reprogramming of the patient T-cell through introduction of chimeric antigen receptors that can recognize and eliminate a specific target antigen. Also, after binding of this chimeric antigen receptor or the synthetic antigen receptor that's created to the target antigen needed to be eliminated, this leads to a vigorous T-cell activation and antibody tumor response. The basic structure of CAR T includes a binding domain, and in our case, we are discussing CD19 binding domain. as well as a hinge region which gives flexibility to the binding domain to access its targeted epitope, a transmembrane domain, and intracellular signaling domain, including CD3 zeta to transfer the signal to the interior of the T cell and activate it. We have many generations of CAR T cells, and they differ according to the type of co-stimulatory domains used, as well as the number of co-stimulatory domains used in the CAR construct. There are 5 CAR T cell products approved, but Tisagen Licleucel, which is a Novartis product under the name of Kymera, which is what approved in 2017 through the Eliana study as a third line in B acute lymphoblastic leukemia in pediatric, is the only one that we will discuss, but still we have also the axicabtagen Licleucel, which is also a lot of trials are running right now, but didn't have the approvals yet. The outcome of this Eliana trial showed an overall response rate at 3 months of 81%, and of notice the 61 of patients who went into this trial had a relapse after allogenic stem cell transplantation, so they are very resistant to treatment, and all the patients who had responded were an MRD negative, and beside only 8 out of 75 patients were transplanted post-infusion of CAR T cell needed transplant, which raised the question if CAR T strategy could replace transplant in near future. And this resulted in an 1-year event-free survival of 50% and overall survival of 76%. The approved indications for CAR T include having acute lymphoblastic leukemia precursor, C, precursor B leukemia with 2 or more relapses, as well as refractory disease to standard chemotherapy either in a primary or relapsing setting. According to different results of studies done in pediatric acute lymphoblastic leukemia using the Tisagen Licleucel or other CD19 products other than the Tisagen Licleucel, we can see that an overall response rate of 3 months have been achieved to more than 81%, beside at least 6 months event-free survival ranging from 67% to 76%. The workflow for CAR T cell includes, could be simplified in this illustration, showing that after patient is selected to be candidate for CAR T cell infusion, white blood cells is extracted through leukophoresis and then sent to the manufacturing facility to produce the intended CAR. And this time could take in some places from 1 month to 2 months. So patients should be kept on bridging chemotherapy. There is no standard chemotherapy for this bridging, but it should be just chemotherapy of low toxicity, and its aim is to control patients' disease and not to induce remission. And after the CAR product is available and received by the requesting center, patient receive lymphodepletion chemotherapy and infused by stem cell by the CAR T cells, and further we follow and monitor response and manage complications if any occurred. So the manufacture process includes an activation to the T cells through exposure to antibody beads, and then transduction of lentiviral CAR T construct to reprogram the T cell and modify its genome to express the chimeric antigen receptor needed, and then expanded ex vivo this CAR expressing T cells, and finally isolation of the final cell product and cryopreserved and sent to the requesting center. There is some limitations to durable remission after CAR T cell therapy, including failure in production, where there is failure to harvest the needed cells in a heavily pretreated patient, or T cell exhaustion with loss of persistence less than 6 months, where patient don't proliferate well for a long time. Also, co-stimulatory molecules differ in their durability as well as persistence power, including the most 2 common 4-1BB or versus CD28 as co-stimulatory molecules. Also, the loss of target antigen through antigen modulation from mutations in CD19 exon or lineage switch or previous use of blinatumomab that can lead to down modulation of the expressed antigen. Some life-threatening complications could be related that, as mentioned in the process, patient receive chemotherapy before CAR T-cell infusion, followed by infusion, and the expansion of the CAR product leads to B-cell aplasia, which makes the patient prone to prolonged infections and different viral and bacterial infection besides the cytokine release syndrome and neurotoxicities, which are common complications post-CAR T infusion. The cytokine release syndrome is related to the T-cell expansion and may be necessary for the efficacy of and outcome for the CAR T therapy. It typically occurs few days from T-cell infusion and correlated with the disease pattern, the disease burden. The higher the disease, the more the patient is prone to have cytokine release syndrome, and it varies from mild form of fever, myalgias, to more ICU needing indications like hypotension or even multi-organ failure. The limitations to start a CAR T-cell therapy in low-middle income countries, some of them are related to specific African challenges or other low-middle income countries' challenges, and other related to the complicated, complex process of the CAR T-cell. We still have in Africa some recent publications discussing treatment abandonment in pediatric cancer therapy. And we can see in this study that done in 5 hospitals in sub-Saharan Africa, including 252 patients, that 7% of patients abandoned treatment. 65% of the patients had to borrow money to reach the hospital for diagnosis and start of treatment. Also, this British Journal Hematology publication was discussing the challenges in hematological African malignancies and highlighted the poor public awareness of childhood cancer and the limited access to diagnosis, where sometimes one clinical pathologist can serve 500,000 to 1 million people. Also, lack of expert physicians, where in some centers 17 had no pediatric oncologist and 10 had no surgeons on site in a survey done in 38 African cancer centers. Also, lack of cytogenetics MRD limits the usefulness of some international protocols to be used. Another problem is the access to antineoplastic therapy. And according to the Essential Medicine Working Group of the SIOP that listed 18 antineoplastic drugs that should be on the national drug list of every low-middle income countries, we can see that Africa still has the lowest median number of medicines, and that 20 out of 26 low-income countries listed were in the African continent. So oncologists from low-middle income setting have tried to different approaches to improve the outcome, some by using modified protocols or twinning with national and international partners. And we can see in this JCO study discussing different collaborative groups, including Africa. We can see the POEM, we can see the French African Pediatric Oncology Group, and the collaborative Wilms Tumor of Africa. All of these collaborations has tailored and improved the outcome of many malignancies through tailored protocols in our region. The other limitations could be related to the CAR T-cell process itself, which is multiple and variable, including financial, healthcare system requirement, trained staff, quality and data management, and most important, is it a standalone therapy to that time or not? And due to the difficulties low-middle income countries are facing, we can see from the global map for CAR T-cell trials that none of low-middle income countries are represented from Africa, South America, India, and only from high economic countries. So healthcare facilities needs to meet certain requirements to offer CAR T-cell therapy. Some of them are process logistics and infrastructure requirement, like production of CAR T-cell needs a good manufacturing product process, fact accreditation, which is needed to any program that seeks immune effector cell needs to be accredited from the Foundation of Cellular Therapy. Leukophoresis and the CAR T-cell infusion should be following a quality-assured program. Also, there should be standard of procedure regarding emergency plan, as well as availability of well-equipped ICU, trained staff, and emergency medications to manage complications that can happen post-infusion. Also, the clinical knowledge and skills should be acquired, and in practice, we should be looking for a clinical center to offer of having the capacity to offer stem cell transplantation with a highly trained staff in allogenic stem cell transplant and the intensive care who can administer the therapy as well as handle different complications post-infusion beside an ID team to deal with prolonged cytopenias. And no matter that financial aspects and financial logistics is one of the major obstacles, and we can see in this US-based prospective study discussing an overview of healthcare resource utilization with Tisagen Leclucil in different phases, included like pre-treatment phase and infusion period and a follow-up for 2 months post-infusion, and they resulted that the minimum cost needed is at least $612,000 associated from leukophoresis till 2 months post-infusion. And besides the main price list for the drug, which costs $475,000, there is 137 additional costs from adverse events, inpatient and ICU admissions, and laboratory and procedures needed. And ironically, it was published in the JCO discussing if US can afford the CAR. And I quoted the author's own words that even at half the current cost, if CAR T-cell therapy became a commonplace, these prices would be unsustainable because healthcare costs already are a heavy burden on the US economy. And that not only the cost, the direct cost is unaffordable, but the cost of medical care required to keep patients alive during treatment. So importantly, is CAR T-cell to date is a standalone for relapsing and refractory cases or additional stem cell transplantation to consolidate remission or treat relapse and loss of persistence is needed. And many reviews have discussed that 40 to 50% of patients initially responding to Tisa-cell treatment relapse, and the proportion of patients receive stem cell transplant additionally. Besides, 10 to 20% are primary refractory to Tisagen. Also, in the previous studies, we can see that a very big proportion of patients before going to CAR T-cell infusion have received prior stem cell transplantation, reaching more than 60% of the population of the group included in the CAR trials, as well as post-CAR T management for relapsing cases and patients who lost persistence includes transplant, among other maneuvers like infusion of other types of CAR T-cells. And this debate was discussed in this review that was published a couple of years, that referral to transplant post-CAR T-cell varied widely from 10 to 78%, and that relapse rate is generally higher without stem cell transplantation compared with stem cell transplantation as a consolidation. So long transplant is one of the main integral parts in the process of CAR T therapy, either prior or post CAR T cell infusion. We need to know the African situation, and according to the African Blood and Marrow Transplant Society that was launched in 2018, we only have 6 out of 54 African countries doing stem cell transplantation, including South Africa, Egypt, Nigeria, Tunisia, Algeria, Morocco. And according to the WBMT, showed that the African and East Mediterranean region just responded only to 3% of the worldwide activities in transplant. Also, we can see in this that the transplant rate, despite being low compared to the other continent, WHO continents, but we can see there is a rise more than 90% since 2006 in more initiation of allogenic and autologous stem cell teams in African and East Mediterranean regions. Also, an important initiative was done by the South African Bone Marrow Registry that was established in association with, or in collaboration with the World Marrow Donor Association, to have donors and search for local and international donors, so they have an access to more than 39 million donors worldwide, which is a very good initiative. Also, this this success story was also discussed in Lancet Hematology, discussing the model of India in rolling out as a low middle income countries for CAR T-cell therapy, and they discussed that they started companies, and one of them is the Immunil company that aims to reducing the price of CAR T-cell in India, and to imitate what they have done already in bone marrow transplantation. They are offering bone marrow transplantation with reduced cost. So this is a success story that we as low middle income countries could also imitate. So in conclusion, CAR T-cell therapy is an important new treatment option for childhood, young adolescent patients. It offers a better chance of having remission in relapsing and refractory B-cell acute lymphoblastic leukemia, but still Africa is facing many healthcare challenges which should be our main priorities to overcome. And to date, CAR T-cell therapy is not a standalone treatment strategy, and either it's a bridge to or bridge over stem cell transplant is not yet defined. Demanding logistics are still complex, and it doesn't come cheap currently. We as low middle income countries cannot afford the cost of CAR T-cell therapy to every person who needs it. But just because we cannot currently administer CAR T-cell therapy doesn't mean we should stop working on it. But actually, this nuclei, multiple nuclei of stem cell units all over Africa should collaborate and initiate a CAR T-cell trial together, as well as if we are discussing and prioritizing what matters most, so we need to invest more in establishing more transplant centers in Africa and to train more oncologists in this field, which could be a step forward to start a cellular therapy program. Besides, it's have a curative potential for many benign and malignant disorders. And by this, I would encourage all my colleagues to join the African Blood and Marrow Transplant Society, so together we can improve the African situation in this matter. And thank you for your attention and time.
Thank you very much, Prof. Hamad. If you wouldn't mind joining us on the podium, I just want to say to junior members of faculty, it's very impressive and an absolute inspiration to see senior people in our community stick to time in a meeting. It's an inspiration because it leaves time for discussion. I'll hand over to Nixon Nyanzima, who's going to curate the discussion.
Thank you, Alan. We'll have a discussion looking at whether Africa is ready for CAR T-cell therapy. And wanted to first give opportunity to Professor Ala El Haddad, who is joining us online, to give us a comment, and then we'll revert to the table here.
Here with you, I wish to be in person. However, that's great. I'm here for any question.
Thank you, Professor. I just wanted to ask Jennifer, Suzanne, and our discussants today, Hamad, just to make brief comments on whether Africa is ready for CAR T-cell therapy right now, what we need to do to start implementing CAR T-cell therapy in our environment in Africa, and then we'll open up the session to the rest of the congregants to ask their questions and to discuss.
If I can start to make a comment. Again, targeted therapies and cellular therapy are very important tools to overcome cancer. And we need to put the patient into remission and to consolidate that. As my colleague Mahmoud said, we are not yet ready for CAR T therapy in Africa. Yet, we need to start doing things ourselves. And we cannot count on drugs that are going to be imported because it's not affordable, at least in my country. Can you hear me?
Yes, we can hear you very well. And thank you very much for your comments. Jennifer, do you have anything to say?
Thank you. This is a very tough question, and it's actually the one that I posed when we were thinking of this session. So I've had 6 months to think of the answer, and I still don't have the answer. I think simply, no, we're not ready. We don't have the infrastructure, we don't have the staff, we can't afford it. But can we afford to never have it? I would say no. I would say we do need to start working towards it. But we also need to work collaboratively, because we don't want to have a very expensive modality available only in certain countries that other countries can't access.
Suzanne, do you have any comment?
I guess I would just add that, you know, CAR T-cell technology is moving on at great speed, and off-the-shelf CAR T-cell products will become available in the future. So I think, you know, it's a space to watch, and there will be more affordable options coming along as the years progress. So I think we should be a little bit optimistic and hope that some of these newer products, as they are developed, are trialed in Africa.
Thank you. Mahmoud, do you have a final comment before we open up?
Okay. I think CAR T-cell therapy is not one of the essential drugs that should be listed in growing economies, but I think we can work on the infrastructure more to be ready in the near future. And as we just mentioned, that complications related to CAR T-cell infusion, as well as infrastructure of CAR T-cell by itself outside the drug manufacturing, it all like allogenic stem cell transplantation. So I think we need to work on this matter rather than starting to think about prices that we can afford or not in CAR T-cell.
Thank you. I'll ask Alan to also give a comment, given his vast experience in treating pediatric cancers.
I'll sneak in a comment, but we're looking for hands, folks, so if we can indicate that you're keen to talk. You know, contextually, it's very interesting. Prof. Hamad spoke about, you gave us a ballpark figure, 100,000 US. Now, put that in proportion. Jamie Moore in Barcelona told us in the last SIOP that a course of dinutuximab is about, that's the can I say, the not reduced price dinutuximab is about 280,000 euros. The price of Blina for 2 courses for the average size child is about 200,000 US. So there are more expensive things than CAR T. The question is, and I want to allude to a conversation the other day about centers of excellence. So they took a bit of a pasting, and I think the community is talking now about centers of expertise. And I must say personally, I would not be unhappy with a particular center of expertise developing this technology and looking for ways to make it cheaper. I mean, that's the million, because the Holy Grail is not to find a way to afford dinutuximab or blinatumomab, or for that matter, CAR T, is to find a way to make it cheaper. Because it may be affordable in one unique place, a center of expertise, but there is a difference between affordable and scalable. It will never be scalable at the current price. None of these things will ever be scalable. Rituximab may be scalable, but that's a different animal. So if you guys initiate a process, I think we should support it. But we know that for now it's beyond everybody. But it may one day be there for us.
Yes, thank you, Alan. Of course, it's interesting what Mohammed touched on, that we need to build the infrastructure to actually be able to recognize the patients that need the CAR T-cell therapy, but also to make use of the other resources that we have in Africa and the other therapies that are accessible to patients. We'll invite questions from the house. We have about 15 minutes for discussion, and we'll start with Jacques. I think somebody will bring a microphone to you.
Jacques, just come to one of these.
Oh, you can come to the
just come
front.
to one of these, we'll go find them.
Okay. So I'm going to quote Leila Hessison, and she said, invest in your human resources before you invest in your stones. So what are we doing on the African continent to get the human resources up to speed with these things? Because as Jennifer said that, you know, she has an interest in it, but we don't have a lot of experts in it. So that's my first question. And then just falling back on what you'd mentioned, maybe we should also be more investing in training people for transplant, and who are the centers of expertise in Africa that is going to do that from now and then in the future?
Thank you. I'll ask each member of the panel to respond, but I'll actually start with Alan because he also is doing a lot of training. But Jennifer, Suzanne, and Mahmoud, and also Professor Ala, if you can comment on what we're doing to build the centers of expertise, what we're doing to build the human resource capacity in Africa for CAR-T cell therapy.
Geez, I'm a little bit at a loss like Jen was. I must say one thing that is that's important. I noted on Prof. Haddad's CV that he's JCI accredited. Let me tell you, JCI accreditation is a walk through the weeds. It is big time. We've spoken in this meeting a lot about trying to find ways to do research. And I think the one thing that we know, and I'm speaking as a very nascent transplant center personally, the regulatory framework to set up the SOPs and protocols is massive. So I think that probably, I mean, I think we do the training, but in order to train effectively, that's where we're going to have to focus. And the only thing I can say is that we must share those things. So we must share them with each other and not reinvent the wheel all the time. There's a question there.
From my own perspective, we are getting an overall survival of 70%. And if we want to see it above 80%, then we need to use other modalities like targeted cell. Then you need to do it. You do it yourself so it can be affordable. And you do it lines so you can have a safe product and effective product as well. Lastly, you need to be trained on how to do it, and it would take me to the ABMT and Mahmoud, and we're having the ABMT, and a lot of centers are participating from Nigeria, South Africa, Tunisia, Morocco, Algeria, and Egypt. And to start with, we can make use out of these centers, and we can provide training, and we're willing to do this for the whole continent, definitely. And I'm talking about bone marrow transplant, of course.
Thank you. And of course, you raised one important question, how we can support the rest of the continent to develop human resources. And I'll ask the rest of the panel to comment and also specifically emphasize that point of helping the rest of the continent. Jennifer?
Well, I think we all realize that we can't do this alone anymore, that working in silos doesn't work. So many of us have started collaborations with other countries. So the virtual online meetings help a lot. And we're trying to do more training. So things like the African Pediatric Fellowship Program, where people come from different countries to train in other African countries in specific subspecialties, makes a huge difference.
Suzanne?
So I don't have much to add other than, of course, training and capacity building are key components of any successful project. And certainly the Cambridge University and the Cambridge University Hospital NHS Trust, we're working closely with the Uganda Cancer Institute to facilitate the training that they need to take these new therapeutic approaches forward, with bone marrow transplant being a particular priority at the moment. But certainly, yes, training and collaboration are key aspects of moving forward.
So, Mohammed, do you have something to say before we go to the next question?
I think what I will add is I try to touch base also in the African challenges, which is including all things. We have already bypassed this by some twinning programs like the Moroccan Society of Pediatric Oncology with St. Jude have implemented a Hodgkin lymphoma protocol, as well as the French African Pediatric Oncology Group. So we generally, in standard chemotherapy, we had some challenges that we have bypassed and overcome through twinning and getting training with other international societies. And I think this could be the same for other targeted therapies.
All right, and we have a question from over there. If you could stand so you can capture your image on the screen.
Ah, there we go. They can see me on the screen, so I won't stand. I'm Mark Hendricks from Cape Town. I mean, I think one thing that has to be thought about on a much broader scale is the issue of developing parallel systems of referral. So it's one thing to create centers of competence and expertise and to develop cheaper techniques or new technologies. But if you're not thinking simultaneously about how to conduit patients who need those very niche interventions to the place where they're provided, then it doesn't help you to scale up services if a patient in Malawi cannot come to Cape Town or go to Cairo to access a treatment that is needed. So that's a much more complex issue. I don't think any transplant center has any shortage of consultations per year from their neighboring countries for transplant or for other therapies. The issue is, how do the patients get there? Who pays for it? So if we're thinking about creating continental centers of excellence, then we simultaneously have to be thinking about how we get the patients who need it, and most of whom cannot afford it, to those centers for that therapy. So there's a very complex international conversation to have that holds in the balance the issue of social justice in addition to just upscaling the medical project, which I think is only one aspect of what we're talking about today.
Thank you, Mark. I don't know if there's any response from the panel, but we have a question just next to you, if you can ask your question.
So I'm Mahmoud Zimbili from Egypt. I'd like to thank the panelists for the interesting talks. I have a question for the panel. Do you think wide use of CAR T cells in the future is going to make it cheaper than now? And when you expect to have the first CAR T cells in Africa? Thank you.
Thank you. I'll ask the panel if they have any comments.
I mean, it's a backward and forward. Mark, you're right. Unfortunately, that paradigm, though, is that ethical construct is in almost everything we do, because we have those parallel systems as things stand right now, where we have different treatment modalities. So it's very important philosophical consideration. Jennifer here is asking. I'm cold. I don't know what the word is. I don't want to ambush my fellow chair, but one of our panelists is suggesting we should vote, on this matter. Shall we? Shall we do that? Shall we take a vote? Should we ask people to vote? Why not? It's not a final. So we would like to ask at this stage, although we're happy to take questions or comments. We've got 1 or 2 minutes left over, but can we ask for a... So Ahmed, you get the last word before the vote. When he's finished, we're going to vote on yes, Africa is ready for CAR T, or no, we are not.
Yes, I'm Ahmed Kamal from the Children's Cancer Hospital, Egypt. And I think the main question now is CAR T cell is available or not. and when we're going to start it. But I think we can invest our time in not only in the training, how to use the CAR T cell and how to get prepared for the CAR T cell, we can invest our timing according to our resources in proper supportive care and proper infectious complications control for our patients, because if this at some point is introduced in our centers, we would need proper supportive care in order not to lose our patients just after introduction of the CAR T cell or going so extensive in the BMT. So the supportive care is so important to target regarding our centers, and it is really important because I expect from the complications mentioned in Prof. Hamad's presentation about the CAR T cell that we could suffer from much infectious complications after this introduction. So if I'm saying we're in 2022, I need to introduce CAR T cell to our centers. I need to get well trained not only to use the CAR T cell, I need to get well trained for proper supportive care and proper supporting our patients. Thank you.
Thank you very much, Ahmed. So guys, I'm going to hand over to my co-chair for some announcements in a minute, but I'm going to ask you to try and be unique as an audience. Please be different. Vote. Everybody puts their hand up for one or other option. You may not abstain, otherwise there's no fun. There's no negative marking. You won't miss lunch. Who thinks Africa is ready for CAR T cells? Please put your hands up. Like this, like this. That means we're going to count all the rest of you. I just want to ask the faculty at CCHE, you guys are not voting yes. Yeah, you see, there's a few more hands there.
I think we're not voting yes yet.
Okay, so who's voting no? I want to see the hands, please. There are no abstentions, folks. All right, so for today we have an answer, but this is an ongoing consideration. So I have to say thank you very much to wonderful speakers for engaging material, for excellent audience participation. And with that, I'll end the session and hand over to Nixon Nyanzima.
Thank you, Alan. So some administrative announcements. The excursion happening tomorrow, that's visiting the Uganda Cancer Institute, and the patient hostels where children are housed as they receive treatment. Please register at the reception. There will be pickups at Munyonyo, that's the resort, and Serena at 8 a.m. tomorrow. 2, the nutrition workshop is happening tomorrow at Munyonyo, 9 a.m. to 12 noon. Transport from Serena at 8 a.m. Please register with Elena Ladas. 3, COVID testing tomorrow. Please register at the reception. This is a special exception for those who are not able to get today. 4, there will be an AGM in the Katonga Hall, which is upstairs, during lunchtime from 1 to 2 p.m., and lunch will be served in that room as well. 5, Mark Hendricks should visit the exchange table for his documents. Thank you very much and enjoy your lunch. Mark Hendricks, visit the exchange table for your documents.
Just a quick word, the annual business meeting is open to everyone who considers themselves part of SIOP. It's free. We discuss fairly important issues there, and there is a small lunch as well. Thank you.
Yeah, and lunch is 1 hour. We'll be back for the afternoon sessions at 2 p.m. in the different breakout rooms.
and she has to present. So I have really bad news for you, but I'm the only pretty face sitting up here for you at the moment. So just bear with me. And so as other people are still coming in, I'm going to try and also see if we can catch up on time. But I promise you I won't cut any of your talks. So we're going to kick off directly. And the main topic of our talks for this session is about implementation, whether it's strategies or new programs or so forth, or if you're just initiating the groundwork to understand what you need to do in your country. So, but we obviously have a very nice talk to start off with. And I'd just like to call Dr. Agrey Semere. And you're welcome. And you'll have a very enlightened talk to kick the session off with. And I'm sure he will introduce himself much better than I can do it. So I'll leave it to Dr.
Thank you, Session Chair. Agrey Semere is my name. And as they bring up my slides, I'll just say one or two things about myself. I'm a physician and researcher based at the Infectious Diseases Institute, Makerere University, here in Kampala. My research is somewhere straddled between HIV and cancer, and though not pediatric related. So I do work with mostly KS and cervical cancer, but I also teach epidemiology and implementation science. So I'm going to talk to you, and I thank the organizers for giving me this opportunity to talk to you about this issue of implementation, but seen from the eyes of HIV. And I'm going to try and build this story around maybe 3 key points. The first being implementation as an evidence, sort of implementation as a bridge between evidence and practice, and then also go a bit into the HIV, show you a few components and how closing that gap sort of enhanced implementation, and then we summarize this with a series of lessons that we can pick up. As you can imagine, this could take us a longer session, but let me see if I can pack that in 10 minutes and the story becomes very interesting. I'm going to start off with this nice cartoon or picture. Unfortunately, you cannot see, and you're going to have to rotate your head around like one of those creatures, which
I'm multi-talented,
I can imagine. So, so implementation starts off with usually us having evidence. And evidence is generated within the context of research. And these are usually small population, manicured, and nicely picked for us to generate evidence that can connect nicely to outcomes, and we say something works. And we catch this evidence excited so that we can implement it for the rest of our populations to generate or benefit from the good that comes from research. Of course, this needs scaling up, scaling out, and you're doing this in a real-world context. And so sometimes the observed outcomes are minuscule and are not exactly what you expected. Yet we know what is expected. So this gives us 2 key concepts to think about. One is what we call a performance gap. Are we performing the evidence the way it's supposed to be performed as envisaged in the trial setting? And that we can actually measure. You can actually know that we are or we are not performing something as it should. The second gap is the outcome gap. The outcome expected, we know what it is, but we are not getting it. And I'm going to talk through some examples from the HIV care world to try and show you these gaps and how HIV has maybe showed us a way to slowly build and enhance implementation to benefit from research. And so I will work with prevention. Most of us know these key components. We know prevention, which has PrEP and male circumcision, MTCT, PMTCT, testing, which includes screening, linkage to care, treat all, and then monitoring. I can't talk about everything. So I've chosen 3 key components in each. I'm going to talk about, from the prevention side, medical male circumcision. Testing, we shall look at the test and treat or the treat-all concept. And then lastly, look at ART virus suppression. So what do I want to say about medical male circumcision? We know very well that early around 2005, 2006, clinical trials, about 3 key clinical trials came out, building on evidence that had come from observational studies that when males are circumcised in this clinical trial setting, the risk of transmission of HIV was down 50, 60%. And so quickly WHO put in place recommendations that countries like Uganda, which predominantly had low circumcision prevalence, should push this ahead. The target was set at 90% population coverage for the population to benefit from this evidence. So there, the performance is set. In a clinical trial, it was 100%. In the population, it has been set at 90%. Now, we have to bring from as low as whatever it was in practice to as high as 90%. Now, what was needed? There were funds needed. You're going to find people, males who are here, normal people who have no problem, and tell them you have to get circumcised. So, and there was money needed for that, and as well as, we needed to rethink. Imagine all of them show up. Can our facilities handle that? So we needed to think about different approaches, outreach, facility-based, task shifting. We don't have that many surgeons. How do we get this procedure done? Simpler techniques via these vice clamps, shangring, and all these other devices. And then to know how well we're moving, you needed to build monitoring and evaluation systems, and then address a myriad of issues, including fear of pain, the post-circumcision abstinence. Men would not want to be away from work, infection, anesthesia, and many cultural and religious beliefs. And hence, this wasn't looking simple. And therefore, if you were to try and see between actually 2005 and 2010, there was hardly a change. And, currently, as I kind of put this together from the UNAIDS fact sheet that for 2020, we have slowly just moved up to 60%. Performance gap reduced from 25 to 60%. It's an improvement, but it's not yet the 90% target set by UNAIDS. But what has it taken to get this done is all that stuff that I talked about. Challenges remain. And, we need to achieve the targets. And what is actually become very clear is the population demographic that is getting into the 15 to 49-year age group is increasing. It's not a static population. When you say you're going to circumcise 90% of a population, while at some point you've done it, more children are coming into that group, more humans are coming into the group. So it's a continuous target. And so the realization is like, oops, okay, this is long term. So as you think about implementation, there are things you have to understand about your population dynamics. And therefore, research is needed. At IDI, I led some study where we're trying to look at antenatal care, where ladies could bring their husbands in and become our points of contact. This is just an example of some sort of implementation studies, how you overcome these gaps. And with this before and after study, we did show an improvement, but it was not statistically significant. And there are many others in the same, of the same type that are trying to bridge the gap between practice, evidence and practice to close the performance gap and hence improve the outcome gap that we expect, which in this case would be HIV prevention. So the performance is circumcision to prevent HIV infection. Now, why don't we look at test and treat? This is a second story. Okay. Thank you. So with the test and treat, you know, a lot of knowing very well where we started off with antiretroviral therapy in the early 2000s, the recommendations for initiation of treatment kept changing along the way from anybody below CD4 200, CD4 350, CD4 500, and then eventually we realized that, you know what, as long as you test immediately and start someone on treatment, as proven, first of all, in resource-rich countries, and then eventually some clinical trials and modeling studies, as well as cost-effectiveness studies, it made sense in many ways. Not only mortality, but as we shall see, even infection. And so 2015, WHO again puts out a recommendation. And then these recommendations are adopted locally into national guidelines. And then donor funding is put in place. Now, I'm setting for you the foundation of sometimes what encourages implementation. Those are key things to think about. Guidelines, key players sort of guiding and giving you the directions, giving you yardsticks. And of course came the 90 now, which have since changed to 95, 95, 95 targets. And so with that funding, academia had to support the way in how to think about increasing ART coverage. This needed personnel, it needed changes to workflows. In fact, we started talking about models of care, the so-called decentralized models of care. Do we need to start thinking about something like that in pediatric onc? Can we always wait for tertiary care for some of these cancers that are so common in some of our countries and regions? Task shifting, task sharing. You know, what can be given to somebody else? What can somebody else do to enhance the way we're delivering? This is the sort of thinking that came through, because the thinking was we need to increase access at the point when somebody was treated. The streamlining initiation of antiretroviral therapy stepwise cluster randomized trial was done here in Uganda, in southwestern Uganda, and looked at a cluster of 20 clinics. And they put together this multi-component intervention in a real-world setting to try and see what can we do if we talked better to clinicians, equipped them with faster measurements of CD4, you know, potentiated by the logistics by making sure there's antiretroviral therapy whenever and when needed. Can we get as many people started? Before this, initiation was at, in the control group, it was at 40%, and in the intervention group, it went as high as 80% initiation. And this cluster randomized trial came out in 2016, around the time when the recommendation was also coming out, and said, actually, you can do it. And so, over the years, this kind of has gone up. As you can see, from 2015 to 2020, about 15 years, we surpassed the 1990 targets, but now we want to get to 95%. As you can see, that's where it is. It's not yet there, but we're very close. And so this kind of tells you that you can get there. But now to get to that last mile needs us now to understand why. And hence, a focus on populations, the so-called most at-risk populations. And these are men who have sex with men, female sex workers, or commercial sex workers, and all these other groups need to be targeted in a way that kind of suits them and can get them into care. What about antiviral suppression? This is, of course, after starting treatment, it's our interest. And as we know, it has both mortality benefits, and even if we can get people undetectable, it reduces transmission. And this is from combined studies from 3 clinical trials, which showed the risk is as low as 0.14%. And so with this, we know that if we can get undetectable virus in most of our patients, would have done a large chunk of the job. Now, achieving this, of course, as I alluded to earlier, first of all, we need effective medication. Dolutegravir right now drives the suppression faster and more sustainable, and we kind of, again, think about different models of delivery. But, for instance, in Uganda, we had to get viral load testing free, and we kind of have this hub system where samples are collected and brought to the center and tested, and results returned via electronic systems. And then, to achieve this, you have to have the patients retained in care. And so, where are we with that? Yes, it's not yet up to the 90, first of all, we missed the 90 target, having 90% viral suppressed, I think by just 3 or 4%. It was just 80-something%. But now it has since been pushed up to 95 by 2030. And so one of the key things, again, that last mile is to look at these key populations, which is work that we are doing to try and get them suppressed. And there are studies, different studies that help you try and understand these populations. So this work by Darius, who was a former mentee, is looking at virologic suppression, for instance, amongst female sex workers, to try and see if you can, what are the key things to address? And this is a cross-sectional study. Do you need to do some of that? So to try and wrap this up, I'm going to try and then bring together a couple of lessons that we can pick on. One, overall, the hub of you trying to improve and enhance implementation works around research capacity. What is the research capacity within the PDONC group, both for epidemiology research, but also implementation science research? Remembering that implementation science research is just a sub-specialty within the general research group. First of all, it should be clear that you have evidence ready to translate. If you look at your practice, is there evidence that should be translated that is not? And so an evidence synthesis is key for critical evidence-based interventions that are of critical importance. And with this, then you can think carefully about the gaps. Okay, if you have evidence, currently are we seeing a disconnect between its performance and the outcome? Are we doing it the way it should be? And what are we getting? That kind of sets the precedent of how next you're going to move, because you then need a few things in place. Some formative research to understand that gap, like, for instance, the paper by Darius, which is sort of helping us understand the issues around female sex workers and viral suppression. And the barriers and facilitators of EBI, evidence-based intervention uptake. Then we need guidelines and policies. And usually these are best for enabling and being localized. And they sort of inform and set the agenda and also the performance targets that are realistic. Then we need to also put together data systems that enable us to collect real-world data for implementation. And then you need to start opening this out, thinking about how well can we reorganize the delivery system. One of the things HIV has done so well and has taught us in Africa is that we can task shift. Task shift things we had never thought about, including circumcision. We thought we would need surgeons, but we're working with clinic officers, and in some places, well-trained nurses. And it's going on well. And in fact, you can talk about the events that have happened, and they're very few. And so we need to think about, of course, different care delivery models, retooling. Are we going to continue doing this the same way? And eventually, one of the key issues here is advocacy and stakeholder engagement. Who is interested and can contribute productively to this whole endeavor? I think with these lessons, I know that as I've showed you, you can see that even HIV, care is not yet there. It's still work in progress, but a lot has been gained and lots of lives have been saved. Thank you very much. I think that can help us kickstart this. Thank you.
So I'm going to be a bit naughty and ask the first question. So first of all, I'm also a very big advocate for cross-pollinating different strategies from different tumor types and different diseases. So my first question to you is, how do you think that we can utilize some of these things in pediatric oncology, for instance? How can we task shift in those things? And the other part is, when you were talking about the multi-component strategies, Professor Kathy Pritchard-Jones asked about how about speaking much easier to families rather than doctors doing that. Do you think that that could also be a strategy that we should focus more on so that they understand better what's going on from a very ground root level. Thank you.
Thank you. Good question. I think one of the things that HIV did was to make us humble. It made the doctor very humble and nimble in a way that you go down to the patient and you seek the patient to be part of the care team. We were very top down, but then we realized if we're going to keep these patients on lifelong treatment, we kind of have to walk the journey with them and they have to understand what they bring to the table. In that sense, I'll start with your second question. Yes, it's part of the stakeholder engagement. How can we improve their understanding of cancer? That sort of breaks the first level, usually stigma. One of the things I really like dealing with is talking about is HIV is stigma-driven. Cancer is also very stigmatized. And what we've learned is the more you talk about it, the more the patients understand it. And hence, they can be part of the treatment and they can be more compliant. This whole issue we talk about patients not returning, you give someone some cycles of treatment and you know, they are struggling to maintain their appointments. And some of these can be broken by just making them become part of the team and seeing what is in it for them and making them own this treatment and own part of the process. I think that sort of looks at both questions that you bring in. If you had to ask me what things to learn, for me, one of the things that we can learn is to just bring the patients more to the table. Let's break down the science in ways they can understand. I know it's complicated. It's always complicated. I know even a very simple disease can be very complicated. But we learned it, we can teach it to our patients. Just let me know if I've answered both questions, but I think I have.
It's good.
Yeah.
So you see more or less 20 people in the room. So there's 20 people that's going to go and check how they can include their families and children more in understanding their own diseases. SIOP in Africa will be in 2024. So you've got 2 years to do that. Any questions from the audience to Doctor? Because if there's no questions, I'd like to move on to the next speaker. That's a very enlightening question, and I hope that everybody is thinking about how they can cross-pollinate different health systems and different questions.
Thank you.
Okay. So our next speaker, I know from experience, has a lot of questions that he still has to ask. So Africa has come quite a long way in setting up oncology units. So our next speaker is Dr. Jonas Nsingiyumva, and him and Dr. Estella Gatketse are looking to start pediatric oncology services or improving, well, pushing it forward in Burundi. And he is going to tell us how they try to see what the burdens were and what they needed to put those systems in place.
Good afternoon, everyone. My name is Dr. Jonas Nsingiyumva, as have been introduced. I work in the Ministry of Health in the program of NCDs, where I head the Department of Oncology, and also I supervise the cancer registry, which is based on the population of Bujumbura. We'll be talking about the burden of childhood cancer in Burundi.
Just press the green button.
Okay, I have no disclosure. As the background, until the end of 2020, Burundi had no pediatric oncology services, and there were no management services beyond limited palliative care, despite the needed for childhood cancer treatment. There is an absence of adulthood and the childhood cancer services. Only one private cancer unit since 2021, one public pathology laboratory, and one private lab. Childhood cancer numbers has never been documented. Concerning the aim and objectives, the main aim is to describe the childhood cancer services and the disease spectrum in Burundi. As the objectives, we are to determine the burden of childhood cancer in Burundi, to evaluate the management resources in the country, assess national health policies for establishing pediatric oncology services in Burundi. The methodology that we used, we visited 24 referral hospitals in 4 regions, and the period we covered was from January 2017 to June 2021. The hospital's resources for the management of childhood cancer were documented. A search of government documents on chronic illness and the cancer care was done on Google and the PubMed. Direct contact was made with the Department of Health for cancer policies. During our study, for the 5 years, we got 161 cases diagnosed with cancer, where, as you can see, the retinoblastoma was very much, and further where we tell you why we had so many cases of retinoblastoma, followed by lymphoma, leukemia, and nephroblastoma. That is the chart for the results. For the resources for pediatric oncology in Burundi, about ward treating children, apart from a private hospital which has just opened. This hospital is a private hospital where one pediatric oncologist who did his training at JFOP is working actually. He decided to open a cancer center. But you can still understand it's very hard for Burundi as a low-income country where most of the population is poor, so affording the private sector, it's very hard for them, meaning we are like not treating actually because they cannot afford the money to go to the private. No public health establishment currently has a service for the management of adult or childhood in Burundi. As with cancers, there is no palliative care services in Burundi. The holistic management, physical, psychological, and spiritual of the problem encountered by patients and their families is therefore not ensured. I have to tell you that we don't have the really palliative care as it is being done in its really meaning. And also, most of the time when the patients are diagnosed cancer, physicians or doctors, they don't tell it to the patient. They hide it. Sometimes, most of the patients are dying without knowing their diagnosis, and that is not a very good thing. And also, the other time is when they find it's cancer and they are not doing palliative care, they do send them at home, waiting for dying. And this is very, very, very thing which is not very good. For doctors with pediatric oncology training, I've said you have one, and equipment we don't have, such as radiology, pathology, radiation oncology, medical physics, and the nuclear medicine. The same is for the physician specialists in pediatric oncology. There I can say at least now we have one in nuclear medicine, and one in adult oncology who has finished in China. And for the equipment, we are not having radiotherapy, you can understand. No chemo is being given in Burundi. We don't even have drugs as chemo. The only thing I've done so far, I managed to put the cancer drug on his list of essential medicine in Burundi. Nursing staff with pediatric training, we can also understand they are not. We don't have nurses that are trained in the management of cancer patients. First of all, we don't have schools there, and also we don't have people to train them. The school, we don't have school of oncology in Burundi. For surgeons, radiologists, and the radiotherapists, Burundi does not have a national specialized training program for oncology, as I've just said, including medical oncologists, surgical oncology, and radiation oncology. We only have teaching university, which has, we do general medicine for specialties, we are doing them abroad. Yes, but the 2 years for other like gyna, pediatric, internal medicine, they are being done in Burundi and they go to finish them abroad. Nuclear medicine specialists, medical physicists, biomedical engineering, and the radiographers, radiotherapy, which remains a major challenge in the field of pediatric oncology. As a discussion, the number of children diagnosed cancer in our study is 161 children diagnosed with cancers during our study. And we have seen, as I've said, that retinoblastoma was the major diagnosis just because it is easy to diagnose. It looks at you as you look at it. That is why maybe we have so many cases of retinoblastoma than any other cancer. It doesn't mean retinoblastoma is the main leading diagnosis of cancer. The expected number to be diagnosed according to our population is supposed to be 500 children per year. And for the 5 years, we're supposed to have around at least 2,000 cases. But as you can see, we are having 161. This means many cases are being missed. We are not diagnosing, we are not doing the right thing to do. This number is more due to lack of cancer diagnosis equipment. As I've said, we only have 2 anatomopathology lab, one in public, another one in private. And just to tell you that this private has just started recently in 2019. That is when we opened it. And for the public, it was once not working since 2012, 13, up to 2019, where we got funds from EXA, East, Central, and the South African Health Community, through the World Bank, where they gave us some equipment for renewing the laboratory. We have also to say that the fact of not treating, it discourages patients to attend the hospitals. Many patients, when they have things like tumors or whatever, they will be visiting traditional healers. Others will go to church for prayers. And also, this number is still low because there is no sensitization being done on a high level. First of all, we had no people before. We train, because we are now training at EJFOP. We are 2 now, and we have at least visited, those hospitals visited, we have explained them the major signs of childhood cancer. Hope it will improve something. And also the number of children died out of the cancer in our study. We could not get the number of children who died out of cancer. As far as we are not treating, we cannot decide this child died because of cancer. They just find another diagnosis, which is like an underlying disease, an infection, whatever. That is what they write in the medical form, because they don't have the real diagnosis well documented. The cause of death in the medical field, as I've said, not to reflect the true cause of death. Other children are referred abroad for further management, and many of these, they disappear from our data. Those who have the means to be treated, they will come to UCI. Others will go to Rwanda, others will go to India, Europe, depending on the means of the family. And most of the cases, they never come back to the facilities because they do come back with chemo prescribed, and they will be visiting private hospitals for just chemo administration. Concerning the government policies, the government has put in place a department in charge of cancer in NCDs, and that department started with me in 18 December 2018, when I was nominated as National Cancer Focal Person and also head of Oncology Department. And that is when we started to, at least to implement some policies, to talk about cancer, to put up a cancer registry, and they do other things. A population-based cancer registry, as I've said, has been created since 2019, at the time being a commission in charge. At this time, we're also having a national commission, which has been nominated to study how to put in place a national cancer center which will be like a referral one. A pathology laboratory has been renovated, as I said, in Kamenge, teaching in the referral hospital. As a conclusion and recommendation, the true burden of childhood cancer cannot be determined due to insufficient data. The most common cancer are retinoblastoma, lymphoma, and leukemia, but I doubt this because we are not doing well in diagnosis. Resources exist to start pediatric oncology services beyond palliative care, because we are having people who are trained and who are willing to start the center. More medical pediatria in pediatric oncology and the nursing skills for management are needed. Government policies should be developed to establish, support, facilitate access to childhood cancer care. Thank you very much. Murakoze.
Thank you very much, Jonas. We've got 1 minute if there is a question. But if there's no questions, I think the next speaker is going to be of great value to you, Jonas, because it is Dr. Is there any questions? No questions. Thank you, Jonas. So the next, a hand for the man. Come on. There we go. So the next speaker is Dr. Mimi Ndela Dio from Senegal, and I probably pronounced that incorrectly. Was it okay? You look beautiful, by the way. She was at my workshop and she was dressed just as impeccably. And she's going to tell us about the implementation of early diagnosis programs for 5 childhood cancers in her region. And I think Jonas, you can, and Estella, you can really have a listen to this talk.
Thank you. Very good afternoon to everyone here. I'm Dr. Mam Ndela Diouf. I'm a pediatric oncologist from Senegal. I'm delighted this afternoon to share with you our experience for the implementation of early diagnosis program for 5 childhood cancer in Africa. So it's a progress report from GFAOP and Institut Jean Lemerle. Every year, nearly 15,000 children have cancer in Africa, in sub-Saharan Africa. Only 40% have diagnosis, and 30% arrive at a late stage. Unfortunately, our cure rate is very low, less than 20%. In other low-income countries, like in sub-Saharan Africa, delayed diagnosis is the first cause of death by cancer in childhood. Because cancer is not avoidable, early diagnosis is very important. It's an essential step to better care for children, to increase the chance of recovery, to reduce the cost of treatments. So developing early diagnostic tools, training healthcare givers, and as well as raising awareness among population is paramount to improve survival rates. How we did that? 2 workshops on designing and validating childhood cancer education and awareness tools were conducted in Senegal in 2019 with pediatric oncologists from 10 countries in Africa and health authorities from Senegal, the Ministry of Health and the National School of Nurses and Midwives. So that we developed and harmonized educational modules on detection of early signs, leading to the diagnostic of 5 main cancers for children: retinoblastoma, acute lymphoblastic leukemia, Riem's tumor, Burkitt, and Hodgkin lymphoma. So manuals, flyers, posters intended for general practitioners, nurses, and other health caregivers have been developed to train trainees and then to train healthcare givers. All these tools had appropriated educational content. So this is, at the left, the trainer's guide, and at the right, you can see the provider's manual. There were also the technical sheets for each disease. In red, you have acute lymphoblastic leukemia. In green, lymphoma of Burkitt, retinoblastoma in blue, in brown, nephroblastoma, Wilms tumor, and Hodgkin disease in green. There were posters for the general public, and you can see on the poster pictures with the early signs for the general public to detect these cancers. So between 2019 and 2091, there was a first stage in Senegal. It was the pilot phase. After that, there were extension in 7 countries in sub-Saharan Africa. Democratic Republic of Congo at Lumumbashi and Kinshasa, Ivory Coast, Mali in Sikasso, Guinea, Burkina Faso in Bobo-Dioulasso and Ouagadougou, in Benin and Niger. With this, they were also relaying information to the general population through the press. So in every country, there was specific training according of the situation of the country and the conditions. And there were an involvement of the health authorities. So we had 1,045 people trained on early diagnosis of childhood cancer in these 8 countries. In this picture, you can see the trained health provider by country and categories. So we trained 79 pediatricians, 361 general practitioners, 400 nurses, 57 midwives, 118 other health providers. I mean seniors health technicians, community health workers, the staff of the Ministry of Health, and communicators. What did we learn from this program? We learned that it is easier to implement a program where there is the involvement of the health authorities. After that, it is possible to have the mutualization with other associations. We had positive feedback from the trainees and the trainers too, and it is possible to have a rapid referral of children if the health providers are trained. But we have seen that it is rare for the health provider to have a counter-referral or a feedback. And we need to develop e-learning for the trainings. Our perspective is first to increase the training capacity. We want to reach at last 1,000 health workers every year, and to expand the training in the other countries of sub-African side, and to reach more people in each territory using the digital training. It's also important to strengthen advocacy and raise awareness among the general public. It's also paramount to do the supervision and retraining of trained providers. It has begun in Senegal. So we have do the supervision for 3 hospitals. And when we are there, the first thing we do is to look if the posters are displayed on the waiting room for the general public. And after we ask to the health provider if he has the sheets, the manuals, and we do an evaluation. We ask a question to know what he has written of the formation. And at the, we also have to find the way to track the referral of children identified by trainers. So I will end this presentation by saying that African children with cancer can and should be treated effectively in Africa by trained Africa teams. Thank you for your attention.
Are there any questions? Can somebody just give the microphone, please?
Thank you very much for your presentation. My name is Rachel Ngum from Uganda. And my question would be, have you been able to analyze what this advocacy and training, what impact it has made on, one, the number of children diagnosed, and secondly, on the stage of disease at which they come? Thank you.
I can answer. Thank you. What we can say is we are in the first step. So it's a step where we interact with the healthcare givers. So for the general public, we are supposed to do advocacy by the major. There is the spot for each pathology we will make for the general public. But what we know is that the trained health givers, they send us messages, they call us to know when they have children with signs. So we can discuss and tell him to bring the boy, the child, or to let it to look another, to bring him in another country. My English is bad. I'm sorry.
No.
What we can say is that we didn't see a very high changement. So we hope that it will come after, because like I said it in the presentation, the training was in 2019. So the supervision, we had begun it this year. So they are 2 years between the training and the supervision. They have forgotten many things, but when we go there, we try to explain, to I don't know how to say it.
So if I can summarize what you're
Yes.
saying is that this is the first step in implementing this program. You're already
Yeah.
getting verbal feedback that they are picking up the signs and everything. In the future, you will look at what the impact is. But I think on a personal basis that 3 years is a bit early to see improvement in your staging of your diseases. But you explained yourself very adequately. Thank you very much. Okay. We're running far behind time, so I'm not going to allow another question. Thank you very much, Doctor.
Thank you.
So our next speaker is going to kill me because the name is a bit difficult. Aline Budiongu. Speaker here? Eline Budiongo. Speaker not here. Oh, then we're catching up on time. Very good. So you will be able to. I can't hear you. Sorry. It's okay. I have not gotten word that somebody else is doing it. Do we have a pre-recording for it? Raise your hand at the back. Not at all. Okay, so nobody. So it's okay. Which is actually good news for you because we might make coffee on time. So let's go to the next speaker, who is Dr. Richard Nyeko. It's one of our fellows at the UCI, and he is going to talk to us about what the value is of a multidisciplinary team to improve the management of children with brain tumors. It's a bit sad that Eileen is not here because, her talk would have really explained to us what having early access and easy access would have made. The next step is obviously what your multidisciplinary team will be doing. So, Richard, take it away.
Okay, thank you. Good afternoon. I'm Richard Nyeko from the Uganda Cancer Institute. I'm just going to share with you what we did to understand our pediatric neuro-oncology services at the Uganda Cancer Institute. So we looked at the value of a multidisciplinary team towards management of pediatric neuro-oncology in UCI, but by extension in Uganda. No disclosures to make. It's a common knowledge that pediatric cancer outcome in low-income countries is still poor, and pediatric neuro-oncology is not an exception. And worldwide, multidisciplinary management has been accepted as the gold standard of care. More importantly, as far as pediatric neuro-oncology is concerned. And in our perspective, pediatric neuro-oncology services, it's still actually in its infancy. Until now, we didn't know the scope of the cases that we see at the unit, at the facility, and as far as what impact the multidisciplinary management has had on as far as management of pediatric neuro-oncology is concerned. So a bit of the statistic, I think yesterday we had a good background on UCI. It was founded more than 50 years ago, and it's the National Cancer Reference Center in the country, serving a population of about 42 million, one of the youngest population actually. More than half of this population are children below 18 years. While the facility has existed for more than 50 years, it was not until recently, in 2012, that a dedicated pediatric oncology services was established, receiving more than 500 cases every year. And it's not until around about towards the end of 2020, beginning of 2021, that we started thinking of the aspect of pediatric neuro-oncology, and that's when a dedicated pediatric neuro-oncology tumor board was put in place with the members that span through the team, pediatric oncologists, neurosurgeons, radiologists, radiation oncologists, the nurses, and a number of others. So we wanted to review the services at the UCI as far as pediatric neuro-oncology and the extent to which the MDT is contributing to the outcome of these patients. Specifically, we also wanted to get the perspective of the team that constitutes the MDT team with respect to pediatric neuro-oncology. We also wanted to characterize, as I said, until now we didn't know what kind of pediatric neuro-oncology cases we have been dealing with. So we wanted to characterize the common cases that we have been seeing at the unit and to assess the management of these patients in light of the MDT. So we undertook a retrospective review of our records, 2017 till around July of 2021. That's about 4.5 years, around there, trying to extract the demographics, diagnosis, management, and also trying to see the extent to which the management plan that originates from the MDT acted upon. We also got perspectives from the members that constitute the MDT. I wanted to know their views as far as pediatric neuro-oncology in Uganda as a whole is concerned. What is their perspectives or thinking about the major barriers that hinder the management of these patients, and also the effectiveness of the multidisciplinary team. So just wanted to share with you 3 key findings that we noted from the survey when we did a survey among the members that constituted the team. As we can see, and rightly so, majority of the members actually observe that what we are seeing at UC High as cases of pediatric neuro-oncology are actually not representative of the national picture. And there's a general belief that most of these children are probably dying somewhere. They are not being recognized. They are not being diagnosed appropriately, probably. But even those who end up in some of these facilities, peripheral facilities, even the major facilities, our referral system still disadvantages them so that they don't reach the treatment centers. But I think again, more encouraging was their views that pediatric neuro-oncology services, especially at the UCI, has actually improved over the years, especially over the last few years. 69% thought we are on the right track, and therefore we wanted to really capitalize on that and move these care services forward. When we sought their views on the barriers that hinder pediatric neuro-oncology services in the country, I think the big two barriers that stood up were neuro-oncology services and imaging. UCI does not have a resident neurosurgeon. Actually, most of the neuro-oncology surgery in the country is done about 245 kilometers away from Kampala. So that's a big challenge. The other challenge is the imaging. We have a CT scan in the unit, but even the CT scan accessibility is a challenge because patients have to pay. But also the team would have loved, and rightly so, that at this time and age, we needed an MRI as one of the important diagnostic modality as far as neuro-oncology is concerned. Of course, diversity of the multidisciplinary team was also came up as an important barrier. The team actually noted that, well, we have more or less most of the members, but consistency in attendance is a big problem. Today you have neurosurgeon, the next time you don't have. But also with respect to survivorship, important services like endocrinologists, special learning, rehabilitation, we don't have those cadres as part of our team. When we reviewed the records, we were able to identify 31 cases of pediatric neuro-oncology that were registered in the unit from 2017 to around mid-2021. But I must add that this data is limited by the retrospective nature of the study, of the assessment. And for the early years, it was quite difficult to actually retrieve and get the files. Much as the record shows there were quite some numbers, but we were not able to retrieve the files. So these were the ones we were able to get our hands on. But as you can see, still, progressively over time, we are seeing an increase in the number of cases that present to the Cancer Institute. Most of the patients, 48% were in the age group of 5 to 9 years, with a median age of 8 years, and a male to female ratio of about 1.2 to 1.
Richard, you have 2 minutes.
In terms of the common diagnoses, craniopharyngioma and astrocytoma were the most commonly documented diagnoses. Some of these were they were not histopathological diagnoses. They were either through imaging and clinical diagnosis. and the median duration to presentation was about 6 months. So in terms of MDT, we can see an increasing trend as far as MDT discussion of the cases is concerned over the years. And overall, 64.5% of the cases that we were able to come across were discussed in the MDT. And in terms of actions on the recommendations of the MDT, there's also been an increasing trend in terms of actions taken. The major decisions that were arrived at, there are many, but I just wanted to point out the 3 key ones. As we see, chemotherapy and radiotherapy, these are services that are within the facility, and therefore, in terms of action vis-a-vis recommendations, I think there's a very close correlation, as opposed to surgery, where the services are, the patients have to get it from quite some distance, and also it costs money and time. And in overall, 66.7% of the decisions that were taken in the MDT were actually followed through and acted upon. Of course, surgical decisions remain the least acted on. We just try to also to relate the actions that were taken as far as MDT recommendations are concerned vis-a-vis the current status of these patients. And the key, I think that findings that we can point at, of course, we did not do any statistical analysis to correlate this, but we can clearly see that for the patients for whom the recommendations were acted on, majority actually are still currently active in care, as opposed to those that for whom the MDT recommendations were not acted on. Quite a number of them had abandoned treatment and either lost to follow-up and died. So in conclusion, we think very few of these children that have brain tumors and other associated neuro-oncology actually do present and get healthcare services in Uganda. Most of them actually probably die somewhere else. And therefore, pediatric neuro-oncology, MD, multidisciplinary management is an essential part of improving patients' care. Implementation of the decisions taken is still relatively low when you compare to what other reported in other places, ranging from 79 to 99% of the recommendations being followed through and acted on. So ours is still relatively low, and therefore improved implementation of whatever decisions that come from the MDT needs to be improved. We think this can be enhanced when we develop a tracker kind of to see that there's a clear follow through from the time the patients are discussed, so that we don't lose track of and then we realize later on that, this patient is no longer in care. We also need to explore the barriers that actually tend to impede implementation of the decisions that we normally take. Of course, as I mentioned earlier, this data is limited by the retrospective nature of the assessment, and therefore um, it's probably not a true picture of what we have at UCI, but we think it still gives us quite a good idea of really what our situation is like. I would want to acknowledge the team at the pediatric unit of the UCI, the MDT members, the SIOP Africa for this opportunity, and last but not least, Dr. Jacks. Thanks.
And with that, I'm going to throw you off the stage. So you've gone over your time, so I'm going to ask you to sit down. There's another speaker that's got a very similar theme, so if we take questions, both of you can answer those. So our next speaker comes from Niger, and she's Aishatu Mahamadu. Is that correct? Oh, goodness. Afterwards, I'd like a lesson in French names, please. And she's going to tell us about her experience at her hospital. I know a little bit because she was in my workshop, which is going to be very illuminating. So.
Good afternoon to everyone. I am from Niger. I am a French speaker, but I will try to speak in English. Donc, we will talk about pediatric cancer in hospital practice in Niamey, Niger, about 164 cases studies. How does this thing work? Okay. Donc, Niger is a population of 24.2 million of population in 2020, and it's located in the heart of the Sahel region in West Africa. The children under 15 years are 51.6% of the population. In Niger, pediatric cancer, which had long remained under silence, drowned out breast and cervical cancer, because before people know pediatric cancer, they are every day talking about what do you call it? Breast cancer, cervical cancer. But when SIOP come to help us to establish the unity of pediatric cancer, now the people start hearing about pediatric cancer. Before, we don't even know that there is pediatric cancer in Niger. When we start the work is in March 2016, and for per years we have 16 to 18 patients. But if we go on what the World Health Organization says, we have 10 to 15 children over 100,000. And we are registered 60 to 18 children per year, what is not the goal of the World Health Organization. And half of them are coming with advanced stage. The management of childhood cancer remains difficult due to the lack of awareness of symptoms among families and even among health cancer. Even some physicians didn't know about, if I take retinoblastoma, they didn't even know how to look about this signs, the sign of retinoblastoma. Due to limited access to diagnosis and shortage of essential diagnosis, the consequence of all this is delay in the diagnosis, the discontinuation of treatment, and high mortality. What is the objective of these studies? Is to describe the practice in the pediatric oncology unit and to report on the demographic, diagnostic, therapeutic, and follow-up aspects of patients admitted in our unit. The study is descriptive cross-sectional studies of the patient medical record on the register that we are using and on their files. What is our result now? On socio-demographic aspects, we have registered 164 children. And the mean age was 4.9. The sex ratio was 1.4. As we see, this is the map of Niger. Our patients are coming from all over the country. What is now the aspect, the diagnostic aspect? If the type of cancer we have registered is the first one is retinoblastoma, followed by nephroblastoma and lymphoma. You can say maybe there is no leukemia or Burkitt lymphoma because they are treating them in another hospital where there is a hematologist. On clinical sign, we focus on retinoblastoma because he is the first cancer that we registered in the unit. But I didn't say in all the Niger, but in the units we have, it's the first cancer we have. Half of the patients who are coming with retinoblastoma have come with advanced stage. Sorry, eh? We, among all our patients that we registered, we have 81 cases that have has diagnosed, confirmed. We confirmed the diagnosis, but 83, some of them had been treated, but on their clinical signs or the history of the disease. Now, if we come to talk about treatment status, we start treating 150,000, but only 32 patients accomplish the treatment. And among them, we have 41 abandonment of the treatment. Some of them abandon the treatment even before we start the chemotherapy. Some of them we start, but they lost the treatment. They didn't accomplish it. Among these children, we register 55 deaths. Some of them died before we started the chemotherapy. Some of them died during the treatment because many of them that we start treating, they come with advanced stage. After treatment, we lost 60.1% of the children, and many of them are the children who comes with retinoblastoma at advanced treatment stage. Sorry. If we talk about the evolution of the cases, during the study, we have 40 cases that are alive. We registered 34% of cases that dead. That if I say like 55 patients dead among the 164, and 24 patients abandoned the treatment during or before the treatment. And we lost, we look about Niger, the population is 24. So that we supposed to have 1,000 to 1,000.5 children that are coming for treatment, but we register only 60 to 80 patients. Among the patient will, and we say we have to act. And we start acting. There is some of acts that which are going on. We have now a team of multidisciplinarity. If the child comes for retinoblastoma or neuroblastoma, among the five cancer that the JFIOP is supporting, if this child comes, we have to talk to them from the day the child arrives in the unit or in any other place that the doctor who saw the children is among the team of multidisciplinarity. We train on the early diagnosis from the program of GFIOP that, what do you call her? The president speaker she talked about early diagnosis. Donc we are in this program. We start this training on November. From November to before I come, we registered already 28 cases. Some of them are late diagnosis, but among them we have 8 that come early. So if we continue, I think that we will go above the patient we are now registered. We have 60 to 80 patients. We are raising awareness about the early signs of childhood cancer in health school. The students who are on their way to finish the school, we go to them and tell them about the cancer, and they see that if they go to start their work, they have to look onto this sign for them to send us the children early, because all the patients start with the nurse before they reach the doctors. There is we call it a house of life. I don't know, some of areas they call it with other name. But this house now is already done. We don't have now problem for people. We can come, they say they don't have where to stay. The place is already prepped. Oh, sorry. Okay. The place is ready. We have some perspective to improve how we are doing, how we are taking care of the patients who are coming in our place. We want to align with the objective of the World Health Organization initiative through many actions. Design a strategic plan for the management of childhood cancer in Niger, developing multidisciplinary guidelines. We already finished 3 guidelines of the 5 retinoblastoma for cancer. We established a regional pediatric cancer registry and organized national data collection, so that every 6 months we will go around the region to see what they collect, and we will come with that, so we can collect every year. We can say that we have tell amount of numbers of patients. The training of early diagnosis will continue by the grace of God. We will improve the technical platform for accurate diagnosis and quality of treatment. This is already ongoing in our Ministry of Health. They are looking how to develop our platform for accurate diagnosis, because many of them, sometimes even they do a pathology, they cannot tell us, is this cancer or this cancer. Many times they send us to diagnosis, so we have to go to look onto the sign that the children come with and the history of his disease.
Vous avez seulement 2 minutes.
Oui. We are about to create an association of parents for a child who has cancer to collect funds for treatment because our Ministry of Health is doing his best. GFF is doing his best, but we have to get money from the other side so we cannot be missing the treatment of the patients. In the conclusion, the proper management of pediatric cancer in Niger is a major challenge for all Nigerians and the partners who have committed to accompany us in this struggle. In view of the result of the study, the design of a strategic plan for the management of childhood cancer in Niger is an absolute necessity. The ultimate goal is to comply with the World Health Organization Global Initiative for childhood cancer, aiming at 60% survival rate by 2030. Thank you for listening.
Giving you a hand for your very good English was right. Thank you for trying in English. This is certainly very interesting and very important information that you've been giving. But I'll allow questions maybe afterwards, if you don't mind. So our next speaker is Dr. Wanjiru. Is Dr. Wanjiru here? Not to come tell us about setting up a day of care in an oncology center at Tertiary Hospital in Nairobi, Kenya. Any Kenyans in the room? I think they're already drinking the coffee that they so amply make in their country. Yeah, Lillian, hi. Now you need to speak to your countrymen. Nah. Oh. Okay, so the next speaker will go over to Dr. Pierre Togo. Dr. Togo, are you here? Oh, another person that's already gone to drink coffee, but maybe he's just elaborating on his tele experience. Is he not here? It's okay. Okay, no problem. We're coming much closer to coffee, it seems. So, tell me that Dr. Mwebe Katasi is here. Yes! What an amazing closer for us to know today. And I'm really excited to hear your experience that is probably complementing Dr. Nyeko's talk. And she's going to tell us about building a model for pediatric neuro-oncology program in sub-Saharan Africa. And you also look beautiful. All the women has been really it's amazing, the most amazing fashions that we have in Africa. Very proud of you.
Okay, so good afternoon, all of you. I am going to tell you about the work that we are doing currently in Uganda to build our pediatric neuro-oncology program, and I'm hoping that this can be a model for East Africa because there's no dedicated pediatric neuro-oncology program in East Africa and also sub-Saharan Africa. So the title of my presentation is Building a Model Pediatric Neuro-Oncology Program in Sub-Saharan Africa. It is a report of the initial experience in establishing a dedicated pediatric neuro-oncology program in Uganda. My name, as I've been introduced, I'm Dr. Mwebe Victoria Katasi. I'm a trained pediatric neuro-oncologist and hematologist practicing in Mulago National Referral Hospital under the Pediatric Hematology Oncology Fellowship Program. So I have no conflicts of interest to disclose. So the background that we see that pediatric central nervous system tumors are reported as the most common solid tumors in children, and the second most common childhood cancer globally, but also the leading cause of malignancy-related deaths in children. And most of these studies are coming from the developed world. We don't have a lot of this data currently in the low and middle-income countries. So there's sparsity of data, as you see in sub-Saharan Africa, and this is evidenced by very few published studies. I tried to do a search, and I could only come up with 2 in Uganda, and generally less than 5 in the whole of East Africa. In East Africa, there is currently no single dedicated pediatric neuro-oncology service as we speak, so we are just trying to start up one in Uganda currently. And the studies based in the USA have also estimated that the total cost of treatment for the first year after a brain tumor diagnosis, and this is for a single child, is $32,000 to $45,000 US dollars. That's a lot of money. And the subsequent annual costs are $4,000 to $8,000 US dollars. So this cost is really too high for our facilities here in low resource settings to incur on our own. So Uganda currently ranks as the 8th most populated country in Africa, with a population of approximately 45 million people, and 50% of our Ugandan population is below 18 years of age. And this is why this is important, because that means that most of the brain tumors are actually going to be in children. So there are 11 trained pediatric oncologists currently in Uganda, and 1 hematopathologist, all practicing within Uganda at 3 main sites, of which 1 has an additional subspecialty training in pediatric neuro-oncology. That's me at the Mulago National Referral Hospital. I currently work with 7 other pediatric oncologists in addition. And saying that this is a fellowship program, we also have fellows, 4 fellows in addition, plus other medical officers who are interested in the field of pediatric oncology and hematology. So there are 2 main hospitals offering pediatric neuro services in this country. 1 is at the Mulago National Referral Hospital, which is a main referral hospital and where this program is set up. And the second one is in a hospital called Cure Mbale. It's about 5 hours drive, I must say, from the city. So the Mulago National Referral Hospital neurosurgery unit has both an inpatient and an outpatient service, but it serves both adults and children, and so their inpatient service has a mixture of children and adults. We are yet in the process of discussing with them how to actually have a separate pediatric unit to make it easier for the neurosurgeons to manage the children alone. Their inpatient wing has a bed capacity of 53. They have 7 neurosurgeons currently. And on average, they review about 1 new pediatric brain tumor patient weekly in their clinic. The Cure Hospital is a Christian non-profit dedicated pediatric neurosurgery center with inpatient and outpatient services, has a bed capacity of about 52. They have 10 ICU beds and they currently have 4 high dependency unit beds. They have actually a very good ICU I have visited. They have 2 neurosurgeons currently and also work with other medical officers. And on average, they operate on about 3 new pediatric brain tumor patients monthly. So the patients that we see come through both the neurosurgery services, but also some come directly to the oncology service. So the objective of this report was to establish or to describe the initial steps taken in the establishment of the pediatric neuro-oncology program at the Mulago National Referral Hospital. So the Mulago National Referral Hospital Pediatric Neuro-Oncology Service was birthed from the Pediatric Hematology Oncology Fellowship Program, currently at Mulago National Referral Hospital, which was established in February of 2018. The above is a collaboration between the Mulago National Referral Hospital, Makerere University, Texas Children's Hospital under the Global Hope Program, and the Baylor College of Medicine. So under the Global Hope Program, we have been able to train 14 pediatric oncologists, 1 pharmacist, and 8 oncology nurses since 2014 to date, providing a foundation for pediatric oncology services in this region. And this was followed by a training of super specialists. That's 1 pediatric neuro-oncologist, who is myself, and 1 neurosurgeon currently, who is now back in Mulago to lead the pediatric neuro-oncology team. So the aim for this program is to provide a dedicated pediatric neuro-oncology service in Uganda, East Africa, and moving on to sub-Saharan Africa through advocacy among the health workers and the general population, and also provision of curative and palliative care services plus relevant research in this field. So the components of this pediatric neuro-oncology service include a multidisciplinary team, care, and multidisciplinary tumor boards. So our multidisciplinary team being based, the program being based within the National Referral Hospital means that we have access to all the different multidisciplinary services that we have, and that was the reason why I thought it was strategic to be within the National Referral Hospital. So team includes the neurosurgeons. Like I said, there are 7 neurosurgeons, but also they have fellows. Currently, they have 3 fellows, and also the surgery residents that rotate on their unit as well, and interns. So all those help within the service. Then we also have radiation oncologists who are within the Uganda Cancer Institute. So we use the same radiation service for the whole of Uganda. And ophthalmologists, we have 1 point ophthalmologist who actually helps out with the children with cancer and especially the brain tumors as well. The service is also within Mulago. We have an endocrinologist leading, one of my mentors. We have neurologists who are also within the department, 2 active neurologists, occupational therapists, the oncologists, who I said we have a team of about 7 currently, oncology nurses, oncology pharmacists. So far we have 1 oncology pharmacist plus 3 other technical staff that she works with. And we also have a consultant neuro-oncologist at Texas Children's Hospital in the USA who is my mentor. And so we are currently in touch in case I have any other difficult cases that we need to discuss. The oncology care for the patient is provided primarily in both an outpatient and inpatient service. So we have an outpatient clinic that runs on a daily basis from Monday to Friday, and we do and we have the brain tumors, especially on Tuesdays and Thursdays. However, they can come in on any other day, and on those days, if I'm not available, I could be consulted. But also I'm trying to build capacity so that the rest of the team can know how to start and manage the patients even when I am away, because I also work in the ICU as well. So that's a picture of part of our team, the medical officer, one of the fellows, and the nurses. And the picture above is a picture of our outpatient clinic, actually. So those are the infusion beds for the chemotherapy, as you can see. So part of our activities have also included a lot of advocacy. As you know, for cancer care, we need to let the public know that cancer is a problem and that these children need to be treated. Yes, they can be treated and they can be cured. So part of the things that we have done have included, 1, in the hospital itself, Mulago National Referral Hospital, we have given continuous medical education sessions. So I have taken part in grand rounds to educate the pediatricians, the postgraduate students and undergraduates about brain cancers. How can they recognize a child who has a brain tumor? What are the first symptoms that you can see and signs? And what should you do if you see a child, and create better referral pathways? Also, in addition, I take part in tutorials for the postgraduates and the undergraduates, especially for the brain tumors, just so to make sure that we are passing the right information and also to equip them with what they need to know when they go out in the field, at least to know how to recognize and then know how to refer and where to refer the children. We've also done advocacy programs like media, so we do television shows. I have been on 2 of them, one on one of the television shows here called NBS, and one is called NTV. And in this we are really trying to improve the awareness of the general public about pediatric cancers, and especially also these brain tumors, so that people know that this is a real problem. It is there, but it can be dealt with. So what are lessons learned as we are setting up this program? Like, you know, we are young. We've been here for about, we are making the 3rd year now. But currently we have noticed that multidisciplinary care is very essential to running a pediatric neuro-oncology service. You cannot run it alone as the oncologist. And so most of the work that we have to do is coordinating with neurosurgeons, the endocrinologists, ophthalmologists, radiation oncologists, and this is something that you have to do on a continuous basis. If you slack for even a week or 2 weeks, then you're actually going to fall behind in what you're doing. So we are having constant communication with them, and one of the things that has helped is that the neurosurgery ward is next to our outpatient clinic, so they can actually walk into clinic as we are seeing the patients, and so we sometimes do clinical reviews together, and that makes it easier to make decisions faster for the children and get them onto surgery. And then also collaborations between low-resource centers and resource-rich centers can greatly improve the care provided at the low-resource centers through supplementing on the available resources and providing expert consultations. Like you see, our collaboration is together with the Texas Children's Program through the Global Hope, and that was the way that I was able to have my training done at the Texas Children's, but also they are actually netly supporting the hospital, like equipping the ICU. They've actually also been able to help in hiring more of nurses, medical officers, and also are helping in training of these different specialties for oncology, plus also providing for our chemotherapy and also other diagnostics like the CT scans and the MRIs. And so this is really has helped to boost this service. And also more specialist training in pediatric neuro-oncology and the different supportive disciplines is still needed in our country, so as to ensure that all children with brain tumors get the necessary care in a timely manner. Seeing that we have 7 neurosurgeons at the site, that is still not enough. For a population of 45 million people, actually currently there's a total of about 13 to 14 neurosurgeons in the entire country. So if you look at our general population, that is still very little compared to the number of Ugandans that we have. So we need to boost up more of these, the radiation oncologists, the oncology nurses, all the different disciplines that you need to manage these children with brain tumors. So what are the strengths of having a collaborative model? As you see, we have a lot of stakeholders, the government itself, the Ministry of Health, the university itself, the Texas children, the funders, the hospital itself. So we have found that due to the subsidization in investigative and treatment costs from the Global Hope partners, the cost of treating each patient is much lower for us, and thus the care is more affordable by our patients, improving retention in care, because that one of the causes of abandonment in care is the fact that the costs would be very high. So this has really helped to subsidize costs a lot for the patients. We basically don't have a lot of out-of-pocket. We also provide transport for those who cannot afford, and we are also doing advocacy for psychosocial support, so through our friends and some organizations, so we get a bit of money to supplement for people who need things like a bit of food or when to come back, and now we're actually starting to help them with startup programs, like if a mother has been in the service for some time, she has a child, and she has no source of income because she spends all the time coming to hospital. We are putting together small funds to help each of these mothers to start up what they can. However, those funds are on loan, seeing that when their businesses pick up, they return, and then we can use that to help other patients. And then also we have an availability of an off-site, more experienced consultant in pediatric neuro-oncology who provides expert opinion in managing challenging patients, improving on the standard of care provided to these patients. So keeping in touch with the team that I trained with in Texas Children has helped a lot, because sometimes we'd have problems with interpreting radiology or pathology, and so sometimes we have to send the samples for second review. And maybe sometimes I meet a brain tumor that is quite challenging for me, so having that expertise to consult has also been a great help in making sure that the care that we are giving to these children is standard and up to date. So what are our challenges and the lessons that we have learned? Our challenges include fewer than expected referrals. I did not put the impact of the program here because I had a second abstract that was in poster form, and it showed that in these 2 years that we've started the program, we actually have now, at the time that the abstract was submitted, we had come to about 66 patients. Right now, we have close to 80 patients in this service, and that's a tremendous difference from what it used to be before when I was still at the UCI. But still, judging from the studies out there, you can see that for Uganda, our referrals are still less. I believe that they are less than they should be. So at this point, we are still at the point of pushing for referrals. We are coming up with more innovative ways, and currently I'm starting to sit in the clinic of the neurosurgeons, just so each week I can catch up some new brain tumors they may not send, and also working in the ICU, and there I catch some other brain tumors that they have operated that they may not have sent through their service. So looking for all ways to kind of catch the ones that may miss. And also because these neurosurgeons also work in private hospitals, they've come to get to know me, so even when they see their patients and operate them privately, they also invite me to go and review those patients, so those can also be registered in the service. So the other thing is late presentation in some patients, and realize that depending on how late the patient has come, cure may not be possible. Then expensive investigations like MRI, hormonal assays, these are currently being funded by our collaborators, but we know that the program is not going to stay forever. So we are still trying to look for ways to keep it going. And inadequate neurosurgery services in the country. Like I said, the neurosurgeons are so few compared to the general population, and radiotherapy challenges. The radiotherapy is present, but we do not have what the ideal should be for managing a child with brain tumor. And because we've so far for long been using 2D, which we've just currently started using a linear accelerator, there are a lot of complications with delivering that kind of radiotherapy to the brain of a growing child. So because of that, one, we have a lot of complications from the radiotherapy, but also because the time to wait is long, since it's only one service that serves the entire country. So we still have a challenge there. The lessons that we've learned are that multidisciplinary care is essential to running a pediatric neuro-oncology service, and that collaborations between low-resource centers and resource-rich centers can greatly improve the care provided at the former through supplementing on the available resources and providing expert consultations. So that are ongoing and future perspectives. So one of the things that we are looking at is more advocacy nationwide, so as to increase the catch rate of children with brain and spine cancers, And one of the things we had thought about is to engage the neurosurgeons more through having maybe like monthly discussions about brain tumors in the neurosurgery groups, just so they understand a bit more of why are we this passionate and pushing for us to be able to see every child with a brain tumor passing through the oncology service. Then establishing a support group for children with brain tumors and their patients is actually already in motion. And it was started by one of my parents whose child had died of DIPG. Last year, so the aim is to improve awareness and also advocate for funding for the children with brain tumors here in Uganda, and also increase funding for the program just so we can do more research and take the unit to where we can actually say this is a model, pediatric neuro-oncology unit that does, up-to-date and standard research, and also we can start training other people. More research and collaboration with other sites in sub-Saharan Africa, because if we are going to create protocols that work for us as Africa, we cannot just import protocols from the Western world. We need to actually study what we have here and then work together to create a continental brain tumor working group and protocols that work for us in that regard. Yes, I'm hoping that within the next maybe 3 to 5 years, we can start a process like that, starting from a national brain tumor program in Uganda, but moving on to East Africa and Sub-Saharan Africa, and through that we can conduct some clinical trials in the brain tumors so that we actually know what we are dealing with and also scale up the care for brain tumors for children on this continent. And in about 5 to 10 years' time, I'm hoping that we can start training pediatric neuro-oncologists in Africa, because the cost of training just one single pediatric neuro-oncologist out there in the developed world is extremely high. And unless you have somebody who is funding your study, it's going to be quite difficult for somebody to do it as out of pocket by themselves. So I think that this is also one of the goals that we need to have as we establish this service. We also start training people. Okay, so these are my acknowledgements to the Mulago National Referral Hospital, Pediatric Hematology Oncology Program, to the Global Hope Makere Hematology Oncology Program, and also the Pediatric Fellowship Program, and the fellows who are seated down there. They're all listed onto this work for the great work that they do in the service, and for SIOP Africa for giving us the chance to present to you what we are doing. Thank you.
That's a very enlightening talk, and it's very inspirational to see that we've got a neuro-oncologist outside of the higher income countries. Well done. While everybody's thinking of a question, I'd just like to ask you, so what plans do you have for rehabilitation services for children? Because we know that neuro-oncology patients come with a lot of long-term care. And the other thing is, do you have plans in motion to provide your services to Mbara and the UCI as well, because those are obviously two centers that also see a lot of patients, and your services could be very valuable in those two centers.
Okay, thank you, Jack, for those questions. So for the rehabilitation services, I must say that has been one of the challenges that we've had, especially for the children who have gotten surgery and probably end up with something like posterior fossa syndrome, like the medulloblastomas. Their rehabilitation is quite difficult. Currently, we have a visiting physiotherapist, occupational therapist, who is part of the Mulago National Referral Hospital. And so he passes by the ward at least twice a week. If you want him to come more times, you can call him more times. But I think it's a service that we still need to strengthen a bit more, because rehabilitation for brain tumors is something that is more long-term than that. And then about scaling up the services to UCI and Mbarara. So currently I'm actually in collaboration with the Mbarara team. They send me the patients that they have. And also there are some that I see at the site, but can be managed in Mbarara because it's easier for them to come. So I send them back, but discuss the protocols. And when they need to review, like do CT scans, they send them back. We do the CT scans. That's how we are working. So for the UCI, not yet, but I'm in discussion with them to see if that is something that we can actually do, because I'm hoping it's better if we centralize the care of the kids with brain tumors. So we'll see how that goes. Yeah, thank you.
It's amazing service. Barnabas, I hope you use her services. I can see you in the audience. Any questions from the audience? You may also direct a question to Dr. Nyeko, because I promised that the two of them can discuss brain tumors together. Any other questions? Or is everybody wanting coffee? Is that it? Let's give a hand. People, you've been a great audience. Thank you for all the people that presented. I can see you're very committed, and I'd love to see what all this brings up in the next 2 years during our next meeting. So enjoy your coffee, have extra sugar in it.
Good afternoon, everybody. Welcome to the last session of the conference. My name is Jennifer Giel. I'm here with Prof. Jackson Oram, who I'm sure you all know by now very well. The topic for this session is actually very important for all of us. It touches on issues that affect all of us, all our patients, our parents, our families. We may think that it doesn't affect us, but then we go to clinic and find one day that it does. So we're going to be treated to a selection of senior colleagues who are going to be giving us some very insightful talks that have been carefully picked. So I'm going to hand over to Dr. Oram for the first introduction.
Thank you very much, Jennifer. Without wasting much time, our session, as Jennifer has just said, is very important. So childhood cancers in special circumstances. And our first presentation is going to be from the WHO country representative, Dr. Jonas Tegen Walder Mariam, who has delegated this role to Dr. Afisa Kachsule, who is the national professional officer in the WHO office here in Kampala. So without wasting time, let me hand over to Dr. Afisa and call her on the podium. You're most welcome.
I would like to convey the apologies of Dr. Jonas Woldemariam, who has not been able to come this afternoon. He's a WHO country representative. And like you've heard, Hafsa Kasule, the National Professional Officer for Non-Communicable Diseases at the WHO country office. So cancer is one of my responsibilities, including childhood cancer. Happy to be here. So the topic that we're given is the WHO's position on childhood cancer care access in special circumstances. Next slide, please. Yes, that is the outline. We shall have an introduction, access to care during disasters, which are some of the special circumstances, and then WHO's position, a conclusion, and some recommendations. Next, please. Kariwan. Sorry, okay. Okay, so as a way of introduction, I want to say that although about 3% of all cases of malignant neoplasms occur in children and adolescents aged 0 to 19 years, it is the most important cause of death in this population and in developed countries, because in the developing world, we still have communicable diseases, which are the leading killers among children. Over 80% of children of childhood cancer occur in low and middle income countries. Okay. So the inequity in childhood cancer survival between low and middle income countries is due to weak health systems leading to lack of awareness, which as a result leads to poor and late access to diagnosis and care, fewer numbers of trained healthcare professionals, lack of cancer drugs, and inadequate quality cancer data for decision making. There is urgent need to close the gap in childhood cancer survival between the developed and developing world. The special circumstances that affect or impact access to healthcare, these pictures show us some of those conditions. It may be a storm, or it may be floods, it may be cyclones, or even tsunamis, and it may be an epidemic or a pandemic like corona. All these interfere with access to services. They disrupt provision of services, infrastructures, if they are like floods and tsunamis and mudslides, these ones may lead to destruction of infrastructure. They may wash away whole hospitals or even communication systems, making it difficult for patients to access services that they need. And so, like I've said, both natural and man-made disasters place an enormous challenge to the organization, preparedness, and resilience of healthcare systems as a result of infrastructure destruction and displacement of human resources, and this includes health workers. For instance, whether it's conflict, armed conflict, like we see or we've seen in some countries, even the health workers may flee for safety and abandon their places of work, leaving patients unattended. And according to the WHO of 2017, it was established that 45% of public hospitals were damaged, with 15% fully damaged and 30% partially damaged in Syria due to armed conflicts. Another survey by WHO found that screening was affected in 46% of the countries, while 13 of the countries reported more than 50% disruptions. All these disruptions affect availability and access to services, including for childhood cancer. Cancer patients in humanitarian situations have poor outcomes because of limited health education. They don't know where to find these services, access to care, and inadequate resources. Even if they knew, sometimes they don't have the means to get to these services. And about 46% of patients with cancer in Syria, for example, completed radiotherapy. Only 46% managed to complete radiotherapy, and 5% chemotherapy. But we know that childhood cancer, most of the cancers require combination therapy. So if you cannot get the complete, or if this child cannot access the complete range of cancer treatment services, then that becomes a big challenge, and it impacts outcomes of treatment. International agencies and volunteer organizations do not usually cover expenses for cancer patients, mainly because they don't have enough resources, or they think that the outcomes of these cases are poor, they have poor prognosis, so they feel that maybe it will be a waste of time to cover them. And also they have competing priorities like providing food or treating infectious diseases like cholera, So they don't usually cover, and even the funders who give them the money don't usually provide money for chronic diseases, leaving these conditions poorly attended to in such situations. There is also lack of data on the burden of these people, on the burden of people with cancer among refugees, for example, or displaced persons, and therefore it makes it difficult to plan for such populations. So what is WHO's position on child cancer care? This one is derived from, I wanted to start with a statement that WHO transformation is anchored in 4 major shifts: to be the impact focused, to be relevant for all countries, and to provide technical and normative leadership, and to get ahead of the curve. If you're ahead of the curve, it means you're doing everything that you must do and more. So that is the aspiration of WHO, and that's what informs what WHO does. And the other one is developing and aligning behind a whole new strategy, which is the strategic plan for WHO 2018-2023. We call it the Global Program of Work 2013, and it has ambitious targets. We call them the triple billion targets, and a new WHO impact framework based on impact and outcome. Impact means reduced mortality, better opportunities for even children with cancer, and this was said by the WHO Director General, Dr. Tedros Ghebreyesus. So what is the vision of WHO? Again, the WHO envisions a world in which all people attain the highest possible standard of health and well-being. And if it means all people, it means even children with cancer among those people that WHO thinks about that should enjoy the highest standard of living, of health and well-being. And this is rooted in the 1948 Constitution of WHO, as shown there. And the vision of WHO, still emphasizing how we are supposed to get that vision, underpins our work to help countries meet the Sustainable Development Goals and our new strategic plan. So the vision of WHO is promote health, keep the world safe, and serve the vulnerable. Keep the world safe from vulnerable situations, from floods, from conflicts, protect them. And the vulnerable, of course, these ones include children with cancer. And it aligns all the work with Sustainable Development Goals, like I've said, and it establishes a clear mission with the 3 strategic priorities attached to ambitious goals. The SDGs, yes, children are also covered in the SDGs, especially Target 3.2, which is about reducing preventable deaths of newborns and children under 5 years. And we know here that the cancers are prevalent in this population. The other target that affects children is to strengthen prevention and treatment of harmful use, of course this one affects those ones that are not born. But Target 3.8, to achieve universal health coverage, access to essential healthcare services and medicines for all, and all means including children with cancer. Target 3B is on access to affordable essential medicines and vaccines for all to protect public health, and for all means, including children with cancer. Okay, so the strategic priorities for WHO include advancing universal health coverage, and this one is about delivery of essential health services without financial protection and access to essential health products. But we know in the low and middle income countries like Uganda, accessing care is usually borne by the family of the patient, which is majorly out-of-pocket expenditures that are unaffordable. We had earlier the cost of drugs for cancer, which are exorbitant. So WHO strives to ensure that the children, the vulnerable children, and other people access services without suffering financial discomfort. The second one is addressing health emergencies, and here we're talking about health. Here we're talking about access to care. We've had there are distractions that affect access to care. So as we prepare, because we know these emergencies, whether they are tsunamis, landslides, floods, we know that where they happen, preparedness. And as we prepare, as countries prepare, there's need to include health products for people with chronic diseases like childhood cancer. We need to prevent infections even during emergencies, and to detect, for instance, in outbreaks, detect these pathogens early and also respond appropriately to reduce their spread to involve other people. We know that children with cancer are immunocompromised by the disease, but this is also worsened by the treatment, so they can easily contract other diseases. So the other strategic priority is addressing health in emergencies. And the other one is about promotion of healthier populations, just like you can see there. So WHO, in addition to doing the strategic plan that has those priorities, also has done tools including investing in our future, which is a comprehensive agenda for health and well-being of children and adolescents. There is also the global initiative that has been shared widely during this conference, and we are aware of what it covers. Yes, and the other one, there's the global platform for access to medicine. We say, yes, access to medicine is a challenge, especially in our setting, and that is what is causing the poor outcomes of less than 30%. So with this platform, when we access it, the platform that was launched by WHO and St. Jude's Children's Hospital, we believe that our outcomes for cancer children will improve to the target of 60 that has been set by the initiative. And there's also the Sendai framework, which provides information for patients with cancer and caregivers and ensuring continuity in emergencies and identifying vulnerable patients. One of the reasons why patients don't get care is because they don't know where to find the information, and even the ones who have the services don't know where to find the patients. So there's a breach in the continuity of care. But according to this framework, these people who need the services are supposed to continue accessing the care that they need, including treatment for cancer. So in conclusion, the burden of childhood cancer is increasing in low and middle income countries, which is a negative impact on human development in health, social, and economic spheres. Cost-effective, high-impact intervention for early detection and treatment of childhood cancers are available. Man-made and natural disasters cause distractions and disruptions of health systems, leading to delays in diagnosis and treatment. And as we are all aware, this means poor outcomes of treatment. And the WHO position on childhood cancer care is premised in our strategic plan, the GPW13, which has the 3 pillars, the triple billions that like we've seen, and is aligned to the strategy, to the SDGs for impact and leaving no one behind. So our recommendation is that there is need for increased investment by government and international cooperation and global partnership for technology transfer and capacity building for improved childhood cancer survival. We also need to adopt and implement the Childhood Cancer Initiative and related tools in order to have improved outcomes for childhood cancer. Thank you very much, UCI. Thank you, the organizers. Thank you, SIOP, for giving us the opportunity to speak to you.
So thank you very much, Afsa, for making a very clear presentation on the position of WHO. We are running behind time, but what we'll do is we'll let all our presenters make their presentation, and at the end, we shall ask them to join us on the podium for brief question time. So for now, let me hand over to Jennifer to introduce our next speaker.
Thank you. Our next speaker is someone who is well known to us in the SIOP Africa community, Francine Kuya. Francine, can you put your hand up? Oh, there you are. Whew, I was panicking. So Francine works in Cameroon, and she's taken something from almost nothing to something really quite admirable that I think many of us can learn from. But it hasn't been easy, and she's had to deal with lots of challenges along the way. So she's ideally qualified to give this talk. Thanks.
Good afternoon. I'm so glad and happy to be here this afternoon to give this presentation and this experience. I have nothing to disclose. So the topic of my presentation is childhood cancer in special circumstances. Okay, So what am I? Okay. So I have nothing to disclose. So this is the outline, background of the Cameroon Baptist Convention Health Service Program, the crisis situation in Cameroon, initial reactions, and the outcome. So I'm going to talk now about the milestone of pediatric oncology in the Cameroon Baptist Convention Health Services. In 2003, before 2003, no service of childhood cancer was available in the northwest region of Cameroon. So basically, all those children were supposed to be referred to the main center in Yaoundé, but it was really difficult to send those children. So those children ended up dying. So in 2003, under the leadership of Professor Hessling, through Stellenbosch University twinning program, we started the program. So what happened? We designed a comprehensive care for the more common and curable cancer. So we have 3 centers, one that was the main center and 3 satellite centers as the number of the patients were increasing. So for those who do not know about Cameroon, Cameroon is a bilingual country. We have the English-speaking region and the French-speaking region. So the English-speaking region is the northwest and the southwest of Cameroon. That is where the crisis is hitting seriously our nation. And the other part of Cameroon is the French-speaking. So basically what was happening, so those from the northwest region and the southwest region, when they were affected to those children with cancer, they were supposed to go to the capital to get their care. So what happened with the program since 2003? About 2,000 children have been treated in this program. One important component of this program was the patient follow-up, because we need to measure. If we treat somebody, we need to measure what has happened. We want to know whether we are successful. So what have we recorded about the survival? 61% for children with Burkitt lymphoma over 1 year, 50% for retinoblastoma over a period of 2 years, and about 50% for nephroblastoma during a period of 2 years. What about the palliative care? We know with our treatment, 50% survivor, and the other 50%, what happened to them? So we needed to establish a palliative care, a mobile palliative care outreach program that was established in 2013. And now the number of the patients were increasing. The burden in the world was really challenging. So a parent's home was inaugurated in 2017. So to reduce abandonment rates, we were supporting the family with transportation and feeding, and also reducing, helping the family to pay the hospital bill. So what has happened? After having this beautiful program, everybody was happy and life was safe. So what happened? Political crisis. Just in 2016, a simple strike in Cameroon ended up with an armed conflict with several armed separatist groups since 2018. What are the consequences of this crisis? More than 1 million of people has been displaced. Frequent lockdown and prolonged lockdown. We will get up in the morning and they say there's lockdown for 3 weeks. Business crumbled, transportation was difficult. So many people flee away from their family or from their villages to relocate. What happened to the education system? Some children for 5 years, they have not been to school. What about the health system? Closure of some health facilities or limited function of those health facilities. And among those health facilities, because we have educated healthcare provider about awareness of early warning signs of cancer, so those health facilities were closed. Increased level of poverty, increased cost of living. I'm not going to talk too much about the COVID-19 outbreak because it was not a serious problem. I'll continue with the effect of the crisis on the program. It was impossible for the patient to travel to the hospital due to increased level of poverty and security on the road and kidnapping, roadblocks and prolonged lockdown, collapsed business, increased late-stage presentation. So parents show up when the pain was unbearable, when the disease was so advanced before the patient were brought to the hospital. Under use of our satellite center in Banso Baptist Hospital, which was the main center where the crisis was really high, difficulties for the staff to conduct follow-up. We said that follow-up was a major component of this program. So we stopped the follow-up because we didn't want to put at risk the life of the staff. Palliative outreach was suspended in rural community in the northwest and the southwest region of Cameroon. Burnout for staff were discouraged. Families were divided because they will have to send their children elsewhere to get their education. Displacement of healthcare professionals that were early trained for warning signs and referral pattern. So what are we going to see now? What the effect on admission? When the crisis started in 2016, 2017, and 2018, it affected the hospital so much, the number of admissions dropped significantly. So here we decided to take the number of the patients from 2014 to 2021. We have 725 children that were admitted in Bingo Baptist Hospital, and the median age of those patients were 8. We are going to see what is the effect on admission. If you look at this line, we have the blue line and the red line. The blue line is before the crisis. We see how the number of patients dropped gradually. And when we look at the right line, it is during the crisis period. During the crisis period, we see the number of patients the number of patients was dropping. And then when intervention were done from 2018, when we started thinking, are we going to abandon this service? What is going to happen to these children? So we sat with the hospital administration to decide which interventions are going to be carried out so that the children can get their treatment. What effect on the stage of the disease? Of course, generally we noticed that the children were coming with worse disease. When we look at these lines, we look at this graph, we see on the green, with the green line, the number of patients that came with stage 3 disease prior to the crisis was, the blue line, prior to the crisis, the green line, prior to the crisis, the number of patients, the majority of patients were coming, there were 73% patients coming at stage 3. But when the crisis hit our nation, the number of patients coming at stage 3 disease reduced considerably, and the majority of the patients came at stage 4 disease. So, looking at those numbers, we thought that there should be an intervention. So the first intervention that were carried out, because one of the satellite centers were underutilized, so a nurse practitioner was sent in Douala in one of our hospitals, and she was under the leadership of an ophthalmologist and a general pediatrician. So what was her role there? First thing, education. The second thing, navigation of the patient. Then in 2019, these are the results. 16 admission that year. 2020, 20 admission. 2021, 22 admission. And what I want to add here, among those admissions, there were 15 retinoblastoma. Why the number of 15 retinoblastoma? Douala has the highest, the biggest clinic, the biggest eye clinic, but they don't have the expertise to give chemotherapy. When they noticed and they were aware that we have the facility and the experience to give chemotherapy, all the children in that town were referred to our unit for the care. That is why the number of retinoblastoma increased significantly there. What other intervention? We created a WhatsApp group. The WhatsApp group was so important because this WhatsApp group we use it for referral, to ask questions. So whenever a center was suspecting a case of malignancy, the child they post the picture of the child, the address of the parents so that we will be able to do some discussion. So the WhatsApp group has helped us also to improve the referral pattern, encourage each other, and also communication and update of the situation. Before we have to refer a patient from one center to another center, we need to know how is the situation, are the roadblock, do we have crossfire? We need to make sure that the situation is calm so that the children should be referred so that the life of the parents and the children is not, is not at risk. Monthly international MDT. At first, the technical support from the lead team was that they have to come to Cameroon twice a year, but it was not possible because of the crisis. So the technical support now was virtual, and this technical support helped us to encourage us to build assurance and confidence that the decision that we were taking on children care were not wrong. Other intervention, the hospital finally acquired a bus, a shuttling bus between the urban center and the hub hospital. This was important because when the patients were in the van, it was like a shelter. So the van was not stopped by the military and was not stopped by the separatists. So those are the interventions that we did. Telephone follow-up was really encouraged where outreach visits were risky. And also psychosocial support for the staff in a moment like this. Parents' home, an important tool. We have the welcome package. At first, before the crisis, the welcome package was just for 2 weeks. But during the crisis, the welcome package now was covering 1 month and sometimes more, because if there's crossfire, if it is too dangerous, the child cannot be discharged from the hospital. So sometimes the welcome package has to cover more than a month. Food demonstrations, so to help the parents cope with that long stay in the hospital, they were organizing food demonstration, gardening, parents group support where parents can share their experience, birthday celebration, and International Childhood Cancer Day celebration. These are intervention that helped the parents to cope with what was happening. And during this time, we have a national collaboration because we know that you cannot treat cancer on isolation. So we have a national collaboration that was harmonized. And during that collaboration, what happened? The first national protocol were written with the standard risk acute lymphoblastic leukemia and retinoblastoma. And today, we as a team are proud to present to you this first child that was enrolled for acute lymphoblastic leukemia. This child was in a hiding with his parents when he started his symptoms, and he was referred to a hospital. So this is a child after, I think, 6 months follow-up after he completed his treatment. Conclusion, despite all the challenges, we were able to sustain the dedicated service. The courage, the sacrifice, the dedication through the hands of the team in Cameroon and our collaborators in Leeds, World Child Cancer, and others that I cannot mention here. We want to appreciate you for helping us, for showing love and encouragement in a time like this. Thank you.
Thank you very much.
I think we move straight to our third presenter, Dr. Eddie Mewesa. I hope you are in the audience. Or he's going to present remotely. Dr. Eddie Mewesa. Hmm?
Did you say you saw him?
No.
You didn't see him?
I didn't see him. Oh, it looks like someone is going to present on his behalf. Okay, so you'll introduce yourself and then go straight to your presentation. Thank you.
Good evening, ladies and gentlemen. My name is Antonia. I would like to register the apologies of Dr. Eddie Mwebesa, who was not able to be present. He is the Clinical and International Programs Director at Hospice Africa, Uganda. And I, representing him, I work as a site manager at one of the sites for Hospice Africa, Uganda, situated in southwestern Uganda. Palliative care is holistic care for persons with severe illnesses with a focus on improving quality of life. And worldwide, we have 40 million people in need of palliative care each year, 78% of whom live in developing countries. And 14% of these people are the only ones who are able to receive palliative care. In 2014, we had the World Health Assembly resolutions, and among them there was improving access to palliative care for all, and also to make palliative care a core component of health systems. What has Uganda done? Uganda has put together a national policy for palliative care. It is yet to be passed, but it has been worked upon. Uganda is a world leader with comprehensive integration of palliative care. We have really participated greatly in providing palliative care, and it is internationally recognized. On top of this, Uganda has also international recognition for response to humanitarian crisis, which is really the core of this presentation. And our special situation is the refugee situation. When we look at the global humanitarian situation, 82.4 million people are forcibly displaced worldwide. And when we look at country-specific statistics, out of 6 people, 1 will be a displaced person. And 86% of the displaced people in the whole world are hosted in developing countries. And Uganda, as I had mentioned in the previous slide, is recognized for receiving and welcoming lots and lots of refugees from different countries. Palliative care is not yet an integral part of the humanitarian and emergency responses because humanitarian planners and health workers are still unfamiliar with this essential role. Therefore, universal health coverage still has a lot of work to be done. And from this slide, we can see that the whole world is in trouble as far as access to palliative care is concerned. When we zero in into Ugandan statistics, from UNHCR, we have statistics from January 2022. Uganda has 1,582,892 persons displaced and hosted in Uganda. 80% of these people are women and children. And their problems, the common problems that these people have include severe illnesses, disabilities. Women are in vulnerable positions in the camps, in the settlements. We call them settlements, not camps, in Uganda. So, for palliative care to be successful in any country or in any setting, there must be a policy. And under this policy, we deal with things like drug availability, education, and that's what makes palliative care implemented. So if you have no policy, it will be very hard to move forward. And what makes the refugee situation so unique? These people have severe vulnerabilities. The rules and policies often are ignored in war and displacement situations. So despite a country with a policy, when it comes to refugees, these things are many times ignored. Food, shelter, water, and sanitation are prioritized above healthcare. Essential medicines are often in short supply, and opioids are really in short supply for refugees. Humanitarian workers are often not knowledgeable, and they are not adequately skilled in palliative care. Then there are the challenges of ethical decision-making and managing emotional, moral, and spiritual distress. And when we talk about COVID-19, it goes without saying, it affected palliative care even more because all the attention went to COVID-19. So in Uganda, some projects have been done to try and help the refugee community. We have work done by Hospice Africa Uganda and work done by the Palliative Care Education and Research Consortium. So for Hospice Africa Uganda in the southwestern region of Uganda, the biggest problem the refugees had was the long distance from the settlements to a health facility where they can get palliative care. So the project was aimed at making access more easy for the patients. And this project was supported by Julia Taft Fund and the United States Embassy. The objectives are, as you see them, we aimed to train people at the grassroots, that is community volunteer workers, spiritual leaders, and traditional healers, and then to train primary health care workers to be able to prescribe opioids. Because palliative care without opioids is not real. Then we wanted to do technical support, infrastructure support for these primary health workers in their health facilities so that there is sustainability. After they are able to do the prescribing, they should be able to be on the government list for health facilities receiving morphine, and that would really be helpful to sustain the care for the refugees. And in this situation in the southwestern region, there are two settlements. One is Nachivale settlement and the other one is Oruchinga. So we really needed in both settlements to have health facilities that are equipped to do the care, in addition to Hospice Africa, which is based in the southwestern region. So the outcomes, we were able to train 25 community workers. We hoped to train 30, but it was not possible. We were able to train 25 community workers, 12 spiritual leaders, and 10 traditional healers. We also were able to train 2 primary health workers, a nurse in Nachivale Health Center, and a midwife in Nachivale Health Center, and a nurse in the other Oruchinga settlement. We were able to support 3 health facilities, and the community volunteer workers, we were able to provide them with bicycles because it's an easy means of transport. You don't need to use fuel, so that they could reach people easily, and those who they identified. And we gave the health facilities motorcycles for the same reason, to help them to reach as many as possible. Despite our efforts, we were only able to succeed with 1 health center, which is Nachivale. We got our nurse trained. We got the health center accredited by Ministry of Health through the support of Palliative Care Association of Uganda to be accredited to get their own morphine. The only challenge is that the midwife has to first be a midwife, and then after duty, look after palliative patients, or whenever she has free time, and that is a challenge. Palliative Care Education and Research Consortium also has done some work in the West Nile region of Uganda. They had 2 projects. There was the Integrate project in Adjumani district and the Transform project, which was in Obongi and Adjumani. When we look at that slide, there are certain things they discovered in their study. Using the APCA-POS form, which is a palliative outcome scale for the children and for the adults, it was found out that there is still a great need for palliative care in those regions of Uganda. These scales, they measure the quality of palliative care provided. And when you see the arrows, they are not near the maximum, so there is still a lot to be done. Also, when we look, the median number of symptoms reported on a scale of 0 to 11, they were 5. The answer was 5, the median, which was also a sign that there is need for palliative care, and only 14% are able to receive palliative care by their interventions. 67% reported pain scores of 4/5 to 5/5 on a scale of 1 to 5. So that is in the line of severe pain. And only 7% of these are able to access morphine. When you look to access to analgesia, you will see that 7.2% are able to access oral morphine, and 22.7% are on analgesia of some sort, NSAIDs or paracetamol. 14% were able to have contact with palliative care professionals, but the green line shows that around 80% got nothing. They didn't see a palliative professional, and they did not get any analgesia. So these are the people in the settlements. Through the Transform project, the baseline data showed the activities they were doing out in the interventions they were doing at the health centers of Adjumani and Obongi. They tried to do some general pain and symptom control. They did some palliative care referrals, and they did some health education. But there is no oral morphine, and there is no spiritual support. And these displaced people really need such kind of care, because what they go through is really difficult.
You have 2 minutes.
So, thank you. The insights that we get from the Transform project, these are quotes from significant key respondents. The district health officer said, "There are so many people in the community with chronic illness, but by the time we discover them, it's too late, so we need to create awareness." The Member of Parliament said, "To integrate palliative care, it needs ownership. This is not a peace hospice project, but an Obongi district government program. Ownership goes with leadership." UNHCR says, "At community level, it is only one person, and this remains a challenge. Plan for the future of palliative care strategically, so that there is no gap in patient care." And a health worker says, "Doing capacity building is very important, training and skilling primary and secondary care, but also include leaders so they know what is being implemented." In summary, let us remember that any one of us can become a refugee and find ourselves in an unfortunate situation because of war or any kind of difficult circumstance. The call to all of us is, let's make collaborative efforts by stakeholders to rapidly improve access. If you are well placed, especially at government level and at the level of big donors like USAID, and I believe the UN also depend on other donors, but if you are well placed, we need voices at that level if we are to have any impact. I just work at the grassroots, and I'm here by chance, because Dr. Eddie was not able to come on his own, but I believe he would echo the same words. Let us stand together. If you're in any position whatsoever of influence, please, let's do something about this. If the host community can suffer with not enough morphine, what do you think is happening in the refugee settlements? Thank you all for listening. Thank you all. I am really grateful.
So thank you very much, Antonia, for making a very, very clear presentation.
Do we have the next talk lined up virtually? Guys? Is that a yes? My eyes are bad. So the next talk is from Professor Nisreen Amayiri, who's a consultant pediatric neuro-oncologist, also has an interest in solid tumors, and she's from the King Hussein Cancer Center in Jordan. So again, she has useful experiences that are relevant to us here in Africa. Please play the video.
Thank you for the kind invitation to join with you today in SIOP Africa 2022. I'm going to share with you the experience from Asia about childhood cancer care in special circumstances. I'm going to first talk about the magnitude of this challenge and then share with you experiences from different 4 regions, Turkey, Lebanon, Jordan, and Gaza Strip, and then go over suggested solutions. According to the UNHCR, there are more than 80 million forcibly displaced people worldwide. 26 million of them are refugees.
About how we might improve access to care for children living in special circumstances. The ideas I present here are my own reflections on the topic. So when I think about children in special circumstances, I cannot but think about the night my mother and I walked 10 kilometers through the bush and swamps to escape from rebels and cattle rustlers who had attacked my village community. I was 12 years old, and that night we trekked in search of peace in the nearby town. And from that night, I became an internally displaced child. So we should cherish peace and security whenever it exists. We should do everything in our means to maintain peace and security so that children anywhere do not find themselves in special circumstances, unless, of course, it is by an act of God, like natural disasters and so on. A child is a person who is below 18 years of age, according to the Convention on the Rights of the Child and the African Charter on the Rights and Welfare of the Child. Although under law applicable to children in some countries, the majority age is attained earlier. These international instruments require member states to ensure appropriate protection and assistance to children of concern, including respecting the rights, freedoms, and duties enshrined in those instruments. National legislation, for example, in Kenya and Uganda, ensure the well-being of children by upholding their rights and protecting them from all forms of abuse, neglect, exploitation, and violence. So children in special circumstances are those who find themselves living as refugees or internally displaced persons. Special circumstances also include children in areas where natural calamities have struck, like in earthquake zones, famine, and drought situations. Now, children in those special circumstances are exposed to several uncertainties. They are also subjected to greater dangers than the average child. For example, they miss out on education, they miss out on proper health care, and they miss out on the stability of the family. They are also exposed to violence, abuse, or exploitation. Now, ethically speaking, children are considered vulnerable groups. They are also dependent and they are developing. Vulnerable because they are susceptible to diseases, to physical injury, and to malnutrition. Dependent because they fully rely on adults for support, for physical survival, for emotional advancement. And developing because they grow in development series, and any interruption on the series could severely derange their development. Therefore, a child's needs should be met within the kinfolk and social structure of the community in which that child lives. A child's well-being is associated with the security and health of the custodian of that child. And this could be the child's mother, the child's father, or a guardian of that child. Now, I would like to briefly discuss three special circumstances. One of them is refugee situation. A refugee is someone who, owing to a justifiable fear of being harmed, flees to another country and is usually unwilling to go back as long as the fearful situation still persists. As of February 2021, statistics show that there were 6 million asylum seekers and refugees in the Horn of Africa, and over 8 million internally displaced persons in the region. And of course, most of these displacements are prolonged, lasting up to 10 years on average, and fueled by a number of situations, including political, socioeconomic, and environmental factors. And inadequate access to healthcare is a major challenge in these refugee settings. The other special circumstance is internally displaced persons. Now, internally displaced persons, or IDPs as we call them, are people who have been forced to flee their homes, but unlike refugees, they have not crossed an international border. These individuals seek safety anywhere they can find within their countries, and they are usually displaced by internal conflicts or natural disasters. But unlike refugees, IDPs may not be protected by international law, or they may not be eligible to receive many types of aid because they are legally under the protection of their own governments. Now, IDPs experience worse health outcomes, including worse mortality rates compared to host communities, and also in some cases compared to refugee populations. The other special circumstance that I want to speak about is famine. Famine is prolonged and severe hunger in a considerable proportion of the population of a region or a country, and usually caused by several factors like natural disasters, extensive poverty, population imbalance, economic catastrophe, and usually resulting in malnutrition and death by starvation. So generally, famines are more common in poorer countries, and it's usually women and children that become more vulnerable to this hunger situation. Now, there are a few ethical challenges in providing care for children in special circumstances that I want to talk about. One is getting healthcare workers to children in special circumstances can be a challenge. Why? One, because the special circumstances are difficult places to work in, and healthcare workers must therefore have additional incentives to be deployed in those special circumstances. And therefore, the challenge then becomes in where to find additional resources to take care of this growing concern. The second challenge, ethical challenge, is that medical workers, especially those coming from other countries, may need permits to work in the different situations and settings. There may be delays in obtaining those working permits. The challenge always is balancing the security interests, the national law requirements on the one hand, and serving the people in need on the other hand. And then number three is when we consider children in refugee settings, for example, they may not be privy to public hospitals because they are not nationals. They may also not have enough resources to pay for, good quality care in private health medical institutions. The challenge, therefore, is to balance the humanitarian need of the child on the one hand with the need to observe the prevailing rules in the host country. It is also an issue of balancing resource allocations to be able to meet the needs, health needs of the citizens of the country, while at the same time providing care to the refugee children. And then in famine situations, another ethical challenge arises in that the healthcare providers may feel morally obliged to provide food in addition to medical care. This constrains the resources available, and many times it is a difficult balancing act. So having said this, what do I recommend? Number one, special circumstances, as much as they are undesirable, should be anticipated. Authorities should therefore always plan for these circumstances and have a mechanism to respond to the need in a timely fashion. Number two, humanitarian assistance for children in special circumstances should be holistic. It is not only the provision of medical services, but also provision of essential needs like water, energy, food, and the others. In this sense, therefore, closer cooperation with other service providers in that particular setting can bring added benefits. And then number three is innovative use of technology can also help. In very difficult to reach areas, unmanned aerial vehicles can be used to deliver diagnostic services or to replenish medicine for those who are already receiving care. And additionally, nutrient-dense foods can also be promoted and supplied in such situations. Therefore, ladies and gentlemen, in conclusion, children are vulnerable groups. And those children in special circumstances are even more vulnerable. Therefore, we should do everything in our means to support them with holistic care. I want to thank you so much for listening to me. And thank you, organizers, once again for inviting me to be part of this great discussion.
Thank you very much, Dr. Julius Churu. Hopefully you are online so that we can invite you together with our other presenters at the end of the session to answer a few questions. And for Dr. Nasrin, the audio was not so good, apologies, but we thought that you could join us online, maybe make some remarks, a summary of the gist of the presentation, so that also you can join the rest of the other team for the discussion. So with that, let me hand over to Jennifer to take the next.
So to the AV team, do we have Prof. Amayeri on the line? Is that a yes or a no? No. Okay. And Dr. Ichuru? No. Okay. So we won't be able to have any discussion with the panelists, but we thought we should just invite comment. When we planned this session, we were all thinking about circumstances in Africa and what we all had to deal with and how we struggled to deal with immigrant children, refugee children, children whose parents had sought asylum. None of us had thought about Ukraine, and I think we all have strong feelings about the world response to those children in crisis. So if anyone has any comments, you are more than welcome to share with us.
Maybe I can start. My own observation is that I think most of these challenges or crises, I think they tend to have common themes and not specifically for childhood cancer, although the impact tend to be more pronounced in groups like children with cancer. And I think they tend to be left out at the end. So I don't know how we can, in a very specific way, get them to be seen, despite the fact that, these crises tend to be like very general. I don't have an answer, but that is really what goes on in my mind.
There's a comment in the corner. Does someone have the microphone?
Hello.
That's Nikki.
Yeah,
Good evening, everyone.
this
I have a question to the WHO representative. In her presentation, she mentioned that most of the international agencies and organizations have or lack interest in supporting humanitarian emergencies. So my question is, what is the World Health Organization's position in improving that trend? And the second question goes to, I think maybe I will shoot this one to Dr. Jackson, much as he was not among the panelists, but I would just like him to give us a brief of what it is for a refugee to access cancer care at UCI. Thank you very much.
Can we have the microphone back up at the front, please?
She would have been better off up here with us.
No, sorry, the question is for the WHO representative.
Thank you very much for that question. Yes, it's true the children or chronic diseases are not covered because, like I said, they are considered expensive and they are deemed to have poor outcomes. So investment in such is not good because the investors think about the return on investment, which is not very favorable. So what does WHO do, or what does it have to do? WHO promotes partnerships. That's why, you see, there's this collaboration with St. Jude. WHO produces data. We heard that if you don't know, if you can't measure it, then you can't work on it, for example, yes. So if we don't have the convincing numbers, then the donors, like I said, return on investment is based on numbers. If you don't have the numbers to calculate that return on investment favorably, then investors will not be interested. So WHO encourages partnerships, encourages advocacy, engages in evidence-based decisions, generates data. So this is where WHO supports, advocates for investment in such conditions. Thank you.
I think there was also a segment of the question that was directed to me. And the question was, how do refugees access cancer care here in Uganda, and specifically at the Uganda Cancer Institute? A very good observation. The answer is that refugees within the country are actually registered and taken care of by refugee agencies or refugee NGOs under the umbrella of the High Commission for Refugees, and of course maybe other UN agencies that look after them. But you'll be very surprised that a good number of them who are seeking care may actually come without registration. So what does the UCI usually do? Number one, for the registered refugees, that means actually they have some package for taking care of their health needs. So we usually demand for whoever is looking after them, if it is the UN agency or it is the NGO, to provide us with the proof that, indeed, this refugee or the family is under their auspices. And once that is provided, then we do give the care, knowing that there is somebody who is going to pick the bill for those type of treatment. So that is number one situation, how we deal with registered and cared for refugees. And then there are those who are actually in the country and they are refugees really, but they are not registered with anybody. That means there's actually nobody taking care of them. Those ones, under the, I would call it the culture as well as the way our government has been dealing with refugees, they are considered just like nationals. So their treatment or their care is usually waived, and they actually access care the same way the rest of Ugandans are accessing. So for that matter, no one is actually left out. But that has also led to a gap, because that means there is a national that is being deprived of care because there is a refugee who is actually being cared for. So we saw that as a challenge, and actually that is what has driven us to put a pillar that is going to be looking at circumstances like the refugee situation in our National Cancer Control Plan. So there is actually going to be a section that is going to be looking at how do we handle the refugee situation. And I think that is going to be the tool that is going to help us to get resources for looking after refugees for cancer in the country. Thank you.
Sorry, we had one question from Nikhil in the corner first.
Thanks, and maybe not a question, but just a comment. To piggyback on the question on the WHO, I think it's important to highlight, I agree with everything that was said, but that the return on investment, the health economics, those are, that children with chronic disease are too expensive, those are assumptions. And those are assumptions, unfortunately, that have been tagged and as a result limit action on this question. And so I think in the last year or two, you've seen substantial work now begin to come out showing that return on investment for children with chronic diseases, especially childhood cancer, actually are in a favorable direction compared to other health interventions. And I say that as someone who does this kind of research and often gets mocked for being boring. It's important, because that's ultimately how you start to convince the ministries of finance and not the ministries of health. And I just wanted to reflect on Jen's question about Ukraine very quickly, and less about Ukraine and more the bigger question, which is, we've seen, Anderson Cooper interviewing about the Ukraine crisis, and we've seen a lot of media attention about specifically the childhood cancer community's response. And on one hand, that absolutely should be celebrated, right? You've seen this incredible response throughout Europe and globally about how to respond and actually get children with these chronic diseases out of war-torn areas to safe facilities all across Europe. And as far as I can tell on the scale that's being done, this is a true first. And frankly, the childhood cancer community has led this. As someone on the inside, I can say that the governments have asked us how we did it for other childhood diseases. And so we should celebrate that. But as I've been having conversations, it's interesting to reflect, because the first and foremost question is, why is this so publicized? This happens all the time in the world, and we don't talk about this enough. And why is it that Ukrainian children are the first ones that we're actually having this discussion with? And we know the answers, right? And maybe it's the elephant in the room, but it's underpinned by racism, it's underpinned by the reality of equity and all of these other concepts. And more importantly, I think to Dr. Orem's point, the success stories that we have in Uganda, in Lebanon with the Syrian refugees, et cetera, don't get told and don't get the media attention back to CNN and BBC. And I think that identifying where the lessons learned and doing a little bit more thoughtful work on the response actually is important. And hopefully that anything from our Ukraine will actually learn a little bit more about this and start taking notes and actually seeing this as an area worthy of true research. Thanks.
Thank you. Catherine, I think your hand was up.
Hi, Kathy Pritchard-Jones, reflecting on this as SIOP president. And Nikhil has partly taken the words out of my mouth. I think, SIOP wants to advocate for proper care for children with cancer all over the world. And throughout last year, actually, we did quite a lot of advocacy work with the WHO, with colleagues in Jordan, in fact, including Nisreen, with colleagues in Turkey, to highlight the specific issues of refugees and displaced people with cancer. And, this is not just confined to the Middle East and Africa, it's also in Latin America and other populations. And then, as we've seen with the war in Russia and Ukraine, this has caused an acute crisis on the borders of Europe. I do agree with Nikhil, there is the elephant in the room that I think with social media, with the press interest, people perhaps put in more effort to help the people that they recognize. They could be in that situation too, and that refugees in Africa and further away parts of the world, perhaps people in Europe and North America feel less connected to them. But what's very, very clear is that the needs are the same, and not only of the children and the families who are displaced, but the countries and the populations who welcome them in. Because it does put enormous strain on countries whose own health services may already be quite limited to accept, very large proportions of refugees and displaced people into their own healthcare systems. But I think fundamentally, as SIOP and as the childhood cancer sort of professional and advocacy community, we should be trying to seek solutions that allow all children to be able to access a best standard of care that enables them to have the best chance of cure. And we should not expect individual countries to be able to mount a sufficient response to answer that, and that we should be trying to advocate, I guess, with the WHO and others, for some kind of refugee relief approach. And I know there is the UNHCR, but I guess we can do the specifics for childhood cancer, because we do know that things have to be mobilized rapidly, because if children are diagnosed late, or if they're on treatment which is then interrupted, you're not going to be able to cure them so easily. So I think we do have solutions of what a care package can look like, but it's going to be working with governments and civil society to understand how we can support delivery. But I think it has to be a coordinated international effort.
Alan, I think you have the privilege of having the last comment. Oh. Okay, so we'll take last two questions from this side.
All right, thank
Comments.
you so much. I'm Dr. Tine Barnabas. I head the pediatric oncology unit in southwestern Uganda. We live, our unit is just about 40 kilometers from one of the biggest settlements in Uganda, and we have a lot of experiences treating refugees, but I just wanted to quickly talk to you about what one little 6-year-old girl taught us. So she had just moved from the Congo in a war, and her father had just died as they were moving, was killed as they were moving. And as soon as they reached the camp or the settlement, she had symptoms, and so they sent her to us, and we diagnosed her with cancer. So she just lost her father. She reaches the settlement, and she comes straight to our unit, and we discover that she has acute lymphoblastic leukemia. And just before she came, we had decided that we're going to intensify the chemotherapy against acute lymphoblastic leukemia, because we had noticed that the protocols we're using were resulting in a lot of deaths due to relapse. And we discussed it among our team as whether this little girl would be able to handle the new intensified chemotherapy, especially given that her social circumstances were actually very, very difficult. At that time, the mother couldn't come to take care of her, so she was being taken care of by some other relative, some other distant relative, who would exchange his role with a sister later. But we've decided that her refugee status should not make her, after a lot of haggling really, should not make her fail to benefit from a protocol that we thought could potentially cure her, much as we knew that it was potentially toxic. Cutting the long story short is that this little girl went through the 8 months of the initial phase of treatment for acute lymphoblastic leukemia successfully, and she taught us that we could be able to intensify the chemotherapy for acute lymphoblastic leukemia, which has resulted into better treatment outcomes for children with leukemia. I just wanted to recognize her and ask you to clap for her. Thank you so much.
Thanks for giving me the last word, Chair, inadvertently. Alan Davidson, SIOP Advocacy Chair. I sort of feel that there's a way to string the beads here, and I'm going to differ slightly from our President on the issue of how we act. What's interesting is that we've moved rapidly from an era of awareness. When I'm speaking about this, I talk about advocacy for children at risk, whether that's refugee populations, internally displaced populations, war, famine, and natural disaster. The fact is, we, for some time now, have been doing awareness. We have these wonderful symposia, we talk about the problem, we kind of think, well, you know, somebody will come and sort it out because we make them aware of the problem. And I think increasingly we recognize that somebody's not going to come and sort it out. The fact is we need action. Now, the next question then becomes this issue of who's responsible. And it's not the same answer all the time. But I can say this, who's best placed to help those kids? Now, our two colleagues from Uganda have spoken in the session right now have shown that actually acting locally is the best. That finding local solutions inside your regulatory frameworks, inside your resource capacity is much more efficient. So I don't think that I don't think it's realistic to consider some sort of task force that sorts out the problem. But what I think we need to do is we need to recognize as a community that we, every time now, as the game has changed rapidly in front of us, we will be called to act, and the goal must be to try and provide international assistance to build local capacity. I think that's the solution, but words are cheap. Let's see what we can do.
Thank you very much. I know we are running late, but really this is a very important topic, and you can see the engagement that we have had over it. We haven't come with a solution. The presenters actually presented us with what the problems are, the interventions, and then some of the results that they have seen. And I hope with the discussion and additional insights that we have had, this should be an ongoing discussion. I want to thank all of you for your patience, and I think I would want to call this meeting to a close. And on behalf of Jennifer and me, goodbye.
Too much of your time as we wind up this day. As we close this ceremony, we thought that, of course, it can't end without having a word from the incoming president of SIOP International. I hope SIOP International. And she has prepared a recorded speech, which I'll ask the videography team to play. And while she's coming, I'll also ask Dr. Joyce Valagadi to get ready. She's the president of SIOP Africa, as well as the chair of the local organizing committee, to say a few words as she says goodbye to us and closes this conference.
Dear friends, dear colleagues from SIOP Africa, it is a big honor for me to send you this message for the closing of your very successful SIOP Africa meeting. I'm really deeply honored for this possibility. I regret not being there today to shake hands, to congratulate you for this enormous success of this very successful meeting, and especially in order to celebrate the great achievements that you are doing in your continent. I think I am really impressed with all the advances that were reported and presented and discussed today and this very meeting. And I'm really enthusiastic to see how much your society is working, how deeply the topics are being discussed, and how many children are now being cured towards our end to cure them all. I really like to say again, thank you for this honor. I look forward to meeting you in Barcelona in October for our SIOP meeting. And you know that here you have a friend, you have a colleague that I will be there in anything you think I can do to help you in your great work you're doing. Thank you very much again, and looking forward to meeting you in Barcelona. Thank you.
I want to thank the incoming SIOP president for those kind words, and I'll ask Dr. Joyce Valagadi to come and give us a few words.
Ladies and gentlemen, friends and colleagues, I'm going to take exactly 3 minutes to give a vote of thanks for everybody who has been involved in the 14th Congress of SIOP Africa in Kampala. It's been a highly, highly successful meeting on many fronts. In the first instance, we have had a total of 386 delegates from 32 different countries, both within Africa and a few abroad. We had a total of 10 workshops, and we had 13 international societies that were represented here and contributed to the multidisciplinary nature of discussions that we had. It has been a wonderful networking experience for us all. So this could not have been accomplished by myself alone. Behind me is a very good team of people that I would feel very bad if they didn't at least, in half a minute, run very quickly so that they can at least be given a hand clap, because they have done a wonderful, wonderful job. So if my team is there, quickly stand up and run very, very fast at those of them that are still here, so that we can together, please run very, very fast. So this is the team of people that have been behind what we have had today, or what we have had since Monday. They have been working tirelessly for more than 8 months, and I want to appreciate them all. So if we can put our hands together once again for a very, very loud. Thank you very much. This is UCI, as well as our sister institutions on the Hill in Kampala, and also our civil society partners. Thank you very much. You can quickly go back so that we can move on. I'm sorry, I don't mean to rush you, but oh, the picture. Okay. Can we quickly please bear with us, have this picture, because nobody's going to come back. So without much further ado, I think I'm going to bow out now. I am cognizant that it's been a very, very, very long week. And so I want to thank you on behalf of Uganda Cancer Institute for coming to Kampala during COVID and making this Congress an overwhelming success that was beyond what we could have ever imagined. Thank you very much.
Thank you, Joyce. At this moment, I'll ask Professor Catherine Pritchard-Jones to come and give us a few words. Catherine is also the current president of SIOP International, and they have supported us heavily in organizing this conference, and we want to thank them, and yeah.
Well, it's been a fantastic week. I've been here since Monday, very late in the evening, and I hope that everyone has really enjoyed both the 3 days of pre-Congress workshops and the 2 action-packed and knowledge-packed days that you've had in the last 48 hours. I just want to add my First of all, my thanks to Joyce and that tremendous team that you just saw on stage for doing such a great job with organising this Congress. Also, the SIOP Africa Board, who, many of whom are members in the room right now, because I know they spend a lot of time planning what this Congress is going to look like, and there's also been a scientific committee associated with it. I'd like to thank Professor Jackson Oram for the support of the Uganda Cancer Institute, all the speakers, and perhaps most particularly the delegates who've come to participate and give this Congress the vibrancy that I've certainly felt whilst being here. I think we've seen, I hope you all will take away something extra from being able to meet face to face with colleagues that perhaps you've only been seeing in Zoom meetings online for the last 2 years, and to have had a bit of chance to reconnect with your peer group, not only in a professional sense, but also social. You know, we've had quite a few talks during this Congress talking about the psychosocial support needs, not only of patients and families, but also the healthcare professionals that look after them. We know that looking after children with a potentially lethal disease, such as cancer, is stressful for healthcare professionals, and not every type of personality will go into pediatric oncology as a career choice. But then with COVID, that's added extra stress. The way you've been able to relate to your patients and families has no doubt changed. And I remember being very struck by listening to a colleague in Italy saying how he was unable to sort of give a cuddle to one of his teenage patients who was in palliative care at a key moment when he had to tell her that her prognosis had taken a turn for the worse. So life has changed for the last 2 years. Let's hope today is the beginning of reconnecting and being able to form new networks, do more research together, more improvement work, and be back in 2 years' time in an unknown location, but somewhere in the continent of Africa, to hear about the great progress you've been making. And thank you all for coming. And I think this augurs very well that SIOP itself will be able to hold an in-person Congress very successfully at the end of September in Barcelona. You heard Guillermo, who'll be taking over from me as president of SIOP at the end of that Congress, telling you a little bit about it. And I think it will also be a great occasion, and I hope accessible to people from this continent. So I can just say thanks for coming, and I hope you all travel safely on your way home.
So before Professor Pritchard Jones leaves the stage, we thought that would be most appropriate that she gives some of the prizes that we have selected today. Moses, if you have the prizes, please bring them to the front. Okay, they're here. So we have a best poster presentation, and the best poster presentation is from R. Kabore from Burkina Faso, who had the poster on combating treatment dropout in pediatric cancer. Yes. Please come to the stage and receive your award, and I hope the photographers are on hand to capture the moment.
Oh, very nice. I'll just maybe hold it in the box. So congratulations. Okay. Congratulations. Thanks very much. Great work.
The best oral presentation was from Nima Moshi, who was looking at association between high-risk histology and clinical features in retinoblastoma in Tanzania. Nima Moshi.
Maybe one of the team?
Is there anybody from Muhimbili who can deliver this to Moshi? Yeah, I think there's somebody from the back who is going to represent her. We also have a category of the most innovative presentation, and this was from C. Eden, from Medcomo 9, integrating a palliative care approach into the healthcare provided by pediatric oncology units. Insights from a 3-year training program. Is this correct?
Well, let me just make sure this, it was, yes, okay, we'll stick with this one.
Merci beaucoup.
We have time for photo.
So Christine is from France, but the work was done in Côte d'Ivoire, so it's for the whole of Côte d'Ivoire.
Yeah, whole of Côte d'Ivoire, absolutely.
Yeah. We have a couple of other words, and we have an award for a friend of SIOP Africa, and I will request Professor Leila Hesesen to come and talk about this award.
May I leave the stage, or you want me to stay? Oh, too late.
No, I think she's just talking about the award.
Yeah, and it's for Elham.
Yes, you're talking about the award for Elham.
Where is Joyce for Ilhan? Not just a mistake, we will arrange it. Okay. Sorry. During those 3 days, I think that I presented so much that I used all my English. And now the most difficult, Catherine. But I can't not to do it, it's Catherine. So what can I say about Catherine? She will be awarded as the SIOP Africa friend. Catherine is more than a SIOP Africa friend for us in GFOP. She is a rock of GFOP. Catherine has been here since 2000. She ensured the sustainability of all the scientific projects of GFOP. The pediatric oncologists in Africa came and they left, they changed, GFOP changed in many ways, but Catherine is still here for us. So Catherine, come here. Catherine is my mentor, my friend. Those were my last words. After this, I will speak only Arabic.
Yes. So I'd also like to invite Glenn Barr to talk about the nursing award.
Thank you. I'm very delighted to introduce my friend and colleague Enyo for this award. But while I introduce Enyo, I would like to introduce while I introduce, While I introduce Enyo, I'd like to invite Sister Rachel Hollis to join me on stage and present this award. Sister Rachel Hollis is from the UK, and she's here to represent a long line of mentors and friends of African pediatric oncology nurses who have been contributing to developing our capacity on the continent. Now, Enyo, a phenomenal friend, and Enyo has almost 20 years of dedication to the care of children with cancer. She's someone who has seen thick and thin of all the challenges that pediatric oncology nurses face in Africa, but she's also someone who has shown resilience and has a track record of finding solutions to this problem. She's currently the matron of pediatric oncology ward at Kolebu Teaching Hospital, and one thing which she did, she contributed to the development of baseline standards for pediatric oncology, the ones from SIOP, and has also represented nursing, has also been a member of the SIOP nursing committee.
Professor Catherine Pritchard-Jones for presiding over this. Thank you very much. You can now have your seat, and I won't call you up again. I would like to invite Professor Jacques to just say a few words. We have a surprise, and Jacques is a master of surprises, so I'll ask him to come and surprise us. Jacques is a good friend of the Uganda Cancer Institute and Pediatric Oncology. He's faculty of Uganda Cancer Institute, actually, and he's been partnering with us in improving human resources for pediatric oncology, and he has worked with us every step of the way, both in this conference, but also in improving pediatric oncology in Uganda. Jacques?
Thank you. I think the biggest surprise is that you've suddenly made me a professor. That I always had is when I was younger was just to get to SIOP International, because then you see all of these wonderful people and the wonderful work that they do and see where we as Africa fit into that, and that we are also worthy of showcasing ourselves. So the surprise today that I have for all of you is that the three recipients of the awards today, the one for the best poster, the one for the most innovative award, and the one for the best presentation, will be sponsored by my institution, the University Hospital of Antwerp, for their registration to SIOP International, hopefully for Barcelona this year. And if I can't make it this year, I'm always happy to let it roll over to the year after that, which I will believe is it back in Ottawa, Kath? Yeah, back in Ottawa. So your registration is covered, so you can start looking for the other funds, but certainly that is done. Okay. I think those three people have my email address. Otherwise, you can get it from Joyce, and you can contact me whenever you're ready to register for the Congress. So that's my surprise for you today.
And we're hoping that when Jacques is promoted to professor, he will help with the looking for the other funds for the other things. At this juncture, allow me to invite Dr. Jackson Orem to give us the final and official closing, to thank you for coming to the Uganda Cancer Institute, and also to wish us well as we go forward. And this is the last bit of the conference. Those who did COVID testing today, the results are outside, but we'll be able to send the emails later, but for the people who are traveling tonight, we have printed them and they're all available. And in case you have any challenges, feel free to call me. Like Jacques has said, Joyce also has my phone number.
Thank you very much, Nixon. Indeed, it has been a very hectic week. It has been full of energy. There has been a lot of exchanges. Knowledge has been flying around. And I think everything up to this moment has been really very, very good. I want to take this opportunity, and this is a very important moment, and I'm wearing many hats. I think three. Number one, on behalf of the government of Uganda, on behalf of the Ministry of Health of Uganda, I want to thank all of you for braving all the scares about the international situation now with the COVID and all other things else, and coming to Uganda in such a big number. This club, if you will, this to our country and to our government, and take it as fact, was the first in-person international conference held in the country. So all eyes were on this conference. And with the success of this conference, I think many more others will take place in this country. So it's so important. So I put on the second hat, which is that of the Uganda Cancer Institute board, the governance of our institute. And as I said, they were all very thrilled and very happy to see that this event unfolded just as it was meant to be, and actually exceeded expectation. So I want to bring appreciation from the board of the Uganda Cancer Institute for your coming. And thirdly, on my own behalf and on behalf of all the cancer fraternities in Uganda, Uganda Cancer Institute, the civil society organization, and name it all, who have actually participated.
Then we'll depart from here. Thank you and have a good evening.